Good morning, everyone. We will start our opening ceremony. Distinguished Pro-Rector, esteemed Vice-Rector, respected presidents of our societies, honored faculty members, dear colleagues, ladies and gentlemen, good morning and welcome to Second Congress of the International Trans-Caspian Hepato Pankreato Biliary Association, held jointly with West East Balkan chapter of EHPBA here in beautiful Taşkent, Uzbekistan. It's a great privilege for us to serve as moderators for this opening ceremony and to welcome colleagues and friends from across Central Asia, Balkans, Europe, and beyond. Before we begin, we would like to express our sincere gratitude to all those whose dedication and vision made this meeting possible. In particular, we would like to acknowledge Professor Mustafa Kerem, whose efforts have been a pivotal role in the establishment and growth of this scientific collaboration, as well as Professor Oktaber Tasheyev, the local organizing committee, all contributing faculty members, and our gracious host in the brotherly nation of Özbekistan.
This Congress represents far more than a scientific meeting. It reflects a shared commitment to advancing HPB surgery through collaboration, friendship, education, and the exchange of knowledge across borders. The Trans-Caspian and Balkan region has historically connected civilizations, cultures, and ideas. Today, it continues that tradition by bringing together surgeons, researchers, and trainees who share a common goal: improving the care of our patients through excellence in science and surgery. We are delighted to see so many distinguished guests gathered here in Taşkent, and thank each of you for contributing to success of this meeting. It's now our honor to invite the Pro-Rector of the Taşkent State Medical University, Mr. Kahraman Hacıoğlu.
Assalomu alaykum, hurmatli bugungi ikkinchi Trans-Caspiy davlatlari Hepato Pankreato Biliary xirurglar assotsiatsiyasi kongressi a'zolari, hurmatli mehmonlar, hurmatli xonimlar va janoblar, sizlarni Toshkent davlat tibbiyot universiteti rektori professor Shuhrat Abdujalilovich Boymurodov, universitetning rahbariyati, universitetning ko'p sonli jamoasi nomidan bugungi ana shu konferensiyani ochilishi bilan muborakbod etmoqchiman. Bugungi kunda universitetimiz 1 yil bo'lgan bo'lsa, tashkil etilganligi, ya'ni yosh universitetlardan biri bo'lsa, bu universitetimizni eng ilk tashkil etilishiga bugungi kunda agar 1920-yildan hisoblaydigan bo'lsak, 100 yildan ortiq tarixga ega. Va aytish kerakki, universitetimizni eng ilg'or, eng oldi va eng bugungi kunni talablariga javob beruvchi, innovatsion, zamonaviy tadqiqotlarni olib boruvchi kafedralardan biri bu xirurgik yo'nalishdagi kafedralar. Xususan bugungi tashkilotchilarimizdan biri hurmatli ustozimiz, professorimiz Oktaber Tasheyevning kafedralari va jamoalari. Hurmatli ishtirokchilar, albatta hozirgi zamonaviy sharoitda tibbiyotni oldida juda ham dolzarb, juda ham keng qamrovli muammolar yuzaga kelmoqda. Va mana shu muammolarni hal qilishda albatta har bir shifokorning o'rni juda ham yuksak va aynan shu yo'nalishda albatta biz barcha imkoniyatlardan foydalanmoqdamiz. Bilimlarimizni chuqurlashtirib, zamonga mos ravishda rivojlanib bormoqdamiz. Lekin kechagina men bir maqolani o'qib qoldim. Ana shunga to'xtalmoqchi edim. Yaqin 10 yillikda sun'iy intellekt tomonidan egallash mumkin bo'lmagan 10 ta kasb degan maqolani o'qib qoldim. Va albatta birinchi navbatda qiziqib, qaysi kasblar ekan, mana shu maqoladan shifokorlikni topa olamanmi yoki yo'qmi deb ochgan vaqtimda, o'qigan vaqtimda birinchi o'rinda fizioterapevt shifokorlari turar ekan. Fizioterapevt shifokorlarning o'rnini hech qachon sun'iy intellekt bosa olmaydi, chunki ulardan kutilayotgan natija bu to'g'ridan to'g'ri bemor inson bilan to'g'ridan to'g'ri bevosita muloqot qilish. Ikkinchi o'rindagi shifokorlik kasbi bu jarrohlar ekan. Ya'ni jarrohlik kasbi hech qachon sun'iy intellekt tomonidan almashinmaydi va jarrohning o'rni har doim o'z mavqeiga va o'zini o'rniga ega bo'ladi. Shuning uchun aytmoqchimanki, har bir jarrohni tajribasi, uzoq yillik tajribasi va har bir jarrohni kelajakda qo'llaydigan usullari, ularni zamonaviyligi, zamon talablariga mos kelishi va albatta aytib o'tish kerakki, to'g'ri, sun'iy intellekt, demak intellektdan biz foydalanamiz, AI dan, texnologiyalardan. Lekin bu faqatgina yordamchi mexanizm bo'lib qoladi. Oxirgi qaror, oxirgi yechim va oxirgi tashxis qo'yish, yakun qilish har doim inson omilida qoladi va bevosita jarrohda qoladi. Har qanday vaziyatda ham jarroh o'z o'rniga ega bo'ladi. Shuning uchun bugungi konferensiya albatta juda ham dolzarb. Bugungi konferensiyada ko'rib chiqiladigan turli mavzular bilan tanishdim. Va albatta aytib o'tishim kerakki, mana shu mavzular qizg'in munozaralarga sabab bo'ladi, savol-javoblar bilan o'tadi. Hurmatli ishtirokchilar, men universitetimiz nomidan bugun ishtirok etayotgan barcha xorijiy mehmonlarimizni universitetimiz nomidan hamda o'zbekistonlik ishtirokchilarimiz nomidan muborakmod etmoqchiman. Shuning uchun sizlardan ularni demak qarsaklar bilan qarshi olib, barcha mehmonlarimizni qutlab qolishimizni so'rayman. Hurmatli ishtirokchilar, xorijiy mehmonlarimiz, o'ylaymanki, bugungi konferensiyaning dolzarb munozaralari, turli mavzular kelajakda hayotda va amaliyotda o'z yechimini topadi, amaliyotda qo'llaniladi va joriy qilinadi. Aynan shu orqali biz o'zaro hamkorligimizning natijasini ko'rib qolamiz. Yana bir bor barcha ishtirokchilarga va eng avvalo tashkilotchilarga minnatdorlik bildiraman. Sog'lik va salomatlik tilayman. Rahmat.
Thank you, Mr. Prorector, for your inspiring words and your support in healthcare and education. And it's now our pleasure to invite Vice Rector of Taşkent, Professor Baymakov Seyfettin, to address the audience.
Assalomu alaykum, hurmatli kongress ishtirokchilari, hurmatli mehmonlar. Barchangizni bizning go'zal diyorimizda va shu bilan birga ikkinchi Hepato Biliary jarrohlar kongressida ochilish marosimida ko'rib turganimdan juda ham xursandman. Hurmatli kongress qatnashchilari, avvalambor bu tibbiyot olamidagi juda ham nufuzli bo'lgan kongressni o'tkazish uchun Toshkent shahri tanlanganligi. Ikkinchidan esa bu kongressni tashkilotchisi sifatida bizning jonajon universitetimiz tanlanganligi bu juda ham biz uchun quvonarlidir. Hurmatli ishtirokchilar, Hepato Biliary xirurgiya, bu xirurg sifatida shuni aytmoqchimanki, bu jarrohlik yo'nalishining eng rivojlanib, shiddat bilan rivojlanayotgan, eng zamonaviy hamda yuqori texnologiyalar talab qiladigan, jarrohdan esa fundamental chuqur bilimlar talab qiladigan tarmog'i hisoblanadi. Shu Hepato Biliary xirurgiyaning eng shu mashta geografiyasini ko'radigan bo'lsak, Turkiya, Ozarbayjon, Qozog'iston va boshqa juda ko'p davlatlardan bugun tashrif buyurgan eng mohir yetakchi Hepato Biliary xirurglarni bizning bu tadbirimizda ko'rib turganimizdan juda ham xursandmiz. Xush kelibsizlar. Endi universitetimiz uchun bu kongressning muhim ahamiyati shundan iboratki, bizning yosh tadqiqotchilarimiz, doktorantlarimiz, izlanuvchilarimiz uchun bugungi va bugun, erta, indin 3 kun davomida bo'ladigan kongressimizda bo'ladigan juda ham zamonaviy, dolzarb bo'lgan ma'ruzalardan demak mazza qilib tinglashlari hamda o'zlarining ilmiy ishlarida yangiliklar qilishda hamda o'sha ilmiy ishlarni olib borishlarida men o'ylaymanki juda ham ahamiyatli bo'ladi deb o'ylayman. Yana bir marta kongress qatnashchilarini hamda bizning qadrli mehmonlarimiz Trans-Caspian davlatlaridan bizga tashrif buyurgan barcha yetakchi Hepato Biliary jarrohlarni, professorlarni yana bir marta qutlab qolgan holda ushbu kongressga kattadan katta muvaffaqiyatlar tilaymiz. 3 kun davomida bo'ladigan munozaralar har bir ishtirokchimiz uchun katta bir foyda olib keladi degan umiddamiz. Hammaga sog'lik, salomatlik va muvaffaqiyatli kongress tilayman. Rahmat.
Thank you, Professor Seyfettin. We now invite Professor Nuru Bayramov, President of the Trans-Caspian HPB Surgery Association, to deliver his remarks.
Çok hürmetli sayın prorektörlerimiz, kongre iştirakçıları, her birinizi ikinci Trans-Caspian Beynəlxalq Kongress'te salamlayıram. Trans-Caspian Hepato Pankreato Biliary Asosiasiyası yeni yaranmış bir dernekti. Çok kısa bir 2 yıl tarihi var. Ama bu 2 yılda çok işler görüp bu derneğimiz hazırda bir neçə ülkəni birleştirmektedir. Bunlar Türkiye, Gürcistan, Kazakistan, Özbekistan, Azerbaycan ve diğer ülkeleri öz arasında birleştiren, özellikle de Hepato Pankreato Biliary cerrahları özünde birleştiren yeni bir kurumumuzdur. Aktif faaliyete başlayıptı ve düşünürük ki gelecekte de bu aktif faaliyetini devam ettirecektir. Bugün bu kongres burada Taşkent'te kardeş Özbekistan Respublikası'nın merkezinde geçirilmektedir. Özbekistan'ı bizler dünya sivilizasiyasına ilmin temellerini koyan büyük mütefekkirleri yetiştirmiş bir ülke kimi bilirik. Bu ülke, bu bölge dünyamıza İbn Sinaları, El-Farabileri, El-Xorazmleri yetiştirmiş bir toplumdu. Bizim için de çok gururlu bir hadisedir, çok sevindirici bir hadisedir ki bizim ikinci kongresimiz bu şehirde, bu ülkede, bu memlekette geçirilir. Tabii ki biz buraya gelene kadar bu geçtiğimiz yolda bize çoklu destekler olup, aynı zamanda bugünkü günde de bu kongresin geçirilmesinde bize birçok kurumlar ve şəxslər dəstək olubdur. Bunların ben adlarını qeyd etməsəm olmaz. Bunlar birinci növbədə TİKA'dır. Türk İş Adamlarının Kooperasiya Dərneğidir. Bunlar bize bu kongresin Özbekistan'da geçirilmesi için bize büyük destekler vermişler. İkinci Türkiye Hepato Pankreato Biliary Cerrahiye Derneği'dir. Ve onun başkanı da burada, Kaya Hoca da burada iştirak ediyor, onun üyeleri de burada iştirak ediyor. Onların desteği olmasaydı biz bu kongresi geçirebilmezdik. Tabii ki aynı zamanda diğer bir kurumumuz Balkan Çapteri de, Balkan Derneği de bugün bizle beraberdiler ve onlar da bize destek olurlar. Aynı zamanda Taşkent Tıp Üniversitesi de bize destek olup, bugün prorektörler de buradadılar, çoklu üniversitetin əməkdaşları da buradadılar. Onlara da ben teşekkür ederim, minnettarlığımı bildirirəm. Aynı zamanda bu kongresin təşkilində 2 şəxsin adını mən mütləq deyməliyəm. Onlardan birincisi, hamınızın, burada oturanların çoxun yaxşı tanıdığı Profesör Doktor Mustafa Kerem'dir. Mustafa Kerem hem bu Trans-Caspian Derneği'nin yaradılmasında, hem faaliyetinde hem de bugünkü kongresin teşkilinde əvəzsiz rolu vardır. Ben ona da teşekkür ediyorum. Aynı zamanda bugün bu kongresin, bu möhtəşəm kongresin, güzel kongresinin Taşkent'te keçirilmesinde böyük emeği olan bizim Oktyabr Hoca'nın, Profesör Oktyabr Teşekkür'ünde böyük emeği var. Ben ona da minnettarlığımı bildirirəm. Umarım ki, düşünürəm ki, ümid edirəm ki, bu kongre, gelecekte de bu kongreler bizim diğer ülkelerde de devam edecektir ve bugünkü kongreden herkes faydalanacaktır. Dikkatinize göre teşekkür ederim.
Thank you, Professor Bayramov. Next, we are honored to invite Professor Mustafa Kerem, past president of the Turkish HPB Surgery Association, whose vision and leadership have contributed greatly to development of this collaboration.
Mr. Rectors and dear colleagues, ladies and gentlemen, welcome to the joint meeting International Trans-Caspian HPB Surgery Association with West East Balkan HPB chapter of EHPBA Congress. It is truly exciting to be here, Taşkent and Uzbekistan. The scientific program for the Congress, comprising more than 50 faculty members from 14 countries, has been prepared with great. I am fully confident the Congress will be a success. I'd like to take you to, again, Rector of Taşkent State Medical University for hosting, and to our Congress President, Dr. Tashayev, for very warm hospitality. I'd like to express my sincere thanks for their support and assistance to Professor Nuru Bayramov, President of International Trans-Caspian HPB Surgery Association, Professor Kaya Sarıbeyoğlu, President of Turkish HPB Surgery Association, Professor Dejan Radenkovic, the President of West East Balkan Chapter, HPB Chapter President, and Professor Ajit Sriverdana and Mark Bezeling, past President of EHPBA. Our heartfelt thanks go to the Turkish Cooperation and Coordination Agency, TİKA, the largest and sole sponsor of the Congress. Without TİKA, we would not have been able to hold this event. They were always for us, they were for us, both on other end of this line and by our side. I particularly like to thank Mr. Ali Fuat Cebeci and Ms. Esin. I'm grateful to our Congress colleagues from Azerbaijan, Bosnia, Bulgaria, Croatia, Germany, Georgia, North Macedonia, Kyrgyzstan, Kazakhstan, Russia, and United Kingdom, Turkey, Serbia, and Uzbekistan. Finally, I'd like to thank Professor Cihan Ağalar, Congress Secretary, and Mr. Recai Tosun, Official Secretary of the Turkish HPB Surgery Association, for their assistance. I hope you also enjoy visiting Taşkent historic and significant sites as well. Yours sincerely.
Thank you, Professor Kerem. We now welcome Professor Dejan Radenkovic, President of the West East Balkan Chapter of EHPBA, to deliver his address.
Ladies and gentlemen, dear colleagues, dear friends, it's great pleasure to welcome you, all of you here in Tashkent, to combined meeting of Trans-Caspian and West East Balkan chapter of European and African Hepato Biliary Pankreatic Association. As a president, of West East Balkan chapter, I would like to express my great sincerity to all of you and to Trans-Caspian chapter and also to Professor Mustafa Kerem for this wonderful organization. I think this meeting will be a nice opportunity for all of us to share experience, to make our countries and region all together and to build a friendship. I think that during this meeting, we will be able to find the pathways in the clinical way and to help our patients for the better treatments within our countries in region. It's my great pleasure to be again here with you and thank you for the warm hospitality.
Okay, we have some technical problems about Professor. It's our great pleasure to invite the chair of this meeting, one of the principal architects of this Congress and the leader of this hospitable team, Professor Oktober Tashev of Taşkent State Medical University, to deliver his opening address.
Assalomu alaykum, hurmatli ustozlar, hurmatli hamkasblar, aziz do'stlar. Tashkiliy qo'mita va Taşkent Davlat tibbiyot universiteti jamoasi nomidan sizlarni bugun ushbu muhtasham koshonada Trans-Caspian Hepato Pankreato Biliary xirurglar assotsiatsiyasining ikkinchi xalqaro kongressida ochilishiga kutib olishdan mamnunman. Biz O'zbekiston poytaxtida turli mamlakatlardan yetakchi mutaxassislar, olimlar, jarrohlar va tibbiyot hamjamiyati vakillarini umumiy maqsad bilan, ya'ni jigar, oshqozon osti bezi, o't yo'llari kasalliklari bilan og'rigan bemorlarni davolashda xirurgik yordamni yaxshilash bilan birlashtirgan holda kutib olishdan faxrlanamiz. Zamonaviy Hepato Pankreato Biliary xirurgiyasi tibbiyotning eng jadal rivojlanayotgan sohalaridan biridir. Yangi texnologiyalar, innovatsion diagnostika va davolash usullari, minimal invaziv jarrohlik usullari, robotlashtirilgan aralashuvlarni ishlab chiqish bizga yana yangi imkoniyatlarni taqdim etadi. Shu bilan birga yangi xalqaro hamkorliklarni, tajriba almashishni, ilmiy tadqiqotlar o'tkazishni, mamlakatlarimizning intellektual salohiyatini birlashtirishni talab etadi. Bugungi kongress nafaqat zamonaviy ilmiy izlanishlar va murakkab klinik holatlarni muhokama qilish uchun platforma, balki professional aloqalarni mustahkamlash, yangi hamkorlik aloqalarini o'rnatish va qo'shma tadqiqot va ta'lim dasturlari uchun istiqbolli yo'nalishlarni aniqlash imkoniyatidir. Global Hepato Pankreato Biliary xirurgik sohasidagi taniqli mutaxassislar va yetakchi olimlar forumimizga alohida ruh bag'ishlaydi. Ularning bilimlari, tajribalari, yutuqlari va samarali munozaralar barchasi kongress ishtirokchilarining kasbiy o'sishlariga hissa qo'shadi deb umid qilamiz. Ushbu tadbirni tashkil etishga hissa qo'shgan barchaga, asosan Professor Mustafa Kerem va Professor Nuri Bayramovlar, shuningdek Toshkentga kelib o'z tajribasi va bilimlari bilan o'rtoqlashish imkoniyatini topgan mehmonlarimizga samimiy minnatdorchilik bildiraman. Barcha ishtirokchilarga qiziqarli va samarali ishlash, konstruktiv munozaralar, yangi ilmiy g'oyalar, muvaffaqiyatli va professional aloqalar va mehmondo'st O'zbekistonda yoqimli dam olishni tilayman. Trans-Caspian Hepato Pankreato Biliary jarrohlik assotsiatsiyasining ikkinchi xalqaro kongressini ochiq deb e'lon qilaman. Xush kelibsiz, aziz hamkasblar. Samarali ishlaringiz uchun va yaxshi dam olishlaringiz uchun va bugungi mana 2 kun davomida bo'ladigan kongressimizda yangi yutuqlar, yangi munozaralar, yangi hamdo'stlik aloqalarini o'rnatishlariga sizlarga tilakdoshman. Sog' salomat bo'linglar.
Thank you, Professor Tashev, for your talk. Now, if we have the connection. Now, I would like to present Professor Srivardhana. It's our pleasure to invite him. The chair, he's a distinguished leader in HPB surgery, and he's very contributing to the field of HPB surgery globally and surgical education. He's past president of EHPBA, and we are happy to have him with us. Professor Srivardhana, can you hear us?
Can hear you. Can you see and hear me?
Yes, we can.
Fabulous. And can you see my slides?
Yes, we can see them.
Just check that they're moving. Yeah.
Can you do it now full screen? Yes.
Yes,
Thank you.
they're moving, yeah.
Yes, you can go ahead. Thank you.
Okay. So, thank you very much for the invitation to be present at the opening of your meeting. I looked through the program and it's a very impressive meeting. So well done for all of you organizing that. I'm just a little bit sad that I can't be there.
We thank Professor Srivardhana for his talk. On behalf of the organizing committee, we thank all speakers, guests, faculty members, sponsors, and participants for being part of this meeting. Now, I would like to invite Professor Nuri Bayramov for presenting plaques to commemorative recipients. Thank you.
Biz söylediğimiz gibi bizim kongresimize, bugünkü kongresimize bir neçə şəxslər çox değer veriblər, katkı veriblər. Sizin izninizle biz onlara təşəkkürlərimizi, təbriklərimizi çatdıraq, plaketlərimizi təqdim edək. Profesör Doktor Dejan Radenkoviç. Bilirsiniz, Balkan HPP Asosiyasyasının sədri. Teşekkür ederim size. Profesör Doktor Oktyaber Teşayev, bugünkü kongrenin prezidenti. Profesör Doktor Kaya Sarıbayoğlu, Türk HPP Derneği'nin başkanı. Tamam, biz alışmışlar. Recai'ye bakarız, orada bakmamız lazım. Ve nihayet hem bu derneğin kurucusu hem de bugünkü kongrenin prezidenti Profesör Doktor Mustafa Kerem. Teşekkür ederim.
We wish all of you a productive, inspiring, and memorable Congress filled with meaningful discussions, new collaborations, and lasting friendships. Welcome to Taşkent and welcome to the second Congress of the International Trans-Caspian HPB Surgery Association. Thank you. Enjoy the meeting. Now we are starting first session of this Congress. Chairs, Professor Dejan Radenković, Professor Ziya Rifat Begovic, and Professor Mustafa Şentürk. Thank you.
Good morning, everybody. It's my great pleasure to chair this session together with my colleague Mustafa Şentürk. So I would like to invite our first speaker. This is Mehmet Fat Khan, neoadjuvant therapy in pancreatic ductal adenocarcinoma. Shifting paradigm involves outcome.
Can we have a Recai? Şey olacak. Şu mu? Bu mu? Okay. Dear presidents, dear colleagues, first of all, I would like to thank Professor Mustafa Kerem and organizing committee for inviting me to speech at this beautiful Congress. Okay. Can I have the, okay, thank you. Neoadjuvant chemotherapy in pancreatic ductal adenocarcinoma is a very, very well-known treatment strategy. As we all know, pancreatic ductal adenocarcinoma is frequently diagnosed at an advanced stage, and only 1 in 5 patients present with resectable disease. And while approximately 50% already have distant metastasis, as we know at the time of diagnosis. The primary rationale for neoadjuvant chemotherapy is to eliminate micrometastatic disease early on and better select optimal candidates for surgical intervention, increase R0 resection rates, and ensure the near optimal delivery of systemic therapy before patients undergo a major like Whipple procedure, high morbidity surgery. Before moving forward, I'd like to briefly harmonize the terminology we use for this systemic approach. Just this is a reminder. Neoadjuvant chemotherapy refers to preoperative systemic treatment followed by surgery, often with planned postoperative adjuvant treatment. Total neoadjuvant therapy involves delivering all planned chemotherapy cycles entirely before surgery, omitting adjuvant treatment. Conversion chemotherapy aimed at shrinking a locally advanced or borderline tumor, specifically to enable a safe and oncologically sound R0 resection. Induction chemotherapy utilized in patients with strictly unresectable disease. And perioperative chemotherapy describes a comprehensive sandwich-style protocol split before and after surgical intervention. Let's review the definitions of resectable, borderline resectable, and locally advanced disease according to the most recent NCCN guideline. The resectable disease means there is no tumor contact, as we see here. There is no tumor contact with named veins or arteries. Again, this is another good example of resectable disease. Here we see a venous contact exists, but without any wall distortion. And this is still classified as resectable because there's no arterial contact here. Borderline resectable implies venous tumor contact of 180 degrees, like we can see here, or less with vessel distortion, but there should be no arterial contact again. Locally advanced disease is defined by concurrent arterial and venous involvement. When managing these patients, our clinical workflow begins with a precise staging workup, as we all know. Checking CA19-9 levels is vital to understanding tumor biology and aggressiveness. We must also rigorously evaluate the patient's performance status to ensure they can tolerate both an intensive chemotherapy and major surgery. In terms of imaging, a high quality, thin slice, and triphasic and preferentially four-phasic pancreas protocol CT is our diagnostic cornerstone. A liver MRI is also frequently required to diagnose, occult metastases. And finally, all suspicious or high-risk cases should undergo PET-CT and staging laparoscopy. And, our approach is straightforward. If we have a resectable disease, we can go upfront surgery. Borderline resectable case goes to neoadjuvant or total neoadjuvant chemotherapy, and locally advanced cases to conversion chemotherapy. For patients receiving neoadjuvant therapy, their response guides our preoperative decision-making, helping us identify who will derive the greatest survival benefit from surgery. With overall clinical status is crucial, a decrease in CA19-9 levels and radiological findings are two primary determinants we rely on in the daily practice. In equivocal or borderline cases, a notable regression in PET-CT can give the surgical team the confidence to proceed with the surgery. But however, the treatment intolerance to treatment remains a major hurdle. Dose reductions or regimen modifications are frequently necessary. Our target is to maintain a relative dose intensity of at least 70% of the intended total chemotherapy, which is the established threshold for efficacy in pancreatic cancer. Okay. So what are our recent neoadjuvant regimens in the routine practice? In Western countries, our frontline standard regimens remain FOLFIRINOX or modified FOLFIRINOX and gemcitabine plus nab-paclitaxel. Gemcitabine plus capecitabine is now considered an old-fashioned combination reserved for patients who cannot tolerate more intense treatment. And this paradigm has remained unchanged for the past decade. So what is shifting the paradigm in neoadjuvant chemotherapy for pancreatic cancer? I want to bring two highly crucial recent developments to your attention. The first one is the PEX-G regimen. This is a four-drug combination consisting of nab-paclitaxel, cisplatin, capecitabine, and gemcitabine. This regimen has taken center stage following the presentation of the Cassandra trial results at ESCO 2025. The Cassandra trial was a phase 3 multi-center randomized control trial evaluating event-free survival as its primary endpoint. In this context, event-free means that following neoadjuvant therapy and surgery, the patient experiences no disease progression or recurrence, no significant spike in CA19-9 levels, no intraoperative discovery of unresectability or occult metastases. And remarkably, the PEX-G regimen significantly improved event-free survival compared to modified FOLFIRINOX. This is, I think there's a problem with the slide here. Sorry. And the 3 years event-free survival was 20% in PEX-G arm versus only 14% with FOLFIRINOX. Disease control rates were also similar. And also, there's a greater drop in CA19-9 in the PEX-G arm compared to only 64% in the FOLFIRINOX arm. Okay. The second major breakthrough is daraxonrasib. Daraxonrasib is a pan-RAS inhibitor, kind of a drug for immunotherapy. It has shown a profound survival benefit in KRAS mutated pancreatic cancer, and FDA has recently approved its clinical use of clinical trials. So as a near future directions, other than daraxonrasib, neoadjuvant chemotherapy is still gaining attraction for upfront resectable disease as well, shifting accelerated by data from Norwegian trial. So in the near future, we are going to send our patients to neoadjuvant chemotherapy in resectable disease if we have also high CA99 levels. NGS-driven immunotherapy is rapidly entering routine practice. And to conclude, looking for our near future directions, PAXG is coming strongly to shift our practice. Daraxonrasib is officially arrived and expanding our target arsenal. Neoadjuvant chemoimmunotherapy is a massive area of focus. Multiple clinical trials are ongoing now, and the combination of durvalumab plus FOLFIRINOX looks highly encouraging for the very near future. Ultimately, PAXG is the new kid on the block. It's a formidable candidate to become our frontline standard before daraxonrasib gains wide acceptance, and it may very well replace FOLFIRINOX as the preferred neoadjuvant regimen for pancreatic cancer before the end of this decade. Thanks for your interest.
Thank you, Dr. Khan, for your very comprehensive and very up-to-date lecture. So is there any questions from the audience? Yeah, Professor Karen.
Very nice talk. Congratulations. You already mentioned that the new agents, especially daraxonrasib, metastatic pancreatic disease, and others will come. What do you think about the routinely molecular profiling and genetic analysis all pancreatic adenocarcinoma patients? Because all chemotherapy we have now not effective to pancreatic adenocarcinoma more. Maybe in future, the new drug may be more effective. What do you think about molecular profiling and genetic analysis?
Okay, thank you. Thank you for the question. Can you please update the slides there? Because we should have some changed in slides. Can you update my slides there? I have changed some slides there, which answers Mustafa's question as well, but we didn't have here. So very good question. You know, NGS or next generation profiling, next generation sequencing is a very important issue in pancreatic cancer. Now, only 12 to 15% of pancreatic cancer cases have the chance to receive immunotherapy by analyzing the next generation sequencing and tumor profile, genetic profile. And as Mustafa stressed, the chemotherapy regimens are both have very high advanced effects, and also we are not very good at treating patients with chemotherapy and recent chemotherapy regimens. But the difference of daraxonrasib, it's a pan-RAS inhibitor, means all patients with KRAS mutant or RAS mutant molecular biology can benefit from this new immunotherapy drug. As we all know, pancreatic cancer patients with pancreatic cancer, maybe 40%, 50% of cases with pancreatic cancer has RAS mutation in their molecular biology. So this means maybe half of all pancreatic cancer patients
may benefit from daraxonrasib with very, small adverse event profile. So in the very near future, I believe this PAX-G regimen and the daraxonrasib, two big breakthrough, will guide our both neoadjuvant and adjuvant treatment approach to pancreatic cancer patients.
Thank you.
By the way, the daraxonrasib has been shown to improve survival up to 3 times. I should have another slide here, a graphic here, up to 3 times survival benefit.
But the FDA not approved still,
But still,
but we can just early access in USA now for our patients, right?
okay, let me explain. FDA now FDA opened the drug, the daraxonrasib, to use out of clinical trials, before, yes, approval. Now in the United States, daraxonrasib can be used out of clinical trial as well. This is very recent development. And I think daraxonrasib will be approved by FDA at the end of this year, like, November, December.
Yeah. Is there any other questions? If no, I would like to extend the talk about daraxonrasib. You have to be fair and to say this study is as a second line in metastatic settings.
Correct.
So I have a problem within my country because a lot of patients are coming and say, okay, this is all in news, social media. It's hype, as I said, for the younger generation, that this is new miracle drug. We have to be fair and to say this is the drug for the metastatic settings as a second line. And in this study, it's double the survival rate from 6 months to 11 months. Ladies and gentlemen, from 6 to 11 months. So we have to wait. It's adjuvant treatment, studies and studies. It's not miracle. And we have to be fair to say that, because otherwise to those hopeless patients with pancreas cancer, they will come to your outpatient clinic and say, okay, I will buy this drug and to survive the pancreas cancer. We have to be fairly, and also to young generation, to tell them what is the truth when we translate the clinical trials into the real practice. What's your comments?
I agree, but we have seen no change in pancreatic cancer patients' chemotherapy protocols over the last decade. So over the last, after 10 years or 15, this is maybe the only treatment protocol that has the potential to encourage us to fight with pancreatic cancer, with this, strongly. So, yeah, we have seen many trials, but this is the daraxonrasib and PAX-G, especially daraxonrasib. Yes, it's the second line now. For now, it's second line. Okay, and after completing other clinical trials as a first line treatment, and also for patients with locally advanced disease, I believe, because please, I want to highlight once again, this is pan-RAS inhibitor. So now we can use immunotherapy only 15% of patients around the world. With this drug, if we see that this is also effective in patients with locally advanced or borderline resectable disease, we will be able to give this to 50% of patients. This is completely different phenomenon, I believe.
I completely agree, but still we don't have the studies.
Of course.
Still we don't have studies, and we cannot offer to
Only
the
one study.
Only one study in metastatic settings, a second line. So we can say we hope in further studies, it will be maybe the bright future. And this was the same story with FOLFIRINOX, I agree. But up to now, we don't have new studies and we cannot promote this drug as a miracle drug. That's my point. Thank you.
Okay.
Thank you for excellent presentation. I would like to invite second speakers, Dragan Basarik, to make his presentation.
Good morning, everyone. I am Dr. Dragan Basaric from Belgrade, Serbia, Clinical for Digestive Surgery, University of Belgrade. I want to express my gratitude for the excellent organization by the Trans-Caspian HBB Surgeons Association, the TICA organization, as well as for the hospitality shown by our friends and colleagues from Uzbekistan. And I hope so that this is just the beginning of our cooperation, and therefore I wish you successful Congress. My lecture is optimal lymphadenectomy during pancreatoduodenectomy, defining the standard. Okay, it is well known that the definition of a standard lymphadenectomy in surgery for pancreatic ductal adenocarcinoma was proposed in 2014 by International Study Group on Pancreatic Surgery, and which based on the classification of lymph node groups proposed by the Japan Pancreas Society. There are three types of lymphadenectomy. We know for standard or regional lymphadenectomy, which involves the removal of regional lymph nodes surrounding the pancreatic head, like peripancreatic, anterior, posterior, pancreaticoduodenal 13 group, 17 group, superior 5, and inferior pyloric 6 group, anterior to the common hepatic artery 8A group, and hepatoduodenal ligament 12 group. Then extended lymphadenectomy extends this section to include distal regional nodes along the hepatic artery. It is 8P group, celiac axis 9 group, proximal distal splenic artery 11 group, and superior mesenteric artery SMA 14 group. Super extended or extension lymphadenectomy include para-aortic nodes 16 group, but some authors classify this type of lymphadenectomy as extended lymphadenectomy. What does it look like? It's like this. We can see pancreatic stamp, skeletonization of major peripancreatic main vascular structures, portal vein, hepatic communis, superior mesenteric artery, left renal vein, and vena cava. But this is a standard lymphadenectomy. I said standard lymphadenectomy because the main question was standard or extended lymphadenectomy. Meta-analysis shows that an extended lymphadenectomy retrieves more lymph nodes and higher risk of post-operation complications like delayed gastric emptying, diarrhea, pancreatic fistulas, hemorrhage, bile leakage, abscess. Also prolongs operative time and higher, and also it has not been shown to improve overall survival and disease-free survival. Guidelines, many guidelines from Europe to Asia recommend retrieving at least 15 regional lymph nodes to ensure accurate pathologic staging, which is achieved through the meticulous skeletonization of major peripancreatic vessels like portal vein, SMV, splenic vein, vena cava. But how to achieve this goal? Problems in pancreatic cancer surgery were like the most frequent involved positive resection margin around SMA, positive in 15 to 45% of resected specimens, and it was implicated in 46 to 88% of R1 resection. So central aim of pancreatic cancer surgery is tumor-free margins or R0 resection. R0 status remains an important independent determinant of postoperative overall. But how important is the resection line? How to get a clean resection lines? We have in history of pancreatic surgery, there are two key considerations. First, mesopancreas, the first concept of mesopancreas and the surgical approach to exercise, it were first introduced by Dr. Stefan Gockel, 2007, but 5 years later, it was the first clinical application by Professor Mustafa Dam and his team with a total mesopancreas excision, which means removal of a monoblock, the right semicircumferential plexus of CT and SMA along the triangular tissue flap, extending from the anterior surface of the aorta between the origin of CT and SMA upward until complete clearance of the posterior surface of the SMV and portal vein. Look at here, results of total mesopancreatic excision shows R0 resection about 42 patients or 18%. It was an introduction for the artery-first approach integration by Professor Inoue, I think 2015 years, proposed early in the operation before completing the rest of the operation, ensuring of a clear posterior margin. The second key of surgical consideration is triangle operation or triangular resection or Heidelberg triangle resection. Professor Thilo Hackert and his team did it 2017. Is an extended surgical approach performed during pancreatoduodenectomy to achieve R0 resection. It targets special anatomic space between major peripancreatic structures, like on the upper side, the celiac axis, and common hepatic artery, superior mesenteric artery on the left side, and superior mesenteric vein and portal vein axis on the right side. And these are borders of Heidelberg triangle. It is special place with potential tumor infiltrated surrounding tissues or abutted of a tumor of head of pancreas. This is compared to standard pancreatic resection, where we can see number of lymph nodes are higher. Number of lymph nodes are higher. Intraoperative blood loss higher also. ICU stay longer, but the overall and postoperative complications do not differ significantly. It is focuses on the microscopic tumor spread and tumor recurrence by removing all soft tissue, lymphatics, and nerves and fatty tissues. It is not extending lymphadenectomy. It is a standard lymphadenectomy, but extends to Heidelberg triangle between major peripancreatic vascular structures with lymph nodes in group 8P and also 14, but not 9 group, not 11 group, not 16 group. Now you can see a very short video. It works. No. I don't know why it's short video, but it is very interesting video. You can see the space with portal vein, superior mesenteric vein, superior artery, left renal vein, also celiac trunk, lineal artery. There's no connective fatty tissue. There's no lymph nodes. There's no nerves. Also, it is interesting during total pancreatectomy. Please. It's working now. Okay. Okay. You can also see main vascular factors and this holy space. It is triangle, Heidelberg triangle. Okay. We have more 2 slides, 2 or 3. And it is one study protocol is currently underway between intervention triangle operation and control group is standard PD or a conventional partial pancreatoduodenectomy versus an extended pancreatoduodenectomy. We were waiting results with this compared study. Any conclusion? The central aim of pancreatic cancer surgery is tumor-free margins and R0 status. Optimal approach for lymphadenectomy during pancreatoduodenectomy or Whipple procedure is a standard regional lymphadenectomy. Guidelines recommend retrieving at least 15 regional lymph nodes. Total mesopancreas excision and triangle operation are essential for the success of pancreatoduodenectomy. It is feasible and safe technique to resect patients with pancreatic duct adenocarcinoma, particularly, but not exclusively those with borderline pancreatic cancer or local advanced pancreatic cancer after neoadjuvant therapy, sparing the major arteries without compromising the radicality. Although it seems to improve the local control, the actual impact on the long-term prognosis remains to be established by future research. World scientist from our region, Nikola Tesla, said, "A man is born to work, to suffer, and to fight. He who doesn't must perish." Therefore, we must continue our fights in order to succeed against an enemy like pancreatic cancer in our surgery. Thank you very much.
Thank you for excellent presentation and update presentation. Is there any question?
Thank you for your contribution. Do you have any experience for prolonged chyle discharge after this extended lymph node dissection?
Can you repeat? Sorry.
The chyle, lymph discharge to the extended, prolonged. Following
lymphatic leakage. It is possible. We don't have any case in our patients. We have some pancreatic fistula also, and I think just a little hemorrhage, but not lymphatic leakage.
Drainage. Okay.
We don't have.
Okay. In your protocol, do you check drain amylase?
Yes, of
triglyceride?
course. Yes, of course.
Okay. And how about the triglyceride levels? If it is more than 150 milligram per deciliter, it means that the chyle discharge. Have you ever got an experience about that?
Higher, not higher. We have pancreatic fistulas with high level, but we only wait, and I think that was maybe 2, 3, 4 weeks, but we wait.
I'm asking these questions because according to my experience, since I've started to do triangle operation after the first defined, I've got more chyle discharge to the drains, and it is sometimes a huge problem. And I'm sending patients with drain and taking it out on the first control, and that's why I'm asking. Thank you for your answer.
Thank you. Maybe we have lucky. I don't know.
Yeah, I guess so. Thank you.
Thank you.
Maybe I'm not so lucky.
Very nice presentation. Thank you. I'm wondering too, when you see aortocaval lymph nodes, looks like metastatic during the pancreatic duodenectomy, what is your approach? You continue to the surgery and aortocaval dissection and pancreatic duodenectomy, or you stop and needed to chemotherapy?
If we have suspicious malignant.
Yeah, suspicious, there is a very big lymph nodes located to aortocaval regions. No, during operation.
Into operation.
Yeah.
We can make biopsy, and we wait biopsy. It is malignant. It is only a few lymph nodes in this region we can remove. But if it's more lymph nodes, we can stop.
Yeah, Mustafa, the guideline says if this lymph node is positive, it's considered as a distant metastasis and you have to stop. But everywhere in the world, any pancreas surgeon who see this, that it's operable cancer and you have just to remove aortocaval, you will do it. Be honest, I think that I don't know any surgeon in the world except America. US is specific, they are taking care about everything. But in other parts of the world, everybody, even though it's positive interaortocaval, we will continue with Whipple. It's different between guidelines and surgical attitude. I don't say that it's right, but I think in clinical practice, everybody are doing the same.
I agree. Yeah.
Yeah.
So we have a preoperative oncological consilium, our team, and then we decide.
I think we should already have seen those large lymph nodes before surgery. Big lymph nodes on CT scan. So, we stop there and just directly send patient to neoadjuvant.
But that's the difference between reality and guidelines. This is one of the key questions. If you see, but everything other is operable. We are talking about the surgical reality. We're not talking about the guidelines. According to guidelines, you are completely right.
Sorry, I don't agree. If I have 3 centimeter large lymph nodes, for example, in the aortocaval window, and I see that on the CAT scan before surgery, but the primary tumor is still resectable, still, I want to send patient to neoadjuvant chemotherapy.
And how do you know that it's malignant before biopsy?
Because we have some criteria, radiological criteria as well, for suspicious malignancy.
Congratulations, you're so strict. You have to be trained in US. It looks like.
Because I'm half Norwegian.
We can learn everything.
Yeah. Okay. Thank you. We are continuing now.
Thank you very much.
It's Emre Bozurt from Turkey, vein first or artery, never strategic vascular decision in pancreas surgery. Emre, the floor is yours.
Dear Chair, thank you for introduction. Before I start my presentation, I would like to thank Congress Organizing Committee to invite me to give talk at this Congress, and I'm happy to be at this beautiful city. The topic of my talk is vein first or artery never, the strategic vascular disease and pancreatic surgery. Actually, this is not a question with one correct answer. It's a question that asks for the best answer among several acceptable options. When we look at the artery first concept, the definitions actually expose and assess the arterial axis, the SMA, before the point of no return, and it answers the question of if this disease is resectable and can we clear the SMA margin. And when we look at the vein first concept, the definition is it's the define and control the superior mesenteric vein and portal vein axis early with the help of the classic resectability tunnel, and it answers the question of if the venous confluence is reconstructible and how do we plan it before the surgery proceed to the no return period. And why the order of vascular control matters? Because the reasons are the oncological clearance and the operative safety. And all we know that the SMA and retroperitoneal margin is the dominant site of R1 disease. And the sequence determines whether you can clear it under direct vision. And operative safety is also an important issue, and early inflow control reduces venous congestion and also blood loss during mobilization, and avoids committing past the point of no return again. And we all know as a pancreatic surgeon that arterial axis is the superior mesenteric artery, the origin, the first jejunal and inferior pancreaticoduodenal branches, and also the coeliac axis, common and proper hepatic artery, gastroduodenal artery. And also the important issue is to know before, from the preoperative radiologic images, the accessory or replaced hepatic artery, as we know that it exists in the 15 to 20% of the population. And to find it early in the operation can be protective to harm liver also. And why we do artery first? Because of the mesopancreatic and superior mesenteric artery margin is anatomically ill-defined, and the common site of R1 is the reason for the artery first, actually. And when you look at the arterial axis, the hepatic artery, the gastroduodenal artery, the proper hepatic artery, in the second image, you can see the accessory right hepatic artery, the portal vein, left hepatic artery and right hepatic artery, and also the common hepatic duct. We can clearly be sure of these anatomical structures, whether the surgery is open or minimally invasive. And after the resection, you can see that the SMA origin, the accessory right hepatic artery are clearly demonstrated. And artery first concept, we know that confirms the anatomy before point of no return, and also it's linked with the early inflow control and less blood loss. And with artery first concept, we clear the retropancreatic and mesopancreatic plan under direct vision. And also we can detect and pro-vascular control early, and this is important for the protection of the aberrant anatomy. There are 6 described routes of the routes to the SMA. posterior approach, medial uncinate approach, inferior infracolic approach, left posterior approach, inferior supracolic approach, and the superior approach. If the tumor is posteromedial head tumors, we can use posterior approach. And if there is a bulky head and uncinate tumors, we can use medial uncinate approach. Or for the many of the pancreatic tumors, we can use inferior infracolic approach, which is more easier than the others. And these approaches are also important for the minimal invasive surgery. These were defined especially for open pancreatic duodenectomy and are being remapped for robotic pancreatic duodenectomy also. And when we look at the vein first concept, early definition and control of the superior mesenteric vein and portal vein axis, the name is the classic tunnel under the neck resectability test, and early venous control when a venous resection is planned. And when it makes sense, the vein first concept, venous dominant abandonment, if there is a borderline disease by vein related problem, or also if we plan a segmental venous resection and reconstruction, we can choose vein first concept. And also if we do vein first concept, it minimizes manipulation when venous wall is involved, and it will prevent the bleedings from the venous branches. And also when the confluence anatomy is the limiting point, we can choose vein first approach. But the limitations of the vein first approach is it does not address the SMA and mesopancreatic margin. And also a clear tunnel under the neck can give false reassurance because risk of arterial involvement is discovered late. And this clear tunnel does not reassure if there is no arterial involvement. And also the inflow not controlled early with the vein first concept, and there will be more congestion during mobilization. And when we look at the literature about artery first and vein first concept, this is a meta-analysis published in British Journal of Surgery in 2018. And the authors showed within that meta-analysis that with the artery first approach, they reported that there is less need for transfusion and less blood loss, and also the morbidity is less, mortality is same with artery first and the standard pancreatic duodenectomy, and grade BC pancreatic fistula is less with the artery first approach. And also the R0 resection rate was higher in the artery first approach, and overall survival is better with the artery first approach. But the R0 and survival advantages of these meta-analyses mostly come from the retrospective and case control data. So what happened when this was put to a randomized trial? And this is a randomized trial conducted 1 year later and published in Annals of Surgery in 2019. And they randomized 179 patients, 75 with standard pancreatic duodenectomy and 78 with the artery first approach pancreatic duodenectomy. And with this randomized multi-center control trial, they has found no difference neither in R0 resection rates nor in postoperative complications in patients undergoing standard pancreatic duodenectomy versus artery first approach for pancreatic head carcinoma or other periampullary tumors. And after this study, this is a new study published this year in Anti-Cancer Research, meta-analysis. This is also a meta-analysis and includes 2 randomized controlled trials and 20 retrospective study that also compares the artery first approach with standard pancreatic duodenectomy. And with this meta-analysis, they report that artery first approach is associated with higher R0 resection rate and lower blood draws compared to standard pancreatic duodenectomy without added morbidity. And observational data strongly support artery first approach, But again, with this meta-analysis, they conclude that confirmatory evidence from well-powered randomized trials remains essential. And as I said in the first slide, that the vessel that determines resectability is the vessel you address first. This sentence determines whether you prefer artery first or vein first approach actually. If the SMA or celiac abandonment on CT detected, or there is a posteromedial uncinate tumor, or there is replaced right hepatic artery in the field, or for the post-neoadjuvant treatment patients, you need to test the plane, you can choose artery first approach. For the vein first approach, if the superior-mesenteric vein portal vein axis is the limiting structure, or if there is planned venous resection and reconstruction, and if you can clearly say that there is no artery involvement from the preoperative radiological images, you can choose vein first approach. And I think the image-led plan is more logic, like always knowing before if there is an vascular involvement or lymphatic dissemination of disease. And with this knowledge, you can choose whether artery or vein first is more logic than doing one technique only. And also, after these all images like high quality vascular CT or MRI, you can also use intraoperative ultrasound just before starting the dissection. And you can clearly see the tumoral relation with vascular structures under the intraoperative ultrasound guidance. And when we look at the special scenarios like triangle or total mesopancreatic excision, if the arterial control is mandatory and not optional, and if we plan the radical clearance of the SMA, celiac, portal vein triangle after neoadjuvant treatment, we should do triangle total mesopancreatic excision. For periarterial, periadventitial arterial divestment, it's an alternative to arterial resection when demanding early superior mesenteric artery exposure. And also when we look at the venous resection and reconstruction, it's a setting where vein first control earns its place. If we do a venous resection and reconstruction, we should first secure the vein and control it from upper and lower parts of the resection site. And also for the body and tail tumors, for ramps or distal pancreatectomy celiac axis resection, arterial planning is the whole operation. It's not an option. When we look at the important points during vascular first, to prevent injury during medial insunate dissection, always map a replaced right hepatic artery on preoperative CT. And traction injury on first jejunal branch of SMA can cause a classic sudden bleed in the initial phase of the surgery. And over or underestimating venous involvement based on imaging alone is an important issue. And we don't forget that a clear tunnel just posterior to the neck of the pancreas gives a false sense of security because it evaluates only vein, not the SMA origin. And after neoadjuvant treatment, full circumferential SMA skeletization may cause severe intractable diarrhea. So preserve the periarterial plexus if oncologically feasible. And this is my last slide as a take-home messages. We don't forget that artery first or vein first is just a strategy, and use the imaging findings to determine the order if artery first or vein first. We can use high-quality vascular CT MRI to decide which vessel is the rate limiting question and therefore which comes first. And if you unsure about the SMA margin, gaining arterial control first can be very helpful. Thank you.
Is there any questions from the floor? If not, yeah.
Good morning, everybody. But first, I would like to say great thanks, Professor, for an interesting presentation.
Thank you.
Pancreatic resection is very important. I have, at present time, frankly speaking, I am getting enjoy from the speakers, getting new information. Yes, instead of your presentation, according to your presentation, I would like to ask you one question. There is a surgeon in the practical medicine, they're using practice. Your recommendation first when arterial venosus, it's depend on the outcome results pancreatic duodenectomy. I mean long-term or short-term outcomes. Thank you.
Before my presentation, actually, we already discussed this topic with Professor Can also for the vein resection or for the artery resection. In that oncological era, actually, with those new chemotherapeutic agents, I think that the arterial resection lose its popularity. It's not preferred like in the previous stages. We do vein resections, yes, but we are not doing arterial resections much more like the earlier periods.
Is there any other questions? Emre, thank you. I have questions just. I think that you pointed in your conclusion that with so powerful CT scans now, the artery first approach as an exploratory phase, as in matter to see whether it's resectable or not, it's losing their role. But the role is after neoadjuvant treatment, when we need to see what to do with the move around the superior mesenteric artery. And also, what do you think about the uncinate first? Because nowadays, when we have everything on CT, maybe just weak point of multiphase CT is that spreading of the tumor to the mesocolon.
Actually, it's also one kind of the artery first approach. It's also the same route to reach to SMA, the uncinate first approach. You can also reach there from. So it's just an alternative to artery first approach just.
Okay, thank you. Is there any questions? Then thank you very much for your talk.
Thank you.
For the final presentation, I would like to invite Stolovic.
Yeah. Good morning, everyone. I'm coming from University Clinical Center Niš in Serbia. And it's my great pleasure to address to everyone to give a lecture on joint meeting on West Balkan and Trans-Caspian chapter of the IHPBA. It's a great experience for everyone of us and opportunity to visit your beautiful country. My topic today is a place of total pancreatectomy in high-risk pancreas fistula prevention. Postoperative pancreatic fistula remains the Achilles heel of pancreatoduodenectomy, and the incidence of clinically relevant pancreatic fistula in unselected population ranges between 6 to 23, according to International Study Group of Pancreatic Surgery, ISGPS. In the patients with a high-risk pancreas, fistula rates escalate drastically, carrying severe morbidity and high risk of mortality. There are numerous etiological factors. We can talk about experience, total and annual volume of an institution, or surgeon, or patients factors, organ factors, and pathology in the setting of pancreatic ductal cancer or non-ductal cancer pathology. On this slide here, we can see complex pathophysiology with many factors and processes going all together in the same time and leading to the pancreas fistula. According to that complex pathophysiology, there are too many predictive scores about postoperative pancreatic fistula from 2010. And after that, we have on this slide maybe 7 pancreatic scores. And we can see many of them address to the texture of the pancreas and diameter of main pancreatic duct. Also, intraoperative blood loss, body mass index, and some others factors less important. The age of 2023, this group, ISGPS, proposed a simple classification of pancreatic duct size and texture, what predicts postoperative fistula with 4 grades, A to D, and the main factors are gland texture, narrow pancreas, and non-ductal pathology. We have a probability of fistula from 3.5 in group A, and in group D, so-called high-risk pancreas, we can expect postoperative fistula in 1/4, about 23%. Pancreas texture means firmness or hardness of the pancreas. Hard texture is the product of pancreas juice retention and so-called obstructive pancreatitis in pathology like PDAC, in pathology like chronic pancreatitis, and we can find it in heavy smokers. We can measure texture of the pancreas preoperatively by ultrasound elastography, by measure density on MRI, and by measure intensity on MRI and density of the pancreas. Intraoperatively, we can use the digital palpation, and in last 2 years, we are using one hard method, Japanese digital little device. It's not so expensive. It's about 2,000 euro, and we are using in scientific reasons to do one PhD. It's not common in surgical practice. We can ask one question. Is there any regional difference in pancreas hardness and texture? Every pancreas I saw in France during 7 months, every pancreas I saw in United States was harder than in Serbia. Is there any explanation? Maybe for France, a little bit more cirrhosis, more good wines, etc. I think preoperative biliary drainage without pancreatic drainage is one of the most important factors. In our country, we don't use preoperative biliary drainage in every case, but in the case of cholangitis and in the case of bilirubin over 300. Maybe that's one of the reasons. Smoking also could be one positive factor for that. Measuring on this slide, we can see the opposite sides of the main pancreas duct diameter. On the upper side, we have one duct about 22 millimeters, and we made one continuous one-layer anastomosis without problems. But in the other side, you can see 1 millimeter duct. What to do with this one? Pancreas fistula. It will be a topic of the Professor Radenkovic lecture after that. Prevention of the fistula, according to the institution and surgeon, is centralization, education, selection of the patients, and procedure for mitigation. Now, we can talk about surgical technique, about pharmacological agents, but we have no scientific approval for any of that. Pancreatogastric anastomosis, invagination anastomosis versus ductal mucosis, Blumgert, Peng, etc. On this slide, we can see some meta-analysis about pancreatogastric anastomosis. No differences, pancreatogastric. We tried everything, internal drainage, external drainage, fibrin glue, reinforcement, etc., etc. But one concept, not pancreas, not fistula, is very, very interesting. And by completely eliminating this anastomosis, the primary source of postoperative morbidity is removed. Historically, avoided due to high perioperative mortality and management of prohibitive brittle diabetes. But in the modern context, outcomes have significantly improved due to modern intensive care, insulin analogs, and continuous glucose monitoring with insulin sensors and pumps. First performed by Rocky and James Taggart Priestley during the Second World War. And after the era of enthusiasm, era of skepticism, now we have one re-emergence of total pancreatectomy. In these days, indications for total pancreatectomy, there are multicentric tumors, IPMN, main duct type, chronic pancreatitis, familial cancer, and our topic, pancreas fistula prevention or managing of pancreas fistula, like salvage after pancreatic angiostomy breakdown. Clinical dilemma. It's about one short-term gain and the end game also between balancing between short-term gain and long-term loss. Loss is in terms of lost endocrine insufficiency. Brittle diabetes, this is so-called pre-C diabetes. It's characterized by extreme, unpredictable fluctuations in blood sugar and need a low dose of insulin. It's not over 30 units per day, but titration must be very, very careful because of the possibility of hypoglycemia during the absence of glucagon alpha cells product. Exocrine change, they are in the era of replacement pancreatic enzyme therapy, and small problem. It's a malabsorption, need for long life, replacement therapy, nutritional deficiency, weight loss, hepatic risk about fatty liver, and problem with the bones also. There is no many comparative studies and high valuable facing with this problem. We have one systematic review and meta-analysis of Stoop and co-authors 3 years ago, comparing outcomes of prophylactic total pancreatectomy versus standard DPC. On PrismaFlow, the authors found only 6 highly quality studies about that. They found that mortality was comparable, that total pancreatectomy eliminates clinically and biochemically also postoperative pancreatic fistula, but overall morbidity rate is the same. On the other side, quality of life was stable, probably because of the modern detection of leukemia with sensors and insulin pump. The newest one is the Dutch nationwide analysis of 1,400 patients with very high risk grade D pancreas. In hospital mortality was the same, about 6% in the group of total pancreatectomy and group of DPC classic. In conclusion of this study, they said, despite the high incidence of fistulas, routine prophylactic pancreatectomy has a very limited therapeutic window. Our experience is 42 years dealing with pancreatic resection and surgery. We are doing about 7% of whole pancreas resection was total pancreatectomy, and just 3.1 was prophylactic. It's 18 prophylactic total pancreatectomy. It's not so much, but in the last 5 years, this number has increased. Clinical relevant fistula occurred on 35 of patients after DPC with high risk pancreas. No fistula, of course, in total pancreatectomy. And 90 days mortality was about 9 days in both groups. The second modality is salvage total pancreatectomy in the case of total disruption of the anastomosis. This is one of the last steps in the treatment. It's a bailout option, maybe, in the treatment of pancreatic jejunal anastomosis with high mortality, 66 at our material. Maybe we can do near total pancreatectomy with no anastomosis. We can discuss about that. And in conclusions, we can say that systematic reviews and meta-analysis did not find a reduction in short-term mortality and major morbidity after total pancreatectomy. Our results suggest the slight total benefit in short-term mortality and value of prophylactic total pancreatectomy should be observed in light of the inevitable total endocrine and exocrine insufficiency. Total pancreatectomy as a bailout option could be based on the selective decision-making in indication like high-risk pancreas with technical no possibility to retain sutures during the attempt of pancreatic jejunal anastomosis, in the patients with comorbidities, and it's very important in the patients with diabetes. We can liberally going to total pancreatectomy and also after arterial reconstruction. In these cases, surgeons should not be overly reluctant to perform total pancreatectomy given the reassuring comparable long-term quality of life after total pancreatectomy. Thank you.
Thank you for your presentation. Is there any question?
Thank you very much. I'm Ivo Takor from Sofia. Congratulations for the nice presentation. I would like to ask you, have you considered total pancreatectomy in the setting of severe nosocomial infection after biliary duct stenting, such as peritoneal phlegmon and right renal fascia, or collections in the lesser sac? Thank you.
We have not experience with the chance like that. In theory, it might be indication, but we have no experience in our institution.
Can we give the microphone, Professor Nuri?
Yeah, just a brief question. Thank you. Danko Mikulic from Croatia. How would you compare the strategy of doing an upfront total pancreatectomy in a high-risk fistula patient versus maybe doing an anastomosis first and then having a very low threshold for doing a completion pancreatectomy in case of doing it early in case of any early complications like a high-grade fistula or post-operative pancreatitis or sepsis or anything, going in very early for the completion pancreatectomy? Thank you.
Yes, but we are, I personally, I'm liberal about total pancreatectomy like preventive method. And our experience with salvage total pancreatectomy after total dehiscence, necrotizing pancreatitis is not so good, maybe because we are doing late in the phase of multi-organ dysfunctions, sepsis, etc.
Dan, can I ask one question, please? It will be a short question. Thank you for your very nice presentation. Do you have any experience with pancreatogastric anastomosis in high-risk patients? Thank you.
Yes, I was very enthusiastic in my first days of pancreas surgery. After education in Beaujon Hospital in Paris. In Beaujon works one of the biggest pancreatic surgeons in Europe, Professor Alain Sauvanet, and and his team almost used pancreatogastric anastomosis. In first maybe 5 years, I was a very big fan of pancreatogastric anastomosis, and today I'm doing in high risk also liberally. Yeah, it's good anastomosis. There is no data with statistical significance, meta-analysis, but it's very logical and maybe could be easy to perform.
Another question, Professor No.
Dear Miroslav Stoyanovich, thank you for your nice lecture and answers. My question about biliary drainage in this patient. What is your cutoff level of bilirubin for biliary drainage perioperatively?
Yeah, cutoff level, it's about 300 micromoles of bilirubin. 300 is a cutoff for Whipple operation. In some cases, we can proceed with the operation in the clear case of inoperable with 400 and 500, because we have a problem in Serbia with ERCP and internal drainage. External drainage is not a problem, and our radiologists are very, very skilled about that. It's 300 micromoles.
Professor John.
Thank you, Professor. I want to ask, apart of the oncological requirements, when you choose the total pancreatectomy, do you prefer spleen preserving or with doing the operation with the spleen? What are your choices for this condition? Thank you.
Yes, in every case, we try to preserve spleen because of the gastric vascularization and short gastric vessels, also right gastric artery, left gastric artery, because of the right side we have no arterial supply after removing of the head of the pancreas. I think the oncological reasons to remove the spleen because of the cancer of head of the pancreas is not so big and so important. There is no oncological logic to remove the spleen because of this.
Thank you for your attention. We are closing the meeting.
Yeah, thank you everybody for participating in this very interesting session. So we are going to group photo and then after the coffee break.
Okay, our second session is starting now. Let's begin the session that we will talk about the challenges that reduce the lifespan of all pancreatic surgeons. And our first speaker is from Serbia, Mr. Radenkovic. Please, floor is yours. You can start your presentation. Please, the session is starting just now. So please close the door of the hall. Okay, you can start, Mr. Redenbacher.
Dear Chairman, ladies and gentlemen, dear colleague, again, it's a great pleasure to be here. Thank you, organizing committee, for kind invitation. My job today is to talk about the strategic approach to managing of pancreas fistula, one of the most painful thing for the all pancreas surgeon. All of us know how does it look like. The definition of pancreatic fistula is that it's drain output of any amylase volume, which is 3 times more than normal serum level, and also it have to be associated with a clinically relevant condition. This is the classification from the International Study Group for Pancreas Surgery done in 2017. It was updated because there was a lot of definition of pancreas fistula, and Claudio Bassi from his team from Verona firstly have done it 2006, and then this is the new updated definition. All of us know that it's Achilles tendon of pancreas surgery and the Whipple procedure is the pancreas fistula, and it occurred in around 13 to 40% of the patients after pancreas resection, and which is much more importantly is the mortality remains as high as 18%, and it's also doubling mortality if you have to do laparotomy for those patients. This is the real world data from of course, it's coming from Netherlands, and it's their national audit of their patients. And if they look like there is the pancreatic fistula B and C around the 30%, and it's in those patients the morbidity is around 45%, and it's more importantly in those patients failure to rescue is around 9%, which is much more in the patients if they have the pancreas fistula. And why it matters? Because if you have in patients with pancreas fistula, then you have intra-abdominal collections and abscess formations. Also, the stomach doesn't function well due to the collection, and it has a delayed gastric emptying, sepsis, organ failure, or need for reintervention. And also, more importantly, the post-pancreatic hemorrhage is much more pronounced in the patients with pancreas fistula. And this is in the same paper where was definition, the International Study Group for Pancreas Surgery did the classification and the grading, and fistula A, which was previously, now is defined as biochemical leak, because we have just measurable amylase in the drain output and there is no other signs. For the grade B, we have signs of the critical relevancy. We need percutaneous or endoscopic drainage, but no reoperation, and no, there is sign of sepsis, but without organ failure. Main distinction between a B and C fistula is that there is no reintervention and no organ failure. So it's very important because we need to report and to have the similar reporting, the standard reporting of our patients, so that we can analyze them. And there is several fistula risk scores, because it's very important to in advance to know which patient will develop fistula. So our treatment will be much more careful to those patients, and we need to take more attention for their treatments. So there is several fistula risk score. This is American. This is alternative by the fistula risk scores done by the Dutch group, Japanese definitions, and mainly they are grouping it in the 3 preoperative, intraoperative, and fistula risk score categories. In preoperative variables, there is several important things like pathology. Then there is sex, also BMI. We know that in the fat patients, it's much more prone to have the fistula. Also the bilirubin level before the operations, and it's different, but mainly we are coming to the pancreas texture and to the diameter of pancreas duct. And therefore, I think the most widely accepted classification on the risk of pancreatic fistula is done by International Study Group for Pancreatic Surgery. It was 2023, where they graded very simply, much more simpler than to other fistula risk scores, to A, B, C, D. And we are coming from A, and all of us know that it's hard pancreas texture, and the main duct size is more than 3 millimeters, then it's grade A, and the grade D is soft pancreas texture, and the main pancreatic duct size less than 3 millimeters. And according to this fistula risk score, we have also take care about the patient. This is high BMI. That means as we have the fat patients, and therefore it's big difference between Japanese and Korean patients, which is all of them mainly slim, so it's much easier to deal with. They have no BMI high. Also, it's important that all patients with pancreas cancer is in malnutrition. So it's very important to know about the prehabilitation, which means that our patients have to be in good nutritional status as possible. Of course, the jaundice and diabetes and preoperative stenting. Preoperative stenting is important because in those patients, mainly we have bacterial infection of the bile. So we have to do it intraoperative culture. So how to know what is the prediction of the bacteria who will be present in that specimen. Of course, the most important from my point of view is soft pancreas and small main pancreatic duct, and is also pointed in the definition of international study group. But what we cannot change all the very few of these, but what we can change as a surgeon is we have to take care about the blood loss. We have to be meticulous skeletonization. We have to try to do our operation as quick as possible, but not compromising the safety. And we have to know how to deal with difficult anastomosis and vascular resection when we need it. And this is the analysis of the, again, international study group, almost 5,500 patients. And they figure out that the biggest rate of pancreas fistula is 23% in the grade D, which is quite acceptable. And that average in all patients in this subgroup is around 16%. So if you would like to measure how do you work in your institution, you have to know that acceptable level of pancreas fistula is around 20%. If you have 30 or 35, you have to think that you have to change something in your practice and to try to adjust to this relevant data. And this is the analysis, again, from the Dutch pancreatic study group, and they look at the patients with grade C fistula, what is the outcome, and look at this data. Almost 50%, 48% have post-pancreatic hemorrhage. Also, major morbidity in patients with fistula is around 100%, 20% of them have the reoperation, and mortality rate in patients, ladies and gentlemen, is around 37%. So it's very high mortality rate. So we have to focus mainly on the patients with predicted grade C fistula, and also the hospital stay is unacceptably long. One of the main thing is, as it was pointed in my previous colleague, Professor Stojanovic, about the total pancreatectomy, and he pointed out, and he showed this study very, very meticulously, that whether it's difference in mortality between total pancreatectomy and anastomosis. And all of us think from the clinical practice that if you don't have do the total pancreatectomy, you will avoid major complications, but mortality rate, according to this meta-analysis, is the same. So it's the same if you do difficult anastomosis and total pancreatectomy, the mortality rate didn't change. Also, it was around 90-day mortality was almost the same, around the 6%. Also, it's data for morbidity from same meta-analysis, and there is no difference in morbidity between both, even in the group which is this is a randomized trial. This is a very well structured retrospective study, prospective study. There is no big difference in the match randomized style. But if you take all studies, but we have to bear in mind that if you have retrospective study, you always have the problems with acquisition of the data. But if you analyze the matched or randomized studies, there is no difference, significantly statistical difference in the rate of the major morbidity. So this is the algorithm which was proposed in the Porsche trial. The Porsche trial was a randomized controlled trial from Dutch study group, where they compared usual standard of care versus early detection of the complications in pancreas surgery. And this is very important, that you have to see if you have patients with one of the following signs, which means the fever more than 38.5 centigrade, CRP more than 300, or CRP which is not dropping, you have to do early CT scan. That's idea of the trial versus usual care. Even though if you have scanned yesterday, but you have changes day after your CT scan and you have all this data, you have to go for the perform the CT scan. Also, if you have the white blood cells, heart rate, or respiratory without any other signs, you have to go to pancreas surgeon or to do the multidisciplinary team who will decide whether you need a CT scan or not. Of course, if you have drain amylase output more than 3 times, then for sure you need to go to perform early CT just to figure out what's going on around your pancreas. So don't be reluctant to do early CT. It doesn't mean nothing for your patients who receive too many CTs, and one more will not compromise their radiological problems, but will allow to figure out what's going on. Also, another part of the PORCH trial is minimally invasive management. When you figure out that you have to start from day 3 to go through the vital parameters, infection, drain production, and also because a lot of these patients were treated in the ICU, surgeon operate, and then come time to time, then it's mainly for the ICU people. They need to call a pancreas surgeon to evaluate together the status, not to think that this CRP is from central vein catheter or urinary infection. If you have these signs, it have to be immediately for pancreas surgeon, and then this is the indication for CT if we have some of these parameters, and also if we will leave the drains or will drains be removed early. If you don't have drain production with amylase and CRPs, then you have to remove the drains as quick as possible. That means as postoperative day 3 or 4. Also, if we have the collections or signs of disruption of anastomosis, then we need antibiotics as early as we are. And also very important, if the drains doesn't function well, you have the amylase output, but on the CT scan, you have the collections, then as quickly as possible to do the percutaneous drainage. And of course, all these decisions have to be done on the expert panels. What is the results of that PORCH trial? I showed you algorithm, which should be adapted, I think, in daily clinical practice. And when they have it, this is the number of the patient which was randomized with the usual care. It was around 900 and 900 patients with the algorithm group or early detection, and the primary endpoint was the morbidity rate, new onset alcoholic failure, and it's statistically significant differently less in algorithm group than it's the usual care. Also, new onset organ failure was significantly different, bleeding events was similar, and the mortality rate, ladies and gentlemen, was double less. So if you do it early, implementation of the early signs and early CT and early antibiotics and percutaneous drainage, then mortality, even though it was not statistically different, but it was 2.7 versus 5%, which was in usual care. Also, another question is whether this is a national analysis of the Dutch group, whether the completion pancreatectomy or pancreas preserving procedure, when you need to reoperate the patients. And all of us as pancreas surgeon, I think, thought that that's our historical thoughts, that if you eliminate the pancreas or do the completion pancreatectomy for reoperation, that's the only way how you prevent. But this is the result of completion pancreatectomy, 56 patients, and pancreas preserving procedures, which means put the drain, wash out everything around, and try to resuture or to redo anastomosis. And then there is significantly statistical difference in the Apache 2 score in the patients who received the completion pancreatectomy. All other data are the same. So you avoid, that means that it's same as you avoid to do completion pancreatectomy in comparing with pancreas preserving procedures. And this is the biggest experience in completion pancreatectomy from the Heidelberg, and they have done, they compare it if it's done 12 days before or 90 days when they change it. And the mortality rates was completely different for the 21% and 37%, and highest mortality is for the patient who had combined pancreas fistula with post-pancreatic hemorrhage, which means the bleeding. And also the uncontrollable leak for the pancreatic jejunal anastomosis was mainly associated with 40%, even in Heidelberg, with 40% mortality. And also, it's very important to stress that a lot of patients have post-pancreatectomy acute pancreatitis, which is very often mixed with pancreas fistula. But therefore, we need to know that they have same signs, but if you do proper CT scan, you will see necrosis of the remnant in comparison, and also the collection. But in pancreas fistula, you don't have necrosis of pancreas remnant. And those patients, it's now still debatable what is older, it's a chicken or egg, who first developed, whether pancreas post-operative acute pancreatitis or pancreas fistula, but it's a mixture of the data. And what's the mitigation strategy? That means, what if you have soft pancreas and you have the small pancreas duct? This is nightmare for pancreas surgeon. And we have to try that all as a surgeons we can do during the surgery. After that, it's interventional radiology, ICU people and other. But for us as a surgeons, we have to try to do it to minimize the blood loss during the surgery, especially during the pancreas transection and during the uncinate dissection. So we have to be meticulous in dissecting the uncinate process, try to suture and ligate every small vessel, because it's also very important. It's very important also when you transect pancreas, if you have soft pancreas, not to use diathermy and electrocoagulation. You need 5 or 6 0-prolene sutures to find and to suture this, because then you have problem of free bleeding if you have the pancreas fistula. Also, it's very important that within your institution, you have standardized technique. Whether it should be on the pancreas, mainly on the discussion and panel discussion within your institution, but you need to have standardized technique that everybody is doing the same, and then you can compare result and to shift or change if you need it. But for beginning, it have to be standardized technique. One of the very good randomized trial in soft pancreas are coming from Hong Kong, and they figure out that external stenting, it's the only randomized trial who show difference between soft pancreas and in the randomized trial that external stenting help and reduce mortality and morbidity. Somatostatin analogs, there is no proofs, but still I think that all pancreas surgeons say if it doesn't help, but it doesn't harm, I will try to do it. Also, there is a Finland group who proposed the perioperative steroids, the use of steroids during because the idea behind that is, the rationale is that it will be less the pancreas secretion due to the perioperative steroids. Also, what is very important is to speak with your anesthesiologist and to ask for the fluid management tailored to the patients, because all of us know if you have overwhelming with the fluid, you have the swelling of the root limb, and you have very hard to suture it. And also, you have to think about upfront total pancreatectomy, whether it's useful or not. It depends, but I say it have to be standardized within one institution. What is postoperative mitigation strategy? It's very important, and also the Porsche trial confirm it, that we have to be proactive, preemptive, and aggressive in the treatment of complication to try to be before the developing of sepsis and before developing of the multi-organ failure. So it's important to have step-up approach, that your patient have to be fed. If it cannot orally take, you need total parenteral nutrition, because it's a hypermetabolic state. It's also important to remove the drains if you don't have problem, to remove it early, or that means after the postoperative day 3, if the amylase output is. Also, it's important to do CT scan as quick as possible. It's to talk with your radiologist and endoscopist if you have collections to be drained as early as possible. Also, if it's not possible to drain collection from some reason endoscopically or interventional radiology, you need to go to OR and to try to do surgical drainage. If it's your anastomosis looks well, but you need to make a washout and to be very extended drainage. Also, you have to think about the completion pancreatectomy. And from my point of view, revising pancreatic anastomosis and switching to other techniques should not be done, because I think that revising anastomosis, it's mainly pancreas necrosis, it's very hard to resuture or to do. If you see that you have necrosis, that you have to do something with your pancreas tap, I think the best option is to do the completion pancreatectomy. So management principles, if you have suspected postoperative fistula, you have to measure amylase and drain output and to look at the clinical signs. If the patient is stable, you need to give them antibiotics to correct the nutritional support. That means to switch to total parenteral nutrition if you cannot, but mainly they cannot eat orally, and to take care about the drainage. If you have collection, you have to go for the immediate percutaneous endoscopic drainage. If you cannot control like this, we need multidisciplinary source control. And if you have unstable patients or patients with bleeding, you have to go to angiography immediately. And therefore, it's important to the pancreas center to have 24/7 angiographical interventional radiology also for the bleeding. And at the end of the day, we will go for the surgery. And at the end, we are, as a surgeon, just one player in the team. And as good as you are, if you are surrounded by more than 3 or 4 players in the white shirts, you will lose your game. Thank you for your attention.
Thank you, Dejan, for your very informative talk. Is there any question from the floor or any comment? Yes, Professor Kerem and Professor John. Yeah.
Nice presentation. You know the Özbekistan comparison using the age with the surgery, especially patients.
We used routinely the tazocine, tazobactam, piperacillin, especially the risk group. For instance, patients who had previously pancreatic or biliary standing. And the second question is especially the soft pancreas, the hydrocortisone treatments, especially protect to the post-pancreatectomy pancreatitis. You use the hydrocortisone routinely. What is your practice to this standing? Internal, external, or no standing?
That's 3 questions, Mustafa. Thank you. Yeah. Okay. Yeah, we used routinely tazobactam after this randomized trial. We used routinely tazobactam, but if we have external stenting, we are adjusting our antibiotic treatment according to the culture obtained from the external stent. If we have internal stent or no stents, we use tazobactam, but as prophylaxis, just for 1 day. And then if the complication develops, we can continue. Before the complication, we just use it as prophylaxis. That's first question, I think. The second question is about the hydrocortisone. We don't use it in our institution routinely, but in the soft pancreas, we will start to use it because there is more and more data in soft pancreas and in small duct. We will start to use it because, as you pointed, it's prevent maybe postoperative acute pancreatitis. And for the stenting, we still didn't use any stents. But I think that maybe because we don't have this specific stents in our country, we don't have that specific stents for pancreas surgery, because there is stents in Germany and the other European countries, because there is a lot of problems with stent removal. And therefore, if you have specific stent for pancreas stenting with balloon, which you can put it in pancreas, then you can avoid that migration of the stent. But mainly this stent migrate, and therefore it's a problem because mainly people using from pediatric nasotube and something which is provisional stents. It's not specific pancreas stent. If you have specific pancreas stent, I also can say that I can recommend it to use it for the externalization, but external, not internal, doesn't make any sense.
Last 3 years, we used to do double G catheter for urologs. We cut the half. It was very soft and no immigration to pancreatic site. It is very soft. And after that, also our pancreatic fistula rate is very low. It's so easy for, especially you say, no soft pancreas, pancreatic stenting in your country, you can do that.
Thank you very much.
Okay. Professor John, please.
Do you have any, thank you for your nice presentation. Do you have any way to check whether your cut surface of the pancreas is vital? How do you check vitality of cut surface? Because I believe the many of pancreatic fistulas after a precise good technique results from cut surface, pancreatic cut surface necrosis after days after surgery. So do you have any do you have any way to or familiarities to way to check for pancreatic duct surface vitality during surgery?
Thank you. It's a very important question. Thank you for it. Actually, intraoperatively, we don't have any. It's just visual. We try to do it before the surgery on CT scan or MRI to see whether it's some signs or not. But generally, we don't have any tools. I don't know for the tools which can really measure what is the softness or how it's acinar production.
For example, are you prone to take another slice from pancreas if you see there's no good bleeding on the cut surface?
Yeah, actually, no. I think that, yeah, but I think it's not problem. It's not problem with ischemic. It's problem for the texture who can provoke the more amylase production. I haven't seen the problem with that it's not good vascularized remnant.
Okay, thank you. And Professor Abbasoğlu, please. Could you please pass the microphone?
Thank you.
Okay.
Just like to add on the Professor Chan's question, how do you think the excessive mobilization of the pancreatic stump affects the vascularization and future complications in terms of fistula?
Yeah, it's a long story, but without any conclusion. Long story is how much you mobilize pancreas and whether. I think that there is intrapancreas vascularization, and very rarely we saw that it's necrosis due to the hypovascularization of the pancreas remnant.
If you don't mind, could you please pass the microphone to Professor Abbasoğlu because he wants. Okay.
Thank you very much for your very informative talk. If fistula is not responding to conservative management, surgery may be required. As you mentioned very clearly, what's your personal experience regarding completion pancreatectomy? In our hands, it's very difficult, a lot of complications. What's your experience in your institution?
Yeah, we try if it's possible. If I don't see complete disconnection between the pancreas stump and roux loop, if it's tied, then I try to wash out and to make good drainage. If I realize that it's completely disconnection between the anastomosis, then I'm going directly for the completion pancreatectomy, which is accompanied with very high mortality rate, around 40% even in my institution. Okay. With 40% is mortality rate after completion. Especially if it's older patients with comorbidities, etc., then therefore they are mainly lost. And also if it's the fat patient, if the body mass index is high, more than 30, then it's really very hard to manage it. Okay. But if it's possible, as I saw, if there is no real disconnection, then it will wash out and put the drains, but not resuturing, because this is the new provocation of the new fistula places.
Thank you, Dejan, for your informative talk. And I'm going to use my privilege being chairman, and I'm going to ask the last question. The last question is, my question is, do you have any routine CT scan in your protocol in order to differentiate acute pancreatitis and post-pancreatectomy? I mean, post-pancreatectomy, pancreatitis, and fistula. It is my first question. And the second one, do you change your attitude if you have a huge suspicion regarding fistula, postoperative fistula? either due to soft pancreas or local conditions. Do you change your attitude in terms of number of drains you use? For example, do you add some new drains, or do you use any sealing recently introduced products over the anastomosis or something like that? Thank you.
Thank you, Ahmed, for a question. Yes, we don't have a routine policy of the CT scans, but if the patient has the amylase output more than 3 times, and also if we have the serum amylase on first postoperative day more than normal, we are more cautious of these patients, and maybe if the day 2 he will not feel well as we expected, we will do very early CT, but it's not routine. Just if you have the amylase in serum and also in the drain output. So because they say that serum amylase is a big prediction of postoperative acute pancreatitis, but it depends now of the level. And yes, if I have soft pancreas, I will put 2 drains, 2 soft drains. Mainly I use Foley catheter, the small Foley catheter, which is very soft, and you can also have another channel for the installation and for the installation of the fluids. So I can put 1 drain below the anastomosis on the upper side, so maybe I can wash out through that Foley drains.
Thank you. And I think it is time to move on. Thank you, Dayan, one more time. And we are going to move forward to second speaker. And second speaker is from Turkey, Sinan Efe Yazıcı, and he's going to talk about the post-pancreatectomy hemorrhage and management of the hemorrhage. Thank you.
I am glad to be here. Thanks to organization committee. And today I will talk about post-pancreatectomy hemorrhage. Despite remarkable advances in surgical techniques and perioperative management, postoperative bleeding continues to be a major cause of morbidity and mortality after abdominal surgery. Overall, postoperative intra-abdominal bleeding is reported in approximately 0.4 to 10% of abdominal procedures. The majority of cases associated with pancreatic surgery. Despite improvements in the perioperative care of patients undergoing pancreatic surgery, the risk of major complications, including anastomotic leak, postoperative pancreatic fistula, and delayed gastric emptying persist. Post-pancreatectomy hemorrhage is a less common but particularly hazardous complication with mortality rates of up to 40%. Therefore, understanding post-pancreatectomy hemorrhage is essential for improving outcomes after pancreatic resection. Before 2007, different studies reported very different rates of post-pancreatectomy hemorrhage and mortality. One of the main reasons was the absence of a uniform and objective definition. As a result, studies often describe different clinical scenarios under the same term, making it difficult to compare outcomes and evaluate treatment strategies. To overcome this problem, the International Study Group of Pancreatic Surgery introduced a standardized definition and grading system. So what does this group's classification include? According to this consensus, hemorrhage is characterized by 3 fundamental parameters: the timing of bleeding, the location of bleeding, and its clinical severity. The combination of these 3 variables forms the basis of the International Study Group of Pancreatic Surgery grading system. Using these parameters, patients are classified into grade A, B, and C hemorrhage. This is the original International Study Group of Pancreatic Surgery definition. The first classification is based on timing. Bleeding within the first 24 hours is considered early, while bleeding after 24 hours is considered late. The second is location, classified as intraluminal or extraluminal bleeding. The third one is severity, categorized as mild or severe according to the degree of blood loss, clinical impact, transfusion requirement, and need for invasive intervention. These three parameters forms the basis of the group grading system. Also, these using the previous described parameters, the groups classifies post-pancreatectomy hemorrhage into three grades, A, B, and C. Grade A represents mild bleeding with minimal clinical impact and usually doesn't alter the standard postoperative process. Grade B is clinically relevant hemorrhage that requires additional diagnostic evaluation or therapeutic intervention such as transfusion, endoscopy, angiography, or rarely surgery. Grade C represents severe life-threatening bleeding associated with major clinical deterioration or mandates immediate intervention. Although the group's classification has been the standard for nearly 2 decades, recent studies have begun to question whether it fully reflects the biological and clinical behavior of post-pancreatectomy hemorrhage. One important criticism is that early severe bleeding and late mild bleeding may both be classified as grade B, despite having different etiologies and management strategies. In addition, the clinical importance of the 24-hour cutoff has recently been challenged. So some studies asked whether an update the group's definition may be required. Also, early hemorrhage is most often due to insufficient surgical hemostasis or bleeding temporarily hidden by vasoconstriction. Therefore, early hemorrhage is generally considered a technical surgical complication. In contrast, late hemorrhage is usually the consequence of postoperative process. It is strongly associated with pancreatic fistula, intra-abdominal infection, anastomotic leakage, and biliary leakage, all of which may lead to vascular erosion and hemorrhage. The source of bleeding is also different between early and late hemorrhage. Early hemorrhage is most commonly related to mesenteric vessels, superior mesenteric or hepatic arteries and branches, and anastomotic suture lines. These hemorrhages are usually extraluminal and reflects technical issues. In contrast, the late hemorrhage is predominantly arterial. The gastroduodenal artery stump is the most frequent bleeding source, followed by the hepatic artery and splenic artery. One of the most important concepts in post-pancreatectomy hemorrhage is sentinel bleeding. This refers to intermittent bleeding through the surgical drain, nasogastric tube, hemostasis or hematemesis or melena. The bleeding is usually self-limited, often causes only a modest decrease in hemoglobin, and may stop spontaneously without transfusion requirement. However, this temporary cessation shouldn't reassure the clinical team. Sentinel bleeding is frequently the first manifestation of an underlying vascular lesion, most commonly a pseudoaneurysm caused by a pancreatic fistula or perivascular infection. Therefore, every episode of sentinel bleeding should be treated as a warning sign of potentially catastrophic hemorrhage. At this stage, blood products should be prepared. The patient should be transferred to a closely monitored setting such as the invasive care unit, and the endoscopy and intervention radiology teams should be alerted immediately, even if the bleeding has stopped. Management of post-pancreatectomy hemorrhage is primarily determined by two factors: the timing of bleeding and the patient's hemodynamic status. Early hemorrhage is usually related to a technical failure of hemostasis. Therefore, surgery remains the preferred treatment option in most cases. In contrast, late hemorrhage is commonly associated with pancreatic fistula infection, vascular erosion, and pseudoaneurysm formation. In hemodynamically stable patient, CT angiography followed by angiography and endovascular treatment has become the standard approach. Surgery is generally reserved for unstable patients or those with failed endovascular treatment. Finally, it is important to emphasize that no single algorithm applies to every patient. Management should always be individualized according to the patient's condition, bleeding severity, available expertise, and local hospital resources. So here is our cases from our hospital. A 67 years old male patient underwent an pancreatic duodenectomy for pancreatic adenocarcinoma during his hospital stay. On postoperative day 28, the patient developed hemodynamic instability. Laboratory test revealed a hemoglobin level of 5.5 gram per deciliter. After initial resuscitation, imaging demonstrated active bleeding from a gastroduodenal artery, pseudoaneurysm. Image A, you can see the gastroduodenal pseudoaneurysm, and image B, the black and white arrow shows the embolized gastroduodenal artery. Also, I would also like to share our own institutional experience. Recently, our group from Hacettepe University published a retrospective study comparing surgical and interventional radiologic treatment of postoperative abdominal bleeding. The study includes 35 patients requiring invasive treatment for a postoperative hemorrhage over a 10 years period. We observed that early bleeding was generally managed surgically, whereas late bleeding was predominantly treated with interventional radiology. Importantly, interventional radiology achieved a technical success and clinical success rate of over 80%. Conversely, late bleeding patients who requires surgery had a very high mortality rate. These findings support the current trends towards an angiography first strategy in stable patients with late post-pancreatectomy hemorrhage. So pancreatic surgery can no longer be considered a one specialty procedure. Successful management of post-pancreatectomy hemorrhage requires close collaboration between pancreatic surgeons, interventional radiologists, and endoscopists. Thank you.
Thank you for the talk, especially thank you for your time observation. Thank you. Is there any question or any comments on the floor? Yes, please. Yeah, right over there. Could you please pass the microphone? And please introduce yourself first and then raise your question.
Hello, I am Dr. Erşin Sönmez from Istanbul Medeniyet University. Thank you for your very good presentation. A post-pancreatectomy hemorrhage is one of the most catastrophic complications of this surgery. So a surgeon dealing with this pancreatic surgery, unfortunately, most have dealt with this type of complications. And I would like to know about your institutional experience about the endovascular stent concerning interventional radiology.
Also, here our interventional radiologist is here.
Perfect.
Maybe.
Hi, I'm Gonca. I'm the IR from Hacettepe. We work together. Endovascular grafting, you mean not stenting? It's a stent graft. You mean the closed ones?
Yes.
If it's a main artery, we only use that in that purpose, like the hepatic artery. But if it's like a GDA stump or a branch, mostly coils or glue embolization, we use that because afterwards, when you graft the artery, eventually it's gonna occlude.
I just want to ask, what is your initial approach mostly? For example, because sometimes the gastroduodenal artery, the stump may be sometimes very short. So technically the embolization cannot be feasible in those cases.
That's all technical, actually.
Yeah.
If I have a stump that I can enter into, I would prefer to coil it. But if it's a very narrow stump or just a little bulge, then we have to graft it.
Okay. Thank you.
Okay. Any other question?
No, thank you.
I have only just one question, quick one. Do you have any experience with portal vein bleeding following pancreatic duodenectomy? Either one of the ligated branches or excessive dissection of the tissues around it. Do you have any postoperative portal vein bleeding experience? And would you put any endostent in it
We have one patient, the bleeding within 24 hours, and we operate him again.
All right. So it means that you didn't send it to interventional radiology.
You can't do that because there is no graft available for portal veins specifically, and usually if it's a venous bleeding, there's always a fistula or something going around there, and we had one actually. It was a branch of portal vein, and I took it into the angio, but we couldn't find any artery, and then your guy is sitting next to you, open him up, and there was a small branch, and he coagulated it. And putting a graft in a portal vein is a very tricky thing because you will close up all the branches draining into the portal vein.
All right, thank you. Any other comment or question from the floor? Okay, thank you. We can move on. Thank you.
Thank you very much. Now I want to introduce our next speaker, Mustafa Şentürk from Turkey, to make his presentation.
Good morning, dear Chairman, esteemed Professor, and distinguished colleagues. Welcome, everyone. I would like to express my sincere thanks to Congress President Professor Mustafa Kerem and organization committee. Today, I will be talking about risk factors and management of delayed gastric empty, a clinical significant condition that can be adversely affect postoperative recovery, prolonged hospital stay, and increase morbidity. According to the most recently updated Global 2022 data, the incidence of pancreatic cancer is 4.7 per 100,000, and its incidence has been steadily increasing. Pancreatic duodenectomy is one of the most commonly performed surgical procedures in the pancreatic cancer surgery. One of the major complications associated with the procedure is delayed gastric empty. In the literature, the rate of delayed gastric empty ranging between 19 and 57%. There have been numerous definitions of delayed gastric emptying in the literature. To eliminate this inconsistency and confusion, the International Study Group of Pancreatic Surgery established a standardized definition in 2007. The terms used most commonly to identify the complication were delayed gastric empty and gastroparesis. In the literature, the delayed gastric empty was classified regarding first, the duration of nasogastric intubation and or need for insertion of nasogastric tube. The second, the postoperative day when oral intake of solid food was tolerated after pancreatic resection. Delayed gastric empty was classified into 3 grades. Grade A, requirement for a nasogastric tube for 7 days or reinsertion of the nasogastric tube after postoperative day 3. Grade B, requirement for a nasogastric tube for 14 days or reinsertion of the nasogastric tube after postoperative day 7. Grade C, requirement for a nasogastric tube for more than 14 days or reinsertion of the nasogastric tube after postoperative day 14. For the diagnosis of the delayed gastric empty, the continued need for a nasogastric tube beyond postoperative day 3 or the requirement for insertion after its removal is taken into consideration. In a meta-analysis published in 2023, a total of 31 studies involving 9,205 patients were analyzed. Literature review of articles in PubMed, Embase, Web of Science Cochrane Library systematically searched for studies from inception to 2022. Rate of delayed gastric emptying, 22%. Non-surgical factors of delayed gastric empty are advanced age, preoperative biliary drainage, soft pancreatic texture. Surgical related factors are postoperative pancreatic fistula, intra-abdominal fluid collection, intra-abdominal abscess, excessive intraoperative blood loss. In other study analyzing more than 5,000 cases from the German pancreatic surgery registry, the incidence of delayed gastric empty was compared between pillars preserving pancreatic duodenectomy and pillars resection pancreatic duodenectomy. No significant difference was found between two techniques. The risk factors for delayed gastric empty were similar to those reported in previous studies. These are advanced age, longer operative time, pancreatic gastrostomy. Pancreatic jejunostomy is safer than pancreatic gastrostomy. And postoperative pancreatic fistula, biliary leakage, post-pancreatectomy hemorrhage. Pancreatics suffering from delayed gastric empty stay for 28 postoperative days, whereas patients without delayed gastric empty were discharged after 18 days. Postoperative length of stay was significantly longer in patients with delayed gastric empty. A study investigating the effect of different nutritional strategy on delayed gastric empty was published in the British Journal of Surgery Open last year. In this study, a total of 2,315 patients registered in the Dutch pancreatic cancer audit between 2021 and 2023 were analyzed. The delayed gastric empty rate was 23. The risk factors for delayed gastric empty are the same as other results in the literature. The risk factors for delayed gastric empty are postoperative pancreatic fistula, post-pancreatic hemorrhage, biliary leakage, Charlson comorbidity index high, and extended resection. Three groups were compared: ERAS guidelines, recommendation, unrestricted diet, step-up diet, and artificial nutrition, yani artificial feeding. None of the nutrition strategies demonstrated superiority over the other regarding the prevalence of delayed gastric empty. In a separate study published in Update in Surgery in 2023, this study evaluated the effect of delayed gastric empty on 13-day mortality rates following pancreatic duodenectomy. A total of 8,011 patients from 2014 and 2027 were retrospectively analyzing using the American College of Surgeons National Surgical Quality Improvement Program Target Pancreatectomy Database. The delayed gastric empty rate was 15.6%. Independent factors of developing delayed gastric empty are pancreatic fistula, deep organ space infection, chronic obstructive pulmonary disease, male gender, and advanced age. When the delayed gastric empty and non-delayed gastric empty groups were compared, the delayed gastric empty group exhibited significantly higher 3 days mortality rates, longer hospital stays, and higher 30 days readmission rate. How is management of delayed gastric empty? Nutritional management is small frequency meals, liquid-based nutrition, low fat and low fiber, isotonic room temperature foods, enteral or parenteral nutrition supports may be required in several grade BC delayed gastric empty when oral intake is inadequate. Pharmacological therapy can be used prokinetics agent, which are erythromycin, metoclopramide, domperidone. In conclusion, treat the underlying cause. More than 70% of delayed gastric empty cases are secondary delayed gastric empty. Whenever grade BC delayed gastric empty is encountered, an occult postoperative pancreatic fistula or intra-abdominal collection should be actively investigated. The second, anatomy and motility are not the main determinants. Both randomized trials and national registry data demonstrated that pillar preserving versus pillar resection does not significantly affect delayed gastric empty rate. Nutritional protocols can be flexible. ERAS style, early unrestricted feeding, does not increase the incidence of delayed gastric empty. High prognostic In fact, the delayed gastric empty is associated with more than a threefold increase in early mortality. Early detection and aggressive nutritional supports are therefore critical. As a result, delayed gastric empty is perhaps the most patients testing complication after a Whipple procedure. However, its management relies not on the operation, but on a patient and well-structured conservative approach. Thank you for attention.
Thank you very much for your informative talk. Is there any question or please, Professor Dr. Abbasoğlu?
Thank you very much for your presentation. What's your policy regarding enteral nutrition access in patients with high risk of delayed gastric emptying or postoperative pancreatic fistula? Do you change your strategy during surgery for the placement of enteral access in this group of patients?
Delayed gastric empty classifications, grade B or C, the patient, we prefer enteral nutrition. Gastrostomy or gastrostomy or jejunostomy.
Hastalarda biraz hızlı jejunostomy gibi böyle şeyler düşünüyoruz.
No, we don't prefer.
Is there another question, please, Dr. Can?
In your clinical practice, how do you manage patients with delayed gastric emptying without any pancreatic leakage or fistula? There is no pancreatic fistula, nothing, no collections, but there is delayed gastric emptying. How do you manage?
We can use prokinetics agents and watch. Gastroparesis is not a treatment, maybe.
In our practice, endoscopy, endoscopy works sometimes because sometimes there is a edema at the level of pancreaticojejunostomy, pylorojejunostomy, and sometimes there's kink or early adhesions in the belly. If you do an endoscopy, many times it works. Thank you. Traversing the anastomosis, of course, traversing the anastomosis.
Please, Dr. Tajankovic.
Thank you for your excellent presentation. My question is about the nasogastric tube removal. Are you removing according to the ERAS immediately after the surgery, or you keep it and also the reinsertion? If you have delayed gastric emptying, how you reinsert and what is the main decision for reinsertion?
We insert nasogastric tube if the drainage is lower, 400 millimeters. But if possible, we start oral intake.
My question is whether you take out NG tube on the OR table. Are your patient going to ICU without NG tube? And when you reinsert it, if you have problem.
Reinsert. Hangi durumda çekiyorsun? No, we always nasogastric tube in operation.
So that means you don't follow ERAS.
No.
Okay, that's your policy. I don't have nothing against, but just because the problem is when you, according to ERAS, you have to take out NG tube on the OR. Patients are going to ICU with, and then it's tricky when to reinsert if you have the gastric.
But as all we know, the ERAS is not completely applicable procedure. It is more ERAS-like procedures, and everybody has its own choice or ERAS style. For example, it is really quite hard to fulfill all requirements of ERAS procedure, including nasogastric tube or any other applications.
May I ask a question? Let me add, sorry, I think the patient in need of nasogastric tube in place immediately after surgery, the day post-operative day 1 or 2 is less than 5%, maybe. So we can put NG tube on demand later on if needed.
Yeah, I agree about it, but I will ask the doctors because there is real proofs that NG tube doesn't mean nothing in post-operative period. And I will ask the doctors who say for any case to put to themselves and to see how does it look like when you wake up from the anesthesia without or with NG tube. Because we have proofs now, doesn't work. It doesn't mean nothing. Therefore, I say,
let's make a deal. Just early removal. All right.
Well, I want to ask a question to the audience also. What's your policy about nutrition, about surgery? Do you apply early nutrition, early enteral nutrition, early nasovaginal nutrition? Maybe it may make worse, or it may worsen the delayed gastric emptying. Malnutrition is a real risk factor, I think. So what's your policy for
we prefer
the malnutrition?
We prefer early nutrition, step up feeding. Yeah, first liquid and solid foods.
In which day or in which hour do you start nutrition?
2 or 3 days post-operative.
Yes, another question. Yeah.
It's not a question, it's more like a comment about this nasogastric or nasojejunal tubes. In my hospital, we have a practice to put the nasojejunal tube and to start early enteral nutrition. After 6 maybe hours after the operation, we start with 10 milliliters per hour with the enteral transnasojejunal tube feeding. Yeah. So.
And how long do you keep it going?
Till 2 or 3 days, and after we are removing it and continue with the enteral nutrition. But sometimes if we have complication, then we will replace it with the drainage tube, with the gastric tube, when we have this delayed gastric emptying or gastric paresis.
But I was wondering if it is against the main concept of the early removal of nasogastric tube in terms of
yes,
respiratory dysfunction or superficial respiration and causing atelectasia or any subsequent problems.
This is 3-luminal tube. With this tube you can make early nutrition, and also you can make the decompression of the gastric remnant.
Okay.
Is there any other strategy for nutrition of these patients? Okay, so we can move on, and I want to invite our next speaker. Thank you very much. Our next speaker is Dr. Cihangir Emral from Turkey. We talk about acute pancreatitis after pancreatic duodenectomy.
I would like to thank the organizing committee for the kind invitation and the opportunity to speak on this topic. Today, I will present an overview of post-pancreatic acute pancreatitis, PPAP, focusing on its clinical outcomes and predictive factors. I will first review the definition and diagnostic criteria of PPAP. I will focus on its clinical significance and risk factors. Finally, I will summarize the current approach of the management. Although postoperative pancreatic fistula has a clinical entity, it's an independent clinical entity, and it's defined ICGPS, International Study Group of Pancreatic Surgery, in 2021. And post-pancreatectomy acute pancreatitis has been recognized as a distinct complication following partial pancreatectomy according to the ICGPS. The underlying pathophysiological process is thought to represent a localized inflammatory and ischemic response within the remnant pancreas tissue. Operative manipulation and mobilization, alterations in blood flow, pancreatic fluid stasis may result acinar cell injury, and this causes the protease enzymes activation, and then parenchymal edema and peripancreatic inflammation occurs. Accordingly, intraabdominal abscess infections, systemic inflammatory response syndrome, and sepsis may develop even in absence of postoperative pancreatic fistula. The ICGPS defines PPAP, an acute inflammatory condition of the pancreatic remnant developing after partial pancreatic resection and initiated during the early phase of the perioperative period within the first third postoperative days. In the consensus, distinguish benign postoperative hyperamylasemia from clinical relevant PPAP. For diagnosis, serum amylase activity exceeding the institutional upper limit of normal and persisting for at least 48 hours postoperatively required. To be classified as PPAP, this condition must be confirmed by radiological imaging, and as with other ICGPS definition, must have clinical relevant consequences for the patient. PPAP represents an inflammatory process affecting clinical outcomes and should be differentiated from the non-surgical etiologies as well as obstructive late-onset pancreatitis. The pain was not incorporated into diagnosis criteria because the clinical presentation of PPAP may be masked by postoperative analgesia. Clinical manifestation of PPAP were not specifically defined in the consensus report. Here we see the classification and grading of PPAP. For the grade B, hyperamylasemia persisting for 48 hours, accompanied by clinical deterioration and radiological anomalies, commonly associated with systemic inflammatory response syndrome, intraabdominal infection abscess, post-pancreatectomy hemorrhage, and postoperative pancreatic fistula. Management requires therapeutic interventions such as antibiotics, steroids, nutrition support, endoscopic procedures, intervention radiology. In grade C, in addition to grade B, PPAP characterized by organ failure lasting 48 hours, extensive necrosis, frequent need for reoperation. This group is associated with highest mortality. Following the pancreatectomy, the reduction in pancreatic parenchymal volume and presence of fibrotic conditions may lead to relatively lower enzyme levels. Therefore, persistent hyperamylasemia during the first 48 postoperative hours assessed through serial measurement is considered more discriminative than single measurement. The typical biochemical profile demonstrates a peak on the postoperative day 1, followed by a decline beginning on the postoperative day 2 and normalization by the postoperative day 3 to 5. Although elevated C-reactive proteins levels may correlate with morbidity, their diagnostic and predictive values has been inconsistent. Therefore, CRP levels was not incorporated in the ICGPS criteria. Imaging findings also peripancreatic edema, fluid collections, and maybe sometimes necrosis, especially in the grade C grade, and typically involving the pancreatic remnant. Patients with radiological evidence PPAP demonstrate increased postoperative morbidity, and nearly all such radiological anomalies have been observed in the presence of concomitant hyperamylasemia. PPAP is strongly associated with major postoperative morbidity. Multiple studies have identified PPAP as an independent risk factor for postoperative pancreatic fistula, with the reported coexistence rate of PPAP and POPF, postoperative pancreatic fistula, is ranging from the 25% to 41%. Furthermore, PPAP has been associated with the increased incidence of post-pancreatectomy hemorrhage, intra-abdominal abscess, infections, delayed gastric empty, sepsis, and laparotomies. In study et al., including pancreatitis patients assessed using ICGPS criteria, the instance of grade BC PPAP was 28%. In PPAP group, major pancreatic specific complication rates were 92% compared with 23% of non-PPA patients. And the most common radiological finding in this study were the peripancreatic fluid collection. High acinar cell density score, soft pancreatic texture, elevated body mass index, and fistula risk score bigger than 3 have been identified as risk factors associated with PPAP. In contrast, pancreatic adenocarcinoma, malignancies, chronic pancreatitis, and neoadjuvant therapy have been associated with lower instance of PPAP. And differences in PPAP characters between pancreatodonectomy and distal pancreatectomy have been also emphasized. Anatomical and surgical factors, as well as differences in postoperative physiological burden, may underline these variations. All the evidence remains limited. PPAP following distal pancreatectomy appears to occur less frequently, but may follow a more severe clinical course. CT is recommended in these cases of clinical deterioration, usually between postoperative day 5 to 15. Earlier or later imaging may be misleading. No specific prophylactic or therapeutic strategy for PPAP has not been defined. Re-evaluation of ERAS principles, antibiotic therapy, drain management protocols should be evaluated. Thank you.
Thank you for your talk. And is there any question from the floor before lunch break? Yes, Professor Can. Could you please make it short because we are quite behind the schedule? Could you please make it quick because we are quite behind from the schedule?
Really? Okay.
Yes, really.
What do you think? Thank you for your presentation. What do you think about the use of stenting? Is stenting preventable for this post-pancreatectomy acute pancreatitis? Using stents during pancreatic jejunostomy, is that preventable or a risk factor for post-pancreatectomy acute pancreatitis?
In one study, I saw using stents for PPA. Actually, in this pathophysiology, the main problem for PPAP is the blood circulation deterioration. So using stents in one study, they say using stent is not effective for PPAP because it's not causing the deterioration of the blood circulation. Because of the acinar cells damaged and protease enzymes activity increase, because of that, pancreatic edema happens, then this cause of the PPAP. So they defend this stent does not increase.
I have an argument on this. If you have a very long tip of stent going very deep into the Wirsung, to the tail.
Professor Can, you mean ERCP stent, right?
A stent of any kind.
Any kind.
If you put a stent very long, going into the deep in the Wirsung to the tail of the pancreas.
During surgery stent. Okay.
During anastomosis. It's a risk factor for postoperative pancreatitis.
Actually, this is a extreme example, I think, because we don't use normally during the surgery stents long as you described.
I have seen 2 cases causing severe pancreatitis.
Okay. In our clinic, we don't use these type of long stents during surgery.
So Fatih,
In our
sorry, Mr. President.
clinical practice.
Okay, all right.
Sorry.
That's okay.
I agree some issues for Fatih. If you do more catheterization or more, how to say, insert to the versum, reasons to do pancreatitis. If you use the pancreatic stenting, short and teeny, less than Virsung. It is important issue. This is a technical issue. Otherwise, it is not the protective to pancreatectomy, postoperative pancreatitis.
Thank you for your comment. And I just wanted to ask a question to Professor Can and Professor Kerem as well, of our speaker. Do you succeed to convince your gastroenterologist not to put any stent before surgery if there is not any cholangitis? Because as far as I saw, one of the most leading cause of postoperative acute pancreatitis or cholangitis is preoperative stenting or persistent stenting attempts. If there is any distal occlusion and if they insist to put in a stent, they are creating some cholangitis as something. Maybe it may cause acute pancreatitis rather than preventable pancreatitis and cholangitis. That's why I asked if your stent is a perioperative or ERCP.
Totally agree with you. The ERCP stenting, pancreatic stenting is really a problem. You know, one study from Japan, the prophylaxis for distal pancreatectomy and pancreatic fistula, preoperatively endoscopic stenting. This group is more has pancreatic fistula, ERCP group. So it is really problem for the pancreatic fistula and the post-pancreatic pancreatitis, preoperative pancreatic stenting. Agree with you.
I believe preoperative stenting by ERCP cause everything, cause several diverse problems, not only pancreatitis, not only pancreatic fistula, but the infection. You know, if we have a colloidal stent put by ERCP, we need the risk of postoperative severe infection is as high as twice as compared to, you know, without patients without stenting. So it's a big problem.
Okay.
Yeah.
Yes, Dayan.
Just short comment. Why we are talking about stenting? Because we put stents only when we have to. Otherwise, we will not put it. We have to put, if we are talking, but he's mainly surgeons. If gastroenterologists took patient and put stent, that's stupidity. But mainly the patients are coming to us. We put stents if bilirubin is more than 300, and otherwise we are forced to do it.
Yeah, so that's why I asked my question. Do you convince your gastroenterologist? Because it is hard to convince them not to put any stent sometimes. Yeah.
But I think that those patients are first come to surgeons, and surgeons ask for the stenting. Maybe it's different in your country.
Sometimes.
Then it's problem.
Thank you.
But in practice, in the world, in all countries, mostly if the patients go to the gastroenterologist, they do stenting, right?
But I have a comment. Beside the ERCP stenting, the stent we do during the surgery, the complication is acute pancreatitis or the complication is using long stents. So why do you use long stents?
Personally, I don't use a long stent, but accidentally.
Okay. Accidentally. It can be, of course. It may occlude all the duct in very small duct, so it can cause pancreatitis, of course. But in real life, we have not used.
We don't use long.
We don't have to use long stents during surgery. Thank you. Thank you very much. It's time for the lunch, please. Thank you very much.
Thank you, everyone, for your comments. And
Can you hear me? Yeah. Hello again. Can I have a mouse pad or something? I don't have any mouse. The first speaker bailed on us, so you're stuck with me again. Once again, thank you for the kind invitation to the organizing committee and the society. Thank you. So I'm going to be talking about the expanding role of local regional therapies in HCC beyond bridging and downstaging. I have nothing of conflict of interest. So these are the all interventional radiologic treatments that we offer. For our young generation, I'd like to go on over them. We call them local regional treatments. When we say local, it's more the ablative treatments. And when we say regional, it's more the intra-arterial or combination treatments. So as you all know, the basic principles of all liver treatments, surgery, us, or anything, depends on the ability of liver to regenerate. We know this since Prometheus. He was bounded to a rock, and by Zeus, he was punished. An eagle came over and ate his liver, and the next day the liver started to regenerate. Surgical techniques, our techniques are all based on these principles. First of all, the IR treatments that were introduced. The first oncologic treatment was percutaneous ethanol injection. It was done by Tito Livraraghi, an Italian group. Afterwards, this group invented the RFA and continued with them. However, intra-arterial treatments were defined by the Easterns, by Japanese, Yokudo, which was actually laparoidal-based TACE. I'm going to shortly mention the role of IR in downstaging and bridging, such as a lesion of 8.5 centimeters out of Milan, reduced by 190 into 3.5 centimeters, or a lesion, a singular HCC lesion in a cirrhotic woman waiting for transplant, which was bridged with TACE and necrosed into an unenhancing. Do I have a pointer? Yeah, okay. Into an unenhancing lesion, and then transplanted, obviously, by this guy. This is so no brainer, huh? So everybody is sure about the role of IR in downstaging and transplants. I'm going to skip this right away. Okay. So what's happening right now? There is a paradigm shift in HCC management beyond transplant, beyond downstaging, and beyond bridging. What is happening? Back in the days, you guys were just operating, and we were doing our best with TACE, and there was no chemo for HCC. And however, eventually HCC showed its many faces. I like to think of it as a multi-personality disorder, or maybe it took us this long to understand HCC. Well, question mark, do we really still understand all of it? No. But things changed. Now it is understood that it's a multifactorial disease. It's complex. It's not unified. There are some subjectivities, some other emotional stuff going on. So from 2020 to 2026, the underlying disease changed. Hepatitis versus metabolic syndrome, decompensated cirrhosis, surgical approaches. You guys are now doing MILS, minimal invasive liver surgeries. Tumor biology kicked in, oncology kicked in, big pharma is there. No one can compete with big pharma, right? And obviously our techniques has also evolved. Once we were blinded, now we became snipers, and we offer better interventional radiology techniques, individualized approaches, and also it's not solely us. We combine them with you guys, with oncology, with many stuff. I'm going to talk about them shortly. So the once being a single diagram with single arrows, do this, do that, and go that, turn into this complex diagram where there is no single one-way side. You have to go back and forward and back and forward, up and down, which is called, regarding to Barcelona 2026 update, the Q's approach. It comes from the complexity, uncertainty, subjectivity, and emotion. Or another very good paper approaching it is the personalized management, defining it as a multidisciplinary hierarchic treatment approach regarding individualized treatment. Again, there is no one-way shortcut. you have to go up and down and right and left, which all of these guidelines tell us the treatment pathways is interchangeable. So this is the same for us too. Once the first slide I showed you as like local and regional therapies. Now we define them as curative intent and palliative intent. And no longer we use the term local or regional, because once I just told you that local treatments were called ablative treatments mostly. Now we can offer ablative treatments even in regional areas. So don't think that all of them are the same, okay? You know, you guys come in the MDTs, this patient was TAST. Okay, what TAST? So I'm going to show you. We have so many TASTs right now. This patient had Y90 treatment. How was it treated? Was it a single dosimetry? Was it individualized dosimetry? These are all now different from each other. So I need you to understand that when an IR approach is done, please ask your IR what exactly they did, okay? So starting with the curative intent, the ablative methods. Now, the most important thing you need to know, RFA is dead now. We no longer use RFA. It's microwave ablation. Many studies have showed it. And I'm going to show you some studies that we are now ablating betterly and combining TACE and different techniques of TACE to have better ablation margins, just like your R0 resection margins. And one other concept is Y90 segmentectomy, which I can ablate a whole segment or a whole tumor or even a whole lobe with just giving radiation. This comes from these trials. One of them is the SURF randomized control trial. This trial showed that this is an old trial, but this is the new interim data showing that RFA versus surgery in small lesions showed no different local recurrence rates. Another new trial was a trial for microwave ablation for lesions smaller than 4 centimeters. This trial also showed us the local tumor progression is lower in microwave ablation than RFA. Another trial, the marathon trial, this was represented in last year in our International Oncology Congress. They are now analyzing the latest data, and I think it's going to be published in a month or two. They checked the lesions which were ablated with microwave smaller than 3 centimeters, and they try to figure out the underlying factors for local tumor progression. What they did, they found that the most important factor was the distance from the vessel, the distance of the lesion from the vessel. And then this led to another trial that shows us the importance of margins. Just as I said, just like you guys, R0 resection is now A0 ablation for us. And now the coverall trial is here, and they also showed the margins are the most important thing. So regarding these trials, we invented new techniques. We invented better ablation methods. One of them is ablating a segment, combining it with TACE and balloon TACE. The logic is we are ablating the lesion, yeah, but when you're doing TACE, you're giving extra and an ischemic component. With balloon TACE, because you change the perfusion, the ischemic component is enhanced and provides you a better margin afterwards. Here's an example. A patient treated with microwave and balloon TACE. This is the example of the balloon TACE. Normally, you see the enhancing lesion here, but when you inflate the balloon, because you change the perfusion, because this area is ischemic, all the blood vessels will try to fill this lesion because the lesion wants to live, right? Okay. When you inflate the balloon and start doing TACE, normally it would have uptake the microspheres or whatever you're using. like this, but when you're inflating the balloon, the perfusion pressure will make the microspheres expand into the lesion and even into the portal vein area. This is one technique we are using right now. Another example is Y90 segmentectomy. Well, this at first we were so blind, we had no idea. We were just giving the Y90 a lower dose, a whole liver dose. Then the studies showed us the most important thing is the dose delivered to the lesion. And the most important thing when you're talking about palliative treatments is the parenchyma reserved without radiation. So now we got we became snipers. These are the studies that showed the importance of individualized dosimetry. Now we are going super selectively. Here is a big segment 4 lesion, 85 years old male. He didn't want to have surgery, and he had also many comorbidities. This is the pure selective uptake of the Y90, and this is the first month follow-up. No enhancing lesion. Another example, again, 79-year-old male, a segment 4 lesion. Here in the angio, we can find them. This is the first day Y90 uptake. So here you can see the rest of the liver is preserved. Only the dose is delivered into the segment. This dose I'm talking about 400 gray in glass microspheres and 200 gray in resin microspheres. And this is the post-op imaging. See, it's all burned out. Okay, this is just like you guys doing segmentectomy. Another patient, this was a palliative lesion. This was done in palliative intent. Hold on. Again, Y90 post radiomessage. Sorry, I didn't forget to change the language. As you can see, all we do is we try to give it to the tumor, the whole dose into the tumor, trying to preserve the normal parenchyma. This was done in palliative intent, obviously, because it was too big. But then this patient survived like for 4 years, not expected for this type of lesion. And look at the AFP. Okay, it's all gone here. There is no there is no parenchyma here because of the radiation. These ones I'm not going to go into because time restrictions. Okay, in palliative intent this time, things are again changing because of immuno-oncology. Okay, now we have the concept of tasteability. Previously, we were doing the same taste as lobar treatments, going into the right hepatic artery, giving everything what we have. But then we understood that as long as we keep the feeder of the lesion, we can come back again and do the taste again. What has showed us this is the combination therapies with immunotherapy. So we give the immunotherapy, we do a taste, we do another immunotherapy, we do a taste. As long as I have that vessel, as long as I preserve that vessel, I can repeat the taste in combinations with other therapies. Another concept, again, regarding tasteability is the concept of biodegradable embospheres. All the previous taste molecules, depth taste, the pyridal taste, they are permanent. And now we have the new concept of biodegradable embospheres, and also, hold on. Here's an example. These are melted down by amylase or in 6 weeks by body's normal resorption mechanisms. Here's an example. This is the first session. Here you can see the lesion up there. And then 6 weeks later, we came back and the vessel is here again. So we have the segmental vessel. So as long as I keep this, my only goal is to embolize the tumor, not the feeding hepatic vessel, I can come back and do another TACE procedure. So, however, sadly, I have no quick solution for you guys. If you have this, go that, go and have this and go that, because this is, as I told you, it's about HCC. It's a multi-personality disorder. We will never, I really don't have the belief that we will understand it eventually, like in every aspect. But the paradigm shift in every discipline is real, and stage migration is real. So it's not a one-way street. It's going back, forward, right, left, up and down. Teamwork is essential. Teamwork is dreamwork. Always remember that. And thank you.
Thank you, Professor Eldem, for this extensive talk. I would like to start with a question.
Yeah.
As you mentioned, the latest BCLC mentions cues which involves complexity, uncertainty, and we know that HCC is a heterogeneous group. Lately, TACE has been less favored and TARE is becoming more popular. And we know that some lesions are refractory to the treatment, and sometimes we end up with a patient who is child B7, 8 and gets decompensated and cannot be transplanted later on. In your experience, do you have a protocol or a sense that certain patients, because we increasingly use local regional therapies more and more, do you think there are certain groups maybe that you focus on, such as kinetics, AFP level, patient age, that you think local regional therapy will not be very useful?
You mean the whole local regional therapy or TARE versus TACE?
Especially TACE versus TARE,
Okay.
yes.
This data comes from downstaging and bridging in transplant. And we know that TARE, radioembolization Y90, has a longer TTP, time to progression interval. So as long as it's a singular lesion, and BCLC, the new BCLC also offers that in lesions smaller than 8 centimeter, TARE is an option because it has a longer TTP timeline. We know this from the transplant data. In my experience in my university, in a singular HCC lesion, I will always prefer TARE over TACE. But now we have the biodegradables. And in private sector, in Eastern, they don't have Y90, so you need something to come up with. Okay, in that cases you can do TACE. Regarding overall survival, there is no study between TARE versus TACE that TARE is better than TACE regarding overall survival. But regarding TTP, which is a thing in transplant, that's important. So regarding nothing. No local regional treatment will be the function of the liver. But again, now the biodegradables, they offer you treatment for patients with lower albumin levels, patients with higher bilirubin levels, because they will open up, the channel will open up. And again, for advanced stage HCCs with portal vein invasion, normally, at the back days, we were not doing TACE when we had main portal vein occlusions with thrombi, but now we can do it. But there's no, sadly, I cannot give an equation like I go this and I go that. But we have every week we have a GI tumor board. We really seriously, one by one, every patient is discussed there, and every patient comes back there regarding the treatment answer. So it's like that for me.
Thank you. So we are quite far away from, just like you said, radio frequency ablation is dead now. Microwave is, we are quite far away from it for TACE versus TARE.
It's dead. Don't even mention RFA. Don't use the word radio.
Okay, thank you.
Use the word micro.
Do we have any other questions from the audience?
Yes, I have.
Please
Dear
go ahead.
Professor, thank you for your advanced lecture. It's very interesting. I have some diagnostic questions. And how you how you differentiate between malignant cancer, between hyperplasia, because the contrast enhancing MRI same. How you distinguish this? My first question.
For HCC, it's very easy. You need a primovist, gadovist enhanced MRI. If you don't have it, you need a three-phasic liver protocol CT. Obviously, we have some lesions that we stay in between, But now oncology wants to biopsy all of them because of immunotherapy. That you can also do that. But back in the days when I was a resident, biopsy was not an issue because we were able to diagnose it with an MRI. But if you're treating liver malignancies, primary or metastatic, doesn't matter. I would suggest to all of you that you use MRI because the division rated imaging will show you something else. Primovist will show you something else. It will show you the function of the liver. The late phases will show you the function of the liver. It will show you the fat ingredient of the liver when you're dealing with resection. It can also be a colorectal metastasis. It will undergo resection. So in our university, MRI is the baseline always.
Or if you want to do for patient TACE or some other procedure, you would do it after MRI, or you would do biopsy and then.
For me, it's MRI is enough. But sometimes if I'm going to combine it with some immunologic or oncologic treatments, then because we discussed it in the GI tumor board, then oncology wants us to do a biopsy. So we do the MRI, biopsy, taste it. I biopsy at the same time, so easy for us. But I don't need to, for me, I don't need the biopsy to diagnose a lesion as an HCC. It's very typical, arterial enhancement, early washout, and at late phase images, hypointense MRI lesion, it's an HCC.
One more question I have. After transplantation, how you control the patient? After liver transplantation, how you control the patient with diagnostic issue?
Again, MRI, our surgeons like to do MRI.
After transplantation, in which day you will do MRI?
That's actually a question for our transplant surgeons. I know, maybe. They don't do it routinely, even directly, but it's after transplant, right? Not downstaging or bridging. Okay. After that, I think it's like 3, 6, 12. We go like
6, 12.
Again, MRI.
First days is ultrasound, yes?
Not the first days. If they don't have any operative complications, they don't need imaging. We do imaging for portal vein or hepatic arterial flow, a Doppler imaging. But regarding the anastomosis and that's regarding the technique, not for the lesions.
No, I'm asking after transplantation, which diagnostics should be the first day, second day after transplantation? Ultrasound and then
ultrasound is a fix. Actually, we do intraoperative ultrasound when they anastomose the hepatic artery and everything. Intraoperatively, we check the flow of the hepatic artery, but we don't do it for the transplanted liver parenchyma. Okay, and next day and 1 week, the modality, I think you're asking about me that, not the lesions, right? Your modality is a Doppler ultrasound, okay, for anastomosis.
Thank you.
Thank you.
Thank you for a nice presentation. I have a question regarding bridging in the patients in the context of liver transplantation. So as in Turkey, you mostly rely on living donors, and I guess you can plan and time your liver transplant as soon as you are ready to proceed. So I wonder whether do you need bridging at all, or do you keep the patients waiting and do bridging to see the biology of the tumor, or actually do you need bridging at all? Because in the West, of course, our patients will wait for a year or so, and they will have 2 or 3 local regional treatments to bridge them until the transplant. So what's it like in Turkey?
Regarding guidelines, if the patient is going to wait longer than 6 months, you should offer them bridging therapy. But now, because living donor transplantation has increased, and we don't do that much cadaver anymore. Those were the ones I showed. They were all cadaver transplantations. You don't need to offer if you're gonna transplant the patient next week. But again, sometimes you can convert if the AFP level is high. Maybe this is not scientific data. This is my personal experience. If your AFP level is high, maybe you can. If you lower it down, maybe if you use TACE or TARE as neoadjuvant, not bridging, we will see that. We don't have that data. But in regularly if they I think in a month they prepare the transplant at most, right?
Thank you. I think that concludes our questions. Now we move, we thank you for your great talk and discussion. Now we move to the next speaker.
Слово представляется докладчик из солнечной Грузии, то есть Джорджии, Заза Такабадзе.
Herkese merhaba. Öncelikle bugün burada konuşma fırsatını verdikleri için oturum başkanlarına ve organizasyon komitesine teşekkür etmek istiyorum. Bugün kolorecik karsinomlarda karaciğer transplantasyonunun değişen rolünü ele alacağız. Özellikle güncellenmiş indikasyonlar, modern hasta seçim kriterleri ve 2024-26 yıllar arasındaki güncel sonuçlar üzerinde duracağım. Belirtmek istiyorum ki merkezimizde kolorecik karsinom için karaciğer transplantasyonu konusunda doğrudan bir deneyimimiz yok bulunmaktadır. Bununla birlikte eksplant patolojisinde tesadüfen saptanan birkaç olgu gözlemledik olduk ve hepinize günaydın. Biz devam edeceğiz ama olduğu gibi. Rahatsız ettiğiniz için özür dilerim yani şimdi Türkçe anlatacağım için. Hepinize tekrar merhaba. Öncelikle bugün burada konuşma fırsatı verdikleri için oturum başkanlarına ve organizasyon komitesine teşekkür etmek istiyorum. Bugün kolorecik karsinomlarda karaciğer transplantasyonun değişen rolünü ele alacağım. Özellikle güncellenmiş indikasyonlar, modern hasta seçim kriterleri ve 2024-26 yıllar arasındaki genel sonuçlar üzerinde duracağım. Belirtmek istiyorum ki merkezimizde kolorecik karsinom için karaciğer transplantasyonu konusunda doğrudan bir deneyimimiz bulunmaktadır. Bununla birlikte eksplant patolojilerinde tesadüfen saptanan birkaç olgu gözlemledik olduk ve ne yazık ki bu hastaların sonuçları genel olarak kötüydü. Kolorecik karsinom anatomik olarak intrahepatik, perihilar ve distal olmak üzere 3 alt tipe ayrılır. Perihilar tümörler tüm olguların yaklaşık yarısını oluşturur. Karaciğer transplantasyonu açısından yalnızca perihilar ve intrahepatik kolorecik karsinomlar önem taşımaktadır. Çünkü distal tümörler cerrahi olarak pankreatodonektomi ile tedavi edilir. 1990'lı yıllarında kolorecik karsinom için karaciğer transplantasyonu sonuçların son derece kötü olması nedeniyle büyük ölçüde terk edilmiştir. Neoadjuvan tedavi uygulanmaksızın nüks oranları %50'nin üzerinde seyretmiştir ve 5 yıllık sağ kalım ise yalnızca yaklaşık %20-30 düzeylerinde kalmıştır. Ayrıca ciddi organ kıtlığı göz önünde alındığında o dönemde karaciğer transplantasyonu bu hasta grubu için haklı gösterebilecek bir tedavi seçeneği olarak değerlendirilmemiştir. 1990'lı yılların başında Mayo Klinik'te önemli bir dönüm noktası yaşanmıştır. Mayo ekibi rezeki edilmeyen perihilar kolorecik karsinomu dikkatle seçilmiş hastalar için neoadjuvant kemoradyoterapi, evreleme cerrahisi ve karaciğer transplantasyonu birleştiren yapılandırılmış bir tedavi protokolünü geliştirmiştir. Bu yaklaşım sağ kalım sonuçlarında çarpıcı bir iyileşme sağlamıştır. 2024-26 yılları arasında kolorecik karsinom için karaciğer transplantasyonu yeni bir döneme girmiştir. Uluslararası uzlaşı önerisi rezeki edilmeyen intrahepatik kolorecik karsinom için OBTN UNOS MMAT3 istisna puanlandırılmış uygulamaya girmesi ve giderek artan sayıda prospektif çalışmaların yayınlanması bu alanı önemli ölçüde dönüştürmüştür. Günümüzde odak noktası tümörün anatomik yerleştirilmesinden çok tümör biyolojisine kaymaktadır. Artık temel soru bu hastalara transplantasyon yapılabilir mi değil, hangi hastalar transplantasyondan en fazla fayda görecektir diye sorusudur. Perihiller kolangiokarsinom için Mayo klinik protokolü, Mayo protokolü eş zamanlı 5 fluorourasil ile uygulanan external eşin radyoterapisini, ardından intraluminal brachioterapi ve transplantasyona kadar sürdürebilen idame kapasitabin tedavisini içermektedir. Transplantasyon öncesinde ise tüm hastalarda lenf nodu tutulumu veya peritoneal yayılımı dışlamak amacıyla cerrahi evreleme operatif staging uygulanmaktadır. Perihiller kolangiokarsinom için uygunluk kriterleri bakıldığında hasta seçim kriterleri son derece katıdır. Genel olarak tümörün 3 santimden küçük olması, sistik kanalının proksimalinde yerleşmesi ve metastatik hastalık ya da lenf nodu tutulumunun bulunması gerekmektedir. Önemli bir nokta olarak önceden yapılmış transperitoneal biyopsi tümörün ekimi riskinin yüksek olması nedeniyle mutlak kontraindikasyon kabul edilmektedir. Sonuçlara bakıldığında Mayo Klinik'ten elde edilen güncel veriler uzun dönem sonuçların oldukça başarılı olduğunu göstermektedir. Niyet edilen tedaviye göre intention to treat analizlerinde 5 yıllık genel sağ kalım oranı artık %50'nin üzerinde çıkmıştır. Daha da önemlisi dikkatle seçilmiş hastalarda transplantasyon sonrası 5 yıllık sağ kalım oranı %70'e kadar ulaşabilmektedir. Bu sonuçlar uygun hasta seçimi ve standartlaştırılmış neoadjuvan tedavi protokolleri uygulandığında karaciğer transplantasyonunun perihiller kolangiokarsinom için etkili bir tedavi seçeneği olabileceğini göstermektedir. Ancak tüm hastalar transplantasyondan eşit derecede fayda görmemektedir. Yüksek CA19-9 düzeyleri, daha büyük tümör boyutu, pozitif patolojik bulgular ve yüksek MER skorları bekleme listesinde hastanın transplantasyona ulaşmadan kaybettiğini riskini artıran faktörlerdir. Buna karşılık rezidüel tümör varlığı, peritoneal invazyonu, ortal ven tutulumu veya yüksek CA19-9 düzeyleri transplantasyon sonrası NUCS için önemli öngörücülerdir. Bu bulgular transplant onkolojisinin temel prensibinden birini bir kez daha vurgulamaktadır. Önemli olan tümörün nerede olduğu değil, nasıl davrandığıdır. Yani başka deyişle tümör biyolojisi anatomiden daha önemlidir. Primer sklozan kolangit ile ilişkili perihiller kolangiokarsinomlu hastalar gelişen tümörlere sahip hastalara kıyasla tutarlı olacak daha iyi sonuçlar göstermektedir. Bu üstün sonuçların muhtemelen daha erken tanı, daha küçük tümör boyutu ve farklı tümör biyolojisiyle ilişkili olduğu düşünülmektedir. Amerika Birleşik Devletleri'nde çok merkezi doğrulama çalışmalarının ardından perihiller kolangiokarsinom için standartlaştırılmış MERD istisna puanları uygulamaya konulmuştur. Daha yakın zamanda ise rezeke edilemeyen intrahepatik kolangiokarsinom da OVPT'in istisna sistemine dahil edilmiştir. Bu gelişme uygun şekilde seçilmiş intrahepatik kolangiokarsinomlu hastalarda karaciğer transplantasyonunun giderek daha fazla kabul gördüğü yansıtmaktadır. İntrahepatik kolangiokarsinom tarihsel olarak karaciğer transplantasyonu için bir kontraindikasyon olarak kabul edilmiştir. Çünkü erken dönem çalışmalarda düşük sağ kalım oranları ve son derecede yüksek NUCS oranları bildirilmiştir. Çok erken evre intrahepatik kolangiokarsinomlar bakıldığında intrahepatik kolangiokarsinom için karaciğer transplantasyonuna olan ilgi Sapichotin ve çalışma arkadaşlarının sirotik hastalarda 2 santim veya daha küçük soliter tümörlerde transplantasyon sonrası olumlu sonuçlar bildirmesiyle yeniden canlanmıştır. Bu hasta grubunda elde edilen sağ kalım oranları hepatosülür karsinom için bildirilen sonuçlarla karşılaştırılabilir düzeyindeydi ve 5 yıllık nuksuz sağ kalım oranları %82'ye kadar ulaşabilmiştir. Bu bulgular dikkatle seçilmiş erken evreinde hepatik kolangiokarsinom hastalarda karaciğer transplantasyonunun uygulanabilir ve etkili bir tedavi seçeneği olabileceği göstermiştir. Lokal ileri evre intrahepatik kolangiokarsinomlara bakıldığında bu modern seriler beklenenden çok daha umut verici sonuçlar ortaya koymuştur. Çalışmalarda 5 yıllık genel sağ kalım olanları yaklaşık %57 ile %80 üzerinde bildirilmiştir. Bununla birlikte NUKS oranları halen nispeten yüksek olmaya devam etmektedir. Dolayısıyla sağ kalım sonuçları belirgin şekilde iyileşmiş olsa da hastalık NUKS'u intrahepatik kolangiokarsinomlar için karaciğer transplantasyonunun önündeki başlıca zorluklardan biri olmaya sürdürülmektedir. Tesla çalışması intrahepatik kolangiokarsinom için karaciğer transplantasyonunun sınırlarını genişletmektedir. Bu çalışmada median tumor boyutu 11,5 santim olması ve hastalarda birden fazla lezyon bulunmasına rağmen transplantasyon uygulanan tüm hastaların erken takip döneminde hayatta olduğu bildirilmiştir. Bu sonuçlar tumor yükünün tek başına belirleyici olmayabileceğini ve buna karşılık tumor biyolojisinin hasta sonuçlarının öngörmede çok daha önemli bir rol oynayabileceğini düşündürmektedir. Bu başlıca deyişle transplantasyon açısından ne kadar tumor olduğundan çok tumorun nasıl davrandığı önem kazanmaktadır. Moleküler profillenme ve dolaşımdaki tumor DNA'sı hasta seçimi NUKS riskinin öngörülmesiyle kişileştirilmiş tedavi stratejinin geliştirilmesi açısından umut verici araç olarak öne çıkmaktadır. Bu teknolojiler tumor biyolojisinin daha iyi anlaşmasının sağlayarak transplantasyondan en fazla fayda görecek hastaların belirlemesinde ve transplantasyon sonrası NUKS riskinin daha doğru tahmin edilmesine katkıda bulunabilir. Dolayısıyla gelecekte moleküler belirticilerin ve ctDNA analizlerinin kolangiokarsinomlarda karaciğer transplantasyonu için hasta seçim süreçlerinin ayrılmaz bir parçası haline gelmesi beklenmektedir. Canlı verici karaciğer transplantasyonu özellikle bekleme süresinin uzun olduğu bölgelerde giderek daha önemli bir seçenek haline gelmiştir. Primer sklerozan kolangit ile ilişkili perihiler kolangiokarsinomu hastalarda canlı vericili transplantasyon sonuçları genel olarak kadavra verici transplantasyon sonuçlarıyla karşılaştırılabilir düzeyindedir. Bu nedenle uygun donorun mevcut olduğu durumlarda canlı vericili karaciğer transplantasyonu bekleme listesindeki kayıpları azaltabilecek ve hastaların transplantasyona zamanında ulaşmasını sağlayabilecek önemli bir alternatif olarak değerlendirilmektedir. Malignite nedeniyle yapılan canlı vericili karaciğer transplantasyonlarda etik kaygılar halen temel bir önem taşımaktadır. Güncel uzlaşı raporları beklenen 5 yıllık sağ kalım oranının yaklaşık %50'nin üzerinde olduğu ve titiz hasta seçimi protokollerinin uygulandığı durumlarda canlı verici karaciğer transplantasyonu desteklemektedir. Bu yaklaşım hem alıcının beklenen faydasını hem en üst düzeyde çıkarmaya hem sağlıklı bir donorun maruz kaldığı risklerini etik açıdan haklı kılmaya amaçlamaktadır. Son çalışmalar modern transplantasyon protokollerinin verihiler hastalıkta 5 yıllık sağ kalım oranları %50 ile %65 arasında tutarlı şekilde sağlayabildiğini göstermektedir. Ayrıca dikkatli seçilmiş intrahepatik kolangiokarsinom olgularında bu oranların daha da yüksek değerlere ulaşabildiği bildirilmektedir. Bu veriler uygun hasta seçimi ve standartlaştırılmış tedavi yaklaşımları ile karaciğer transplantasyonunun kolangiokarsinomlarda giderek daha öngörülebilir ve etkili bir tedavi seçeneği haline geldiği desteklemektedir. Sağ kalım sonuçlarındaki iyileşmeye rağmen NUCS halen önemli bir sorun olmaya devam etmektedir. NUCS'lerin çoğu sistemik karakterdedir ve genellikle akciğer, periton veya kemik gibi uzak organları tutar. Buna karşılık karaciğer greftinin kendisine NUCS daha az görülmektedir. Bu durum hastalığın biyolojisinin transplant sonrası bile sistemik yayılım potansiyeline sahip olduğunu ve bu nedenle yalnızca lokal kontrolün yeterli olmadığını göstermektedir. Güncel tartışmalar bakıldığında intrahepatik kolangiokarsinomların standart bir transplantasyon indikasyonu olup olmamasını halen tartışmalıdır. Sağ kalım sonuçları umut verici olmakla birlikte ve UPTN tarafından tanınması bu yaklaşım desteklese de yüksek NUCS oranları ve sınırlı kanıt düzeyi nedeniyle karaciğer transplantasyonu yalnızca iyi seçilmiş hastalarda ve standartlaştırılmış protokoller çerçevesinde uygulamaya devam etmektedir. Alan giderek anatomik temelli seçiminden biyoloji temeli seçime doğru ilerlemektedir. Tumor biyolojisi, tedavi yanıtı ve moleküler özellikler artık yalnızca tumor boyutundan çok daha önemli bir hale gelmektedir. Bu yaklaşım transplantasyon için uygun hastaların daha doğru belirlenmesini ve uzun dönem sonuçlarının iyileştirilmesini amaçlamaktadır. Sonuç olarak kolangiokarsinomda karaciğer transplantasyonu zaman içinde bir kontraindikasyondan dikkatle seçilmiş bir tedavi seçeneğine dönüşmüştür. Hem perihiler kolangiokarsinom hem de intrahepatik kolangiokarsinom için başarının temel belirleyici sıkı multidisipliner değerlendirilmesi ve neoadjuvant tedaviye verilen yanıttır. Sonuçta biyoloji anatomi aşmaktadır. Günümüzde ayrıca devam eden birçok önemli prospektif çalışmalar var. Tesla, Oripicola gibi. Bu araştırmacılar gelecekte kolangiokarsinomlarda transplantasyon indikasyonlarını büyük olasılıkla yeniden şekillendirecektir. Bunu dinlediğiniz için teşekkür ederim.
Вопросы к господину Зазу.
Are there any questions from the audience?
Türkçe mi sorayım?
Türkçe sorarsan.
Türkçe. Sorunuz için teşekkür ederim. Güzel bir sorumdu. Ben sadece bir şey eklemek aslında için şey yapıyorum. Bence bunlardaki esas problem cerrahi değil. Benim düşüncem. Yani tabii ki cerrahi problem ama şimdi nakil yapılan hastalar çok seçilmiş hasta grupları. Esas problem sizin söylediğiniz gibi aslında bütün konuşmalardaki bence ortak nokta tümör biyolojisini anlamak ve onu hapsetmek. Burada tabii ki kemoterapi veya immünoterapiye çok iş düşüyor. O bahsettiğiniz işte FGF, IDH, ARID1A, ondan sonra KRAS ki KRAS bunları yanlış hatırlamıyorsam %10-20 civarında bir kısmını ilgilendiriyor mutasyonlar açısından.
Evet.
Ama gelecek hani önemli olan işte bu unresectable olan hastaları resectable hale getirmek veya transplante edebilecek hale getirmek bence mevzusu. O selektif dediğimiz hasta grubunun şeyini daha fazla arttırmak, o range'i biraz daha genişletmek. Buradan aklıma şey geldi. Tabii ki aynı hasta grubu değil ama hepiniz duymuşsunuzdur. İşte bu iş en yakın zamanda bir onkoloji kongresi oldu Chicago'da, Amerika'da. Orada bir metastatik pankreas hastalarıyla alakalı. Sadece bir düşünce ben şey yapıyorum. Yani belki spekülatif bir şey ama orada metastatik pankreas hastalarında konvansiyonel kemoterapiyle işte multiselektif KRAS inhibitörlerini kıyasladılar. Sonra ciddi anlamda bir sağ kalım açısından fayda gördü bildirildi. Şimdi New England Journal of Medicine'da yayınlandı. Muhtemelen gelecek sadece onları değil herhalde kolangiokarsinomları da etkileyecektir diye düşünüyorum. Yani bunların bir grubunda çünkü KRAS'lar var. Sonrasında belki daha farklı işte mutasyonel basamaklar inhibe. Yani iş oraya doğru gidiyor. Yani bunda işte o bizim dışımızdaki kısım tedavi kısmı ne kadar daha etkili olursa bizim ağırlığımız, rolümüz bunda çok daha baskın hale gelecek diye ben düşünüyorum. Teşekkür ederim.
Ben teşekkür ederim.
Есть еще вопросы? Можно пару слов? Спасибо за хороший доклад, потому что холангиокарцинома, не просто я комментарий даю.
Окей.
Распространенный опухоль почти около 10% при гепатобилиарной зоны составляет распространенный. Поэтому раньше был средневековый один постулат, все дорога ведет Рим. Bütün yollar Rim'e aparır. Şimdi такой постулат meniyalsa все дороги ведет Турции. Bizim Türk kardeşler yaxşı çıkış elədi. Bütün yollar Türkiye gelir. Содержательный доклад. Я почему этого говорю? Потому что все красиво вступали, от души вступали, но, видите, это совершивший факт, это онкопатология гепатобилиарной зоны. Надо думать, этого есть в мире, это правило, это питание, цепочка питания. А медицина тоже есть цепочка этого развития заболевания. Надо нам этого этиологии, первопричинные вопросы надо решать. Потому что, которые все красиво оперируют этого холестектомия, делают дренирование желчевыводящих путей, эндоскопический ретроградный панкреата, холангиография делает, стентирование делает, они приведет, в конце концов, стеноза, склероза этого Халедоха, это по механической теории, по онкологии, они приведут к онкопатологии. Поэтому первоначальные причины это какие? Которые мы сказали, медицинская процедура, потом это цирроз печени, который здесь Мирослав Стажанович немножко намекнул, и потом это желтуха, который осложнение, потом это питание, потому что сейчас доказано в последнее время много встреч активной добавкой, потом это питание, экология, они тоже приводят к этого онкопатологии. Видите, причины у нас этого начала 20 века в Советском Союзе был министр здравоохранения Семашко. Семашко был один постулат, прежде всего этого проводить профилактику, чем лечение. Если мы профилактику не будем делать, видео, который докладывал, это красивый доклад, трансплантация не всем доступна, который до этого докладывал американский выпускает препарат, тоже недоступно. Эта трансплантация недоступна для всех больных. После трансплантации антидепрессанты, статики надо применять, гормональные препараты, они тоже приведет к этого подавлению иммунитета больных. То есть это такой-то сложный проблем, поэтому мне казалось, что этого сначала можно начинать этого, то есть добавлять сюда, это первоначальные причины, там какие-то профилактики проводить, там здесь сидит это начинающие врачи, студенты, даже сейчас такой тенденция, даже анамнез неправильно, достаточно не собирает, даже у нас этого Казахстана есть река берет этого, Иртыш берет бассейн из Сибири, есть там сибирские двузгузки, то есть это ленточные этого гельминты, паразиты, они паразитируют желчевыводящие путей, приводят этого к рак печени, рак этого холедаха. То есть этого пресноводные рыбы используют люди, термически не обрабатывают. То есть, видите, причины есть не устранят. Это которые доклад, все красивые доклады, все души вложили, все от души докладывали. Но этого, видите, затратный там этого. Поэтому, мне кажется, немножко этого надо выделять этого этиологии этого заболевания. Потому что, видите, это который это операция тоже этого почти это трудоемкий, там много времени отнимает. Даже у нас встречается после резекции панкреаса больные проходят, через который до этого Амира, по-моему, докладывал, аэрозивное кровотечение там начинается, потом анастомозит, несостоятельность анастомозит, потом больных мы отправляем, где оперировали, они назад не забирают больного. То есть больной в течение сутки выживаемость, это пятилетняя выживаемость, это может быть 2, 3, 4%, у кого возможность есть, большинство погибает. Поэтому, мне кажется, надо выключать этого первоначальные, которые причины, устранять причины. Если устранять причины, потом осложнений такой не было бы. Видите, это нам недоступно. Допустим, в обычных больницах, стационарах, там доклад красивый. Они, видите, по научно где-то исследовать центра проводит лекарства, препараты. Также у нас панкреат там поступает. Иногда антиферментный препарат найти невозможно там. То есть это сложный процесс. Поэтому на будущем может этого какой-то там уделять внимание к этому. Спасибо. Рахмет. Еще, извиняюсь, Казахстан, казахов есть этого поджелудочная железа, вы знаете, как переводится, юфудази, спящий орган. Это сравнивать с медведем. Медведя нельзя раздражать. Если раздражать, он не только она уничтожает окружение, сам себе. Поэтому, видите, это все органы гепатобилиарной зоны, да, печень, там, селезенка, селезенка немножко далековаты, это подделка железы, они даже имплантационный опухоль распространяются, поэтому это подделка железы где-то 80-100 грамм, он не любит раздражение, поэтому алкоголь, который я сказал, биодобавка, это все приводит к этому, поэтому мне кажется, этого все стороны надо смотреть. Спасибо за внимание.
Okay. Now I would kindly ask Mikhail Efenov from Russia, our next speaker. Thank you.
Dear Mr. Chairman, dear colleagues, it's quite difficult to move to the next presentation after so brilliant discussion, but I try. First of all, I'd like to thank the organizing committee for the opportunity to present our analysis of textbook outcome in intrahepatic cholangiocarcinoma surgery, where we used so-called independent negative predictors. What is it and how did we use it? I tried to explain during my lecture. That is the first textbook outcome, which was elaborated for personally for liver resection, open and laparoscopic. It was elaborated in multi-center study in Delphi voting, and it was proposed 7 years ago by Gorgic and his team. According to the definition, the textbook outcome is a composite measure that captures the most desirable surgical outcomes as a single indicator, which should be realized according to the rule all or nothing at once in the single patients. This definition included the following desirable outcomes like negative surgical margin, absence of intraoperative incidents, no postoperative bioleakage BOC according to the ISGLS classification, no severe morbidity, no readmission within 30 days, and no in-hospital mortality. The rate of achievement, you see, was quite high, around 70%. The reason for that was maybe the main reason was a mixed area, mixed population of patients with different kind of liver tumors. Despite the wide adoption of this model, the final rate of textbook outcome achievement ranged widely from 10 to 77%, and one of the most reasons for that, for this ranging, was different types of the tumor and different types of surgery. Now, if we looked at PubMed timelines result for the keywords combination, textbook outcome and liver resection and textbook outcome and intrahepatic cholangiocarcinoma, we can find six-fold differences in the search results, six-fold less for intrahepatic cholangiocarcinoma. That is the first model, special model for textbook outcome estimation in intrahepatic cholangiocarcinoma surgery, which also was proposed 7 years ago in multi-center study. The authors used quite strict definition of textbook outcome, and the most limiting estimated outcomes were no any postoperative morbidity and no prolonged hospital stay. That is why it was quite expectable that the rate of achievement was quite low, around 25%, but maybe there were other reasons, because one of the important thing in this study was introduction by the authors so-called clinically relevant factors, which had strong negative impact on the probability to achieve textbook outcome. So they may be called like negative predictors, negative independent predictors of textbook outcome achievement. The strongest one were bile duct resection, jaundice, neoadjuvant chemotherapy, and major hepatectomy, and the whole list of these negative predictors were inserted in the nomogram, which was proposed for individual calculation of the risk not to achieving the textbook outcome in this study. There is the next paper from the same team of authors. It was also multi-center study. 1,500 patients were included. But and you see that the rate of achievement of textbook outcome dramatically increased up to 60%. What was the reason? One of them maybe their more liberal textbook outcome definition, because no any complication were replaced by post-hepatectomy failure, and no major infection complication, and length of hospital stay was removed from this definition. But if you look at the list of negative predictors of textbook outcome, you see that you can find only 2 of them which were the same as in previous study. The third one didn't work at all, and the rest of the negative predictors were completely new. That is why the negative predictors depends largely on the series which was analyzed. That is why the relevance, it was a lot of issues as a relevance for our study. First of all, the ranging of the textbook outcome achievement, rate of textbook outcome achievement from 11 to 60%. No universally adapted textbook outcome model for ICC surgery. Textbook outcome achievement certainly depends on independent negative predictors which do not depend which do not depend from the textbook outcome structure, but really depend from the series. And we aim in our study to compare the most reasonable textbook outcome models to define which negative predictors have the strongest impact on textbook outcome achievement, and to clarify how can we use these negative predictors in order to increase the transparency of textbook outcome analysis. At that moment, when we started this study, we included 106 patients. More than half of them were treated for by liver resection only, and more than one third of patients underwent combined liver and bile duct resection. In laparoscopic approach was used mostly in liver resection only. But when we need to perform the bile duct reconstruction, we used in selected patients robotic approach, and we compare it to most validated models proposed by Gorgic and Altaf. That is quite a complex slide, but you can see the structure of these 2 models proposed by Gorgic, the blue bars, and proposed by Altaf and team in the orange bars. You can see that that rate of achievement for these 2 models was almost the same, 43% and 40%. And the most limiting estimated outcomes was major morbidity in Gorgic model and major infection morbidity in Altaf models. Maybe it's a different estimated outcomes, but the meaning almost the same. And both models included 1 resection as negative estimated outcome, which also was significant for textbook outcome non-achievement. When we compare it, that is why, let me return to the slide. That is why, despite the different estimated outcome included in the structure of these 2 models, they are quite close in the meaning, in the sense. When we compare the overall survival between patients who achieved textbook outcome with patients who did not, we didn't find any differences in overall survival, and we didn't find differences between 2 models. The same results were obtained for disease-free survival. There were no differences between TO and non-TO groups, and again between 2 models as well. That is a list of factors which differed significantly between groups of patients achieved and not achieved TO. You see that all these lists were the same for both models, and it was like a potential negative predictors. So when we performed the logistic regression analysis for textbook outcome failure, multivariate analysis confirmed the strong negative impact of 3 of them. In our study, it was tumor size more than 10 centimeters, biliarization, and open approach. That is the strongest negative predictor of the achievement. The combination of this, the predictive value for combination of these 3 factors were good for both models, almost the same plots. And at last, how can we use the independent predictor in order to increase the transparency of textbook outcome estimation. First of all, we can use it in so-called subgroup analysis. What it means, let me explain. For example, we have two independent centers with different rate of combined liver and bile deactivation. You know that bile deactivation is the strongest negative predictor of textbook outcome achievement. And if we compare the whole series without considering the difference in the rate of biliary realization, almost certainly we finally obtain the difference in the rate of textbook outcome achievement between these two centers. But if we analyze the rate, or if we compare the rate of textbook outcome achievement in subgroup analysis separately for patients who underwent liver and bile deactivation, separately from patients who underwent only liver realizations, maybe the rate of textbook outcome achievement will be the same between these two centers. That is so-called subgroup analysis. We use this concept in our last study, which was published recently in Korean HPB Surgery Journal, where we confirmed that this policy, the applying of the negative factors in subgroup analysis, increased the transparency of textbook outcome analysis in intrahepatic cholangiocarcinoma surgery. And the last but quite complex slide where I'll try to explain another useful way to use the concept of negative predictors is certainly that different negative predictors should have uneven or different contribution to the textbook outcome achievement. It can be described by so-called textbook outcome coefficient, which means ratio of negative predictor frequency in patients who achieve textbook outcome and in patients who did not achieve textbook outcome. The textbook outcome coefficient demonstrates the likelihood of achieving textbook outcome when the predictor is present, and the different negative predictors should have different or various textbook outcome coefficient reflected their different impact on on the risk of textbook outcome failure. For example, if we take the strongest one, a negative predictor in our series, it was size of the tumor more than 10 centimeters, and calculate the textbook outcome coefficient, the value of it will be lowest. If we take another one, the weakest negative predictor, and calculate the textbook outcome coefficient, it will be the highest. So there is a reverse relationship between the value of textbook outcome and the chances to achieve textbook outcome. In other words, the less the coefficient value is, the less likely it is to achieve textbook outcome. That is why we have a new tool for estimation the strength of negative influence of negative predictors, and we can choose the most reliable, most valuable predictors for analyze, because as it was shown in previous papers, you can find more than 50, even 20 negative patients, and you should not perform 20 or 15 subgroup analysis. You should do only 1, 2, maybe 3 at maximum. In conclusion, I dare to say that textbook outcome achievement in ICC surgery varies widely from 10 to 60%, and there is no any widely adapted model for this. But nowadays there is a clear tendency to limit the number of estimated outcome included in the structure of textbook outcome model. And this estimated outcome usually have the close meaning, because if you use some very special, for example, for biliary surgery, it should be like not completeness of lymph node harvesting. If you use this very special estimated outcomes, the rate of textbook outcome achievement drops down dramatically. That is why you should use very similar textbook outcome models. Independent predictors help you to increase the transparency of textbook outcome estimation using subgroup analysis, and you have very useful tool like it is Butalcam coefficient, which help you to choose which the negative predictor is much more strong and useful for your study when you compare it to experiences, centers, surgeons, departments, and so on. Thank you for your kind attention.
Okay, do we have any questions from the audience? Please go ahead.
Congratulations, very nice study. I just have a question. I think I noticed that the rate of R1 resections was about 40% in your cohort. So was that mainly like R1 vascular or in the patients with the combined liver and bile duct or parenchymal? It looks like a rather a high rate of R1.
Okay, thank you. It's a very nice question. Honestly, I don't remember what was the exactly rate of R1, but our concept maybe we consider that a patient should have a chance for surgery. So many of our patients had so-called R1 vascularization, so locally advanced, located in the hepatic caval confluence. When you detach the tumor, there is no invasion, and maybe it should not be contraindication for surgery. What was surprising, majority of these patients were treated by not a major hepatectomy, but parenchyma sparing with bile duct resection. Of course, the surgical outcomes was a little bit worse in this subgroup, but the overall survival also, but without significant differences. The overall survival, there is no data in this presentation. In our series, is 48% overall survival. This is free survival at 5 years, and median survival is 58 months. So it's a little bit normal for R1 resection. That is why our policy is not refuse patients from the chance to have a surgery if you suspect the R1 resection.
Thank you. Are there any other questions from the audience? Thank you for your talk and discussion. Now we have around 20 minutes of break, then we will continue with our next session. Thank you.
Your hospitality in your beautiful country. Dear colleagues and dear friends, after this very sophisticated surgery items, we will proceed with the less sophisticated but very important item. It is the management of the biliary tract injuries. This simple operation have a very sophisticated complication. So, is this kind of injury surgical disaster or it is a manageable complication? We will hear from the Osman Absagoglu from Turkey.
Thank you very much for this kind introduction. Dear friends, dear colleagues, in the next 15 minutes, I will talk on bile duct injuries. Dear friends, dear colleagues, in the next 15 minutes, I will talk on iatrogenic bile duct injury. Is this a complication or a disaster? This is my disclosure, and a quick answer to the question in my topic. The answer is yes and no. Iatrogenic bile duct injury is both a surgical disaster and a manageable complication. And in addition to that, I have to say that first approach should be prevention of the bile duct injury rather than management of complications. Fortunately, there are very well-known risk factors for biliary injury. Some of them are patient demographic related, like old age, male gender, and acute cholecystitis, previous bile duct intervention. And in addition to that, some comorbidities and patient-associated diseases like cirrhosis or prior upper abdominal surgery, obesity, and others. If we know that our patient has these risk factors, we may be better prepared for the surgery. And meticulous preoperative evaluation is critical in these patients who are at risk. On behalf of our center at Hacettepe University, we analyzed more than 1,300 patients, and we analyzed variables that may result in difficult cholecystectomy and conversion to open surgery. In our series, which included more than 1,300 patients, the conversion rate was found to be 7.7. It's close to the average number in the literature. And then we analyzed these variables. You see some of these variables, and we found that patients older than 60, male patients, patients with previous cholecystectomy treatment, patients with prior abdominal surgery, and patients with elevated alkaline phosphatase levels are at risk for conversion for open cholecystectomy. Now, I would like to emphasize that preoperatively, we can have some idea about difficult cases. What about at surgery? Similar to that, during surgery, there are some clues for difficult cholecystectomy at laparoscopy. What are these clues? For example, confusing anatomy. We are not sure where the cystic duct is, where the bile duct is. Lack of progression with dissection. Maybe we can say that about 20 minutes you are dissecting, but no progression. Unexplained bleeding, bile leakage, and finally, the need for an excessive number of clips are clues for difficult cholecystectomy at laparoscopy. So what should be done? I suggest to call a colleague for help. Intraoperative consultation may be life-saving in these difficult cases. Sometimes, especially young surgeons, may think that conversion to open cholecystectomy is a defeat, but actually it is not. Is it helpful, conversion to open surgery from laparoscopic surgery? Sometimes it is helpful, especially in case of severe bleeding for better exposure. On the other hand, in many cases with severe inflammation, open surgery may not help. In these cases, please consider stopping the operation or performing subtotal cholecystectomy. On behalf of Turkish HBB Surgery Association, a few years ago, we published a consensus statement regarding the prevention and acute management of biliary injuries during laparoscopy. In this study, 7 expert surgeons and endoscopists were involved, and we identified some risk factors and management strategies for the treatment and prevention of bile duct injuries. I will not go in detail on this consensus report, but I would like to focus on certain points of this consensus statement. What needs to be done if critical view of safety cannot be achieved? We are doing laparoscopic cholecystectomy, but for some reason, we cannot achieve the critical view of safety. If anatomy is clear, but inflammation is severe, as an example, acute cholecystitis, we suggest subtotal cholecystectomy in the first hand. The second option is open cholecystectomy. The second scenario is anatomy complicated, like prior abdominal surgery or dense adhesions. In this case, open cholecystectomy should be the treatment of choice. Here, I would like to emphasize the importance of experience. This decision mainly depends on the experience of the surgeon and experience of the center. Intraoperative cholangiography is also a debatable issue. We don't recommend routine intraoperative cholangiography, but in some cases, it may be extremely helpful. This is a cholangiography, intraoperative cholangiography of one of our patients. During surgery, we see a small bile leak through the gallbladder wall. And we introduced a cholangiography catheter, which is shown as a white arrow, and performed a cholangiography. You can see a tiny leak, which is shown with a yellow arrow. Here we notice that the main structure of biliary tree was observed. So we repaired this leak. And after surgery, and also we placed a T-tube. After surgery, we have obtained a T-tube cholangiogram. The patient was fine. There is still some leak, but she recovered very well. Please note that the T-tube was inadvertently placed in right hepatic duct. The anatomy was shows some anomalies. We thought that we are placing the T-tube in common bile duct, but it was in the right hepatic duct. So intraoperative cholangiography may be helpful if anatomy is not clear and if you are trying to repair any kind of biliary injury. What's the danger in the occurrence of bile duct injuries? First, risk factors. It's clear. Then complex anatomy. But maybe more important than that is overconfidence. Here, I would like to share a video with you. This is a courtesy of my dear friend Ahmet Balık. This patient was referred to Professor Balık from another country hospital. This is a typical sign of overconfidence during laparoscopic cholecystectomy. Now, surgeon is encircling an anatomic structure. He thinks that this is cystic duct, and now he encircled that. Please note that a lot of blood around, inflammation. I think this is a case of severe acute cholecystitis. Now surgeon clips this duct, thinking that this is cystic duct. And now he is proceeding with an energy device, which we do not recommend to be used during laparoscopic cholecystectomy. Now he encounters another bile duct. This is a typical occurrence of bile duct injuries. Common bile duct was transected. This was a difficult case because of severe inflammation. On the other hand, some easy cases may be difficult. Here now I would like to share one of my patients. This is a straightforward case. This looks like a cystic duct. Now we are about to encircle it. If we push the sector some more, we could encircle the cystic duct. But when you achieve the critical view of safety, actually this is choledochus. The patient has very small cystic duct directly opening to common bile duct. In these cases, overconfidence may be also very dangerous. Without achieving the critical view of safety, transecting or clipping anatomical structures may result in disaster. What about the late complications of bile duct injuries? Management of late anastomotic stricture. Here, I want to share one of our patients with you. She was a 43-year-old female. She had undergone laparoscopic cholecystectomy 7 years ago, and bile duct injury was diagnosed at the time of surgery. And at the index case, Roux-en-Y hepatic angiogenestomy was performed. She was fine for the first 3 years. Then she developed cholangitis episodes. And 7 years after the index case, she was admitted to our center with jaundice fever and abdominal pain. After routine workup and routine imaging studies, we obtained percutaneous transhepatic cholangiography. Here you can see that two bile ducts, right and left, are not joining. This is Strasberg E4 injury. Common hepatic duct could not be visualized. And after treatment of infection and stabilization of the patient, we took this patient to surgery. Now you can see the operative field. Please look at the liver, signs of chronic liver disease because of secondary biliary obstruction, and 2 biliary orifices. In this patient, we dissected till we reached the healthy bile ducts, and we performed new hepaticojejunostomy. In this case, we were lucky, and this is the cholangiogram on day 7. Nice anastomosis, no leak. She did fine for many years, but I don't know what happened after several years. She lost follow-up. And the last question that I would like to discuss is bile duct injury a complication or malpractice? I think this is a very important question because malpractice is a common problem recently in the last few years, at least in my country. Bile duct injury is almost always a complication, but under certain circumstances, it may be regarded as malpractice. What are these conditions? First one is inappropriate indication. We should have a clear indication. The second one is documentation. If there is no informed consent or if there are defects in hospital care documentation, again, this may be a subject of malpractice. Negligence of symptoms suggesting biliary injury. If your patient develops fever or jaundice after surgery and you don't investigate this patient, this may be a subject for malpractice. And finally, delay in referral despite insufficient experience and insufficient resources. In summary, biliary injury is complication. But if you don't manage this patient appropriately, then there is a risk of malpractice. Dear friends, dear colleagues, I would like to conclude my talk. Detailed and meticulous preoperative evaluation in all cases of laparoscopic cholecystectomy is critical. I don't agree with the chair. This is not a simple surgery. It is a demanding surgery under certain circumstances. Please avoid complex cases when appropriate experience is not available. You don't need to operate on every cases. You can refer these patients to experienced centers. Invite a colleague if you have a difficult case. This may be consultation, may be life-saving. Adjust surgical technique in the setting of non-routine cases. And finally, iatrogenic bile duct injury is usually a preventable complication. Kata rahmat.
Thank you, Professor, very much for your very nice, comprehensive exposure. I'm not a fan of the partial cholecystectomy, and I will ask you, I don't have any experience with it, so I will ask you, can you tell me what is your experience with partial or subtotal cholecystectomy? Do you have bile leakage or some another problem?
Yeah.
Thank you.
Thank you very much. This is an important question. If you don't do partial or subtotal cholecystectomy, it seems like a scary surgery. Fortunately, it's not, because if you do partial or subtotal cholecystectomy, in the majority of these patients, cystic duct has already been obliterated. And the risk of bile leak is minor. Despite this, in some patients, they experienced bile leak after subtotal cholecystectomy, but this can be easily managed with ERCP. I don't remember a single patient who required stenting after subtotal cholecystectomy. Majority does very well. Subtotal cholecystectomy is also a useful tool in some kinds of Miritzi syndromes. In this Miritzi syndrome, it may be very dangerous in certain cases to come close to bile ducts. In summary, I can say that it's safe. It's safe.
Thank you very much.
Thank you.
Is there another question from the chairmen or from the audience? Please.
Yeah.
В моей памяти очень много дефектных холецистектомий. Это когда
после так называемой субтотальной холецистектомии опозрунение происходит и образуется конкремент, рецидив. И эти пациенты подлежат повторной операции. Поэтому, если тяжелый случай, чем субтотальной лапароскопическая холецистектомия, как вы думаете, лучше ли открытой холецистектомию сделать, правильную? Ваше мнение?
Thank you. If you understand the question, I will please you to answer it. If you didn't, maybe some other comment.
I need some translation.
Demek bizim sual belə oldu ki, əgər laparoskopik başlamışsınızsa, bunu subtotal holistektomiya ilə sonlanmaqdansa, bunu açıq üsula, open holistektomi, açıq üsula keçib və onu total holistektomiya etmək daha düzgün olarmı? Çünki subtotal holistektomiyadan sonra yeni daşlar əmələ gələ bilir.
Okay, thank you for translation. The question is, instead of doing subtotal cholecystectomy, why don't we open the case, conversion to open surgery, and do total cholecystectomy to prevent future stone formation? That's the question. My answer is, it depends on your experience. I am in favor of subtotal cholecystectomy if there is severe inflammation, not for all the cases. If there is a severe inflammation of the callo triangle, if you convert to open surgery, still you have big problem. And conversion may not help to do safe, complete cholecystectomy. But again, if you think that if you convert to open surgery and you can finish the surgery safely, that's an excellent option. But if you think that despite conversion to open, you'll still have problems with dissection of the callo triangle and possible injury to major veins, arteries, and bile ducts, then subtotal cholecystectomy may be safer, less invasive, and may improve the quality of life of the patient. Subtotal cholecystectomy means removing the majority of gallbladder without touching the callo triangle and taking all the stones and bile in the gallbladder out and closing the stump. Sometimes you may not need to close and placing a drain in. So it depends your experience. There is no single strong recommendation on this topic. You can do the translation.
Спасибо. И позвольте еще раз вопрос задать. В последнее время очень модно становится операция холецистолитотомия. Ваше мнение по этому поводу? Хотел бы услышать ваше мнение. Холецистолитотомия. Хотя я противник этой операции.
Profesör sual verir ki, son vaxtlar holesistolitotamiya bu əməliyyatlar bir qədər geniş istifadə olmağa başlayıb. Təbii ki, bu xəstələrin yaşına, yanaşı xəstəliklərinə, ağırlaşmalarına bağlı. Sizin bu barədə fikriniz?
This surgery doesn't mean to taking the stones out. This is not the definition of subtotal cholecystectomy. At subtotal cholecystectomy, you are taking the stones out, to taking the bile out, to removing all the stones in. So it's not just removing the stones. It's more than that.
Если можете переводить. Его мнение просто хотел услышать. Да или нет?
Thank you very much, but we need to proceed with another question. Professor Khan, please.
Thank you. As we all know, laparoscopic cholecystectomy is one of the most frequently performed surgeries across the world. And patients mostly undergo surgery only with ultrasound, hepatobiliary ultrasound imaging. That's all. Do we have any exact criteria in which we need to take a MRCP or together liver angiography, hepatic arterial angiography, so that later on, if we have any complication after laparoscopy or during laparoscopic cholecystectomy, less than required imaging is regarded as a malpractice.
Thank you, Fatih. This is an important question and it's not easy to answer. I don't think that there is a standard algorithm in this subject, but I can tell you what I do in my practice. If the patient is a typical patient for cholecystolithiasis and without additional comorbidities, I rely on sonography. That's okay. 40-year-old female with right upper quadrant pain with normal liver enzymes, no clinic, I think it's okay. But under certain circumstances, if the clinic is not typical for cholecystolithiasis, 70-year-old man with weight loss and right upper quadrant continuous pain. In these patients, I always ask for a CT scan because there is a risk of cancer in these patients. A patient with a typical cholecystolithiasis but elevated liver function tests and don't decline during the short follow-up, I ask for MRCP in this group of patients. In patients who have previous biliary interventions before taking the surgery, I always want to see the biliary tree in some kind of tests. Regarding angiography, I never asked for angiography. And Fatih, to be honest, another danger is to skip the diagnosis of some other diseases. In my university, we have a series of, I can't call the exact number, but around 10 patients who were taken to surgery for cholelithiasis. Then we found gastric cancer. We found pancreatic cancer because inappropriate imaging studies. So you are right. If we have a high level of suspicion, we shouldn't take these patients to surgery based only on sonography. Here, clinical judgment is critical, I think.
A quick add. 1 centimeter thick gallbladder wall and Mirza-like clinical situation.
MRCP.
And we don't know if patient, for example, has a replaced right hepatic artery coming from somewhere else. So do we need to add CT angiography?
In particular cases, it may be helpful. I agree with you. In particular cases, it may be helpful. Maybe you have such an experience in the past. So, we learn from our complications, our nightmare surgeries. So I agree with you.
Actually, in my practice, what I perform is just to take a good CAT scan with hepatic artery angiography.
Okay.
If patient has a severe acute cholecystitis. Thank you.
Thank you for your contribution.
Thank you. And the last question from the audience.
Değerli meslektaşım, teşekkür edirəm çıxışınıza görə. Məni sizin praktikanızda olan bir məsələ maraqlandırır. Xəstədə sağ və sol axarlar, yəni pay axarları ayrılıqda kəsilibdir. Bu zaman bir hepatika yeğnostomiyanı necə icra edirsiniz? Bu birinci sualımdır. Bir də hansısa bir əməliyyat zamanı əgər
Ona cevap vereyim ben önce. Önce ona cevap vereyim. My memory is not good enough to remember 2 questions in a row, so let me answer your first question. The question is, if right and hepatic ducts are cut at the same time, what should we do at the time of surgery? If you are in an experience center, I think the best approach is hepaticojejunostomy. But if you are working in a small hospital and you don't have much experience You don't have a team, radiologist, intervention radiologist, gastroenterologist, and you don't have a backup. In these cases, I would suggest to place drains and refer the patient to a referral center. Do not try to repair if you are not in an experienced center. That's critical, in my opinion.
Thank you very much. We are way over the time, so we need to proceed. Professor, thank you very much for the presentation and for the discussion, and we will continue with the HPP cases, bile duct injury, Isley human, Turkey. Thank you.
Hello. So we'll present you bile duct injuries with Professor Gonca Eldem. I'll be presenting the surgery side and we'll consult her during the radiology cases. We have 3 cases, 2 from 9 Eylül University İzmir and 1 from Bakırköy Hospital, Istanbul. So Professor Aposol had a great talk summarizing everything. I have a couple of slides to sum up the topic. As we know, 1882 was the first cholecystectomy date, and 9 years after that was the first repair date. So I wanted to mention that with the invention of the surgery, the repair surgery also started. And now modern bile duct injury incidence is less than 0.3%, around 0.3 to 0.7%. And this is an anatomy of error. Usually, a surgeon has a misperception and encounters a common bile duct and misunderstands it with the cystic duct. So we start with our first case. The first case is a 66-year-old male. This patient is undergoing laparoscopic cholecystectomy, and the surgery is uneventful according to the surgeon. At the postoperative second day, there is bile leak in the drain. What would you do? At that point, you are the surgeon who operated and you see bile in the drain on the second day. What would you do? To answer this question, please scan this code and vote. You can do multiple votings as well. Professor Gonca, you can go to yours.
Can we open up my screen, please? Thank you. Yeah.
Not stop yet. Yes. Once everybody votes, we can show the answers. Last one is not visible. It says refer to another center. Couple more seconds for everyone to finish. Türkçe özetleyeyim hocam istiyorsanız. Birincisi ERCP ile stentleme. İkincisi antibiyotik başlayıp 3 gün ondan sonra gelen diren miktarına göre takip ederim. Üçüncüsü reoperasyonu alırım. Sonuçlandı mı?
No, I haven't. I'm just looking.
Okay.
Just speaking.
Dördüncüsü bir uzmana konsültasyon yaparım ameliyat esnasında. Sonuncusu da bir merkeze refer ederim. Yollarım, sevk ederim. I think we can finish.
You're the boss.
Yeah, you can finish the poll. Thank you.
Okay, in 3, 2, 1, done. Let's see the results.
Okay, so 60% answered that I would consult with a specialist for a second opinion during surgery if available, which is a great answer, which should be probably the first thing to do during surgery, to consult a senior or a colleague during surgery, and if not, continue with referral or other options. So what did our surgeon do in this case? The surgeon in the primary center reoperates on the second day by himself, and he says, I sutured everywhere where bile was coming, and I used silk sutures. So anywhere there was bile leakage, he closed it with silk ties. And the next day, there is complete bile fluid in the drain again. At that point, the surgeon refers the patient to a tertiary center for the reason of ERCP and stenting. The surgeon tells the patient, you only need ERCP and a stenting, and everything will be okay. So that's the reason of referral for a tertiary center. The tertiary center does some imaging, and then we will see how it goes. Professor Gonca.
Can I have my screen back? Thank you. Okay, the given images for me and some we couldn't open. We have 3 CT images. The first 2 you see on the upper corner. I won't be mentioning them, but for your anatomic evaluation, this is a CT angiogram. Oh, I need my mic. This is a coronal MPR image. Okay, this is the reformatted image that we do from raw images. You see the arterial phase. The first thing we look at it is the arterial patency. So here's the celiac, the origin, and we have a normal anatomy actually. The hepatic artery, the common hepatic artery is right from celiac, and then here we can see the left. Can you trace my arrow? Yeah. Let me just enlarge that for you. And then this is the GDA. We have an aberrant right hepatic here, right here, which I cannot see the patency instead. But when I see this is normally a 3-phase imaging. I always confirm with the portal phase that whether everything is intact, okay? So think of it as the blood is flowing, the blood is coming, arriving, and then we have the portal phase and then venous phase. Normally in our institution, we do CT angio. This is not a CT angio, this is a liver triphasic imaging, okay? I'm not going to mention more about this because we have a better image here. In 2 weeks, they do it again, probably. This is the axial. This is the real CT arteriography. This is the matter where timing of when you image the patient. Okay, CT angio means 7 to 10 seconds, but liver imaging means 25 to 30 seconds. Okay, it's the arterial phase of a liver is different than arterial phase of a native vessel. So this differs. This is the arterial axial images. Again, here is the celiac, the common hepatic. You can see the multiple clips that Veysel told, like he clipped everywhere. Here we have a little abscess here, inoculation, let's say. Here I can follow both the hepatic arteries. I'm just going to direct the check with the portal phase. Here's the main portal. And in the portal phase, I can see the parenchymal enhancement of the liver is the same. Okay, this is an indirect clue for you guys if you're not used to it. But here we can directly observe that the intrahepatic bile vessels are enlarged here. Okay, and I continue them. They have air in it. And here is my clip. Probably this we don't have the MRCP images didn't work. Probably this is a injury in the bile duct, in the main bile duct, in right main bile duct.
Thank you.
According to radiology.
So following these comments from the radiology, what would you do? Is there anything that you would recommend? Anybody, any recommendations? Maybe ERCP has been recommended. So the tertiary center re-operates the patient. They try to do a reconstruction. So this is what they see when they open the patient. There's bile staining and there's bile collection with a drain. This is the image they see. This is a video. So they notice there are silk ties, and these silk ties are all along the biliary duct. The one that's been removed is the distal duct. As we proceed further in the hilum, there are ties of the proximal bile duct as well. So wherever there was bile leakage, it was sutured and closed. And the hemlock clips that you see below, those are also closing common bile duct. Those are also removed. So I move on with the next video because I cannot speed this up. It's a little bit long. After we remove the long, big clips, after we remove the hemlock clips, we see that this is the distal common bile duct and it continues with duodenum. So it is, in fact, the common bile duct. Common bile duct has been completely torn from both the proximal and the distal end. We check with the stylus if the duct continues to the left side, and we see that it does continue with the left side. We check the right bile duct structure. Okay, at this point, what would you do? Would you do anything else? Do you have any recommendations? Right now, the problem is identified, and now we can move with the reconstruction phase. But is there anything, any recommendation that you would think of before we move on with hepaticojejunostomy? So, great suggestion by Professor Aposolu. So the team suspects that the right duct might not be continuing in an intact fashion. So they do intraoperative cholangiography. In this cholangio, we notice that the left duct is completely open. Right anterior duct is also open, but the right posterior duct is missing. Am I correct, Professor Gonca?
Yeah, orientation in intraoperative images is not as easy for us as you guys. But regarding you can see the I think it's the Portigue or the Penset. That's the colodoc, and continuing with the left. And there you can see, maybe you can move your arrow because I don't have it. There's a string-like structure there, continuing with the right. But the middle end is missing as a string-like structure there, yeah, and the upper part, yeah.
So
and I think they will find it, yeah.
So they, after cholangio, they investigate the area again, and they find that the posterior duct has been also sutured and closed, and now you can see both the right anterior and posterior ducts are cannulated, and now it's opened again. So before moving on with reconstruction and bringing the jejunum for hepaticojejunostomy, especially in these complex cases, performing an intraoperative cholangio can be very important. Otherwise, closing of the posterior duct would cause even more problems post-operatively. And this one, Professor Gonca, after.
Yeah, this is after the repair, I think. That the in the upper corner you see the ecarter, the surgical ecarter, and the one. Just remember the previous image. There was a string-like structure, and they are now all continuous, draining into the main bile duct, and in the inferior part you can see the duodenum.
And this is the final one.
Yeah. The main duct is patent, and the flow is going right at the duodenum. So I think intraoperatively, you guys just give the contrast and flow it, and just image the flow. So everything should be going smoothly into the duodenum. Then you're good to go. But an MRCP would be great with this case.
True. So this is the final preparation of the bile duct. This is the common bile ducts. All the sutures has been passed, and And here is the site where anastomosis will be performed. So what lessons do we get from this case? There are a couple don't and couple do lessons. The first don't is probably reoperating alone after injury. Second one is suturing the bile ducts and especially using silk ties, which are more inflammatory and harder to find, and late referral to an expert center. What should be done would be checking the vascular imaging as well, and intraoperative cholangiography control during the reconstruction phase is also as important. Any comments for this case, Professor Sarbialı?
I think that in this patient, there was a vascular injury at the posterior site. I think. Is that right?
A vascular injury?
Arterial injury, posterior side. It wasn't the case?
No.
So
Can you bring me back my screen?
On the CT angio, we don't see it.
Yeah, okay, here's the axial arterial face. Here you go. This is the main, common hepatic artery, then the GDA and the proper. Then
posterior branch is there or is missing?
It's actually there. It's tiny, but it's there. But it's tiny.
Okay. When
It's
it's there,
tiny.
it's
It's
okay.
small in caliber.
Okay. In this patient, maybe there is also not so bad to control intraoperatively with Doppler ultrasound. This is my suggestion. If you see arterial sonography, that's okay. But if it's not, there's also an option to make a posterior resection. Thank you.
Thank you. So intraoperative Doppler ultrasound to check the vascular structures as well. Thank you for the contribution. Professor?
During after bile duct injury, all guidelines recommend permanent hepatocogenostomy 2 months after the first operation, so that the severe inflammation subsides there. So here the permanent hepatocogenostomy has been performed, I think 18 days after the first operation. So I believe surgeons here are lucky because 18 days, 20 days, 25, this period is, where we have a severe inflammation there because of bile leakage there. So I believe in many cases, 2 months interval is a better option.
Thank you. Thank you for the contribution. I think in this case...
Sorry, if I can give one comment. I don't expect, or I don't know why after 2 months of the bile duct leak, you will have less inflammation than at the time of the operation or just after the injury. So I think that the good solution as soon as possible is the best for the patient. Thank you.
Professor Can, would you like to?
All guidelines recommend early repair or late repair, not in between. In a few days after injury is okay. But if it's too late, then guidelines strongly recommend waiting 6 to 8 weeks.
Thank
That's
you.
why.
I think I'd like to add that in this particular case, they had to identify the problem, so they had to do exploratory laparotomy because all bile duct and structures were tight. So during the exploration, they followed up with the reconstruction as well.
Yeah, of course, with a very good biliary drainage, of course.
Yeah. Professor Sarbialı?
I do not agree with Fatih. Unfortunately, I didn't read these guidelines, but the timing of the repair, it must be individually taken. And if the patient is not septic, as soon as possible. In the clinic which I'm working right now, we are repairing if the patient is stable and is not septic. Otherwise, these time frames, they are really changeable. Sometimes you have to wait 2 months, 3 months, but you cannot suggest something like that. yeah, to my opinion, in my experience,
Right.
you can make this reconstruction as soon as possible if the patient is fit for the surgery and not so septic. So this is also which guidelines I do not know, but I didn't read these guidelines. But
Thank you. We have a case similar to this topic. It will be our third case. Professor
Sorry, we
Kerem.
have one more
Yeah,
question.
yesterday the Professor Joker given very good presentation about the timing of early or versus delay repair, the bile duct injury. Maybe he can say something about this. I agree with Kaya. Depends on patient status, sepsis. We can do early or late. We have to make decision the patient's status and individual statement.
Of course, in septic patients, we cannot wait. All these guidelines recommend in patients with stabilization. After stabilization, if you can wait, please wait. If you cannot wait because of severe sepsis, of course, you should proceed.
Thank you for forwarding your question to me. Actually, you answered my question. The golden standard is the clinical situation of the patient. If the patient is stable, you don't have to wait for a long time. And I gave my talk regarding the long-term and consequences of delayed and early repair of bile duct injuries. This is an injury, but we are not discussing here the long-term results of this, the early time and early period of injury and the effects of early period of injuries. And that's why we have to go to surgery as soon as possible because there is a sepsis, as you have emphasized before. And that's why we don't have to wait for it. Thank you.
Thank you. If there are no more contributions.
Very much for a presentation of this complex item and complex cases. If there is no question from the audience or from the
Chairman, we have 3 more cases. So we have 2 more cases.
We are a little bit over the time, but no problem. Continue.
For this session, I think the timeline is 1 hour, 15 minutes.
We have time.
Okay.
So a couple slides to remind. The navigation in modern intraoperative imaging is important. As Professor Abbasol said, it's not mandatory to do intraoperative cholangiography, but in cases that are confusing and complex, it can be a good bailout option. Or if you have the availability, infrared ICG cholangiography can be another option. Recognizing and managing this defect, this injury is very important, and timing of recognition can change how to proceed. If there is delayed, as we discussed, if there is delayed presentation, first you might have to control the septic situation and then go ahead with hepatocogenostomy. As many of you all know, critical view of safety is now mandatory in most Western centers. You need to clear the triangle, callow triangle, expose the hepatic plate, and then following verification of both cystic artery and cystic duct, you can go ahead with clipping and cutting. This is called CVS, and this is usually in most Western centers photographed and added to the pathology patient surgery report. In addition to this, SAGES Society started a COSIC culture of safety in cholecystectomy. It is comprised of anatomical mastery, mandatory CVS exposure, followed by imaging if necessary, and then low threshold to convert, and finally multidisciplinary management. Now I'd like to continue with case 2. Our second case is 67-year-old female. Again, laparoscopic cholecystectomy, but this time during the surgery, the surgeon notices intraoperative bile duct injury. This first surgeon tries to dissect and find structures. He thinks if he can find, he will be able to repair the defect. But meanwhile, while trying to repair, upon dissection, there's extensive bleeding, and he clips and cuts multiple structures, probable vascular injury. What would you do at this point? You are the surgeon. You try to repair the possible biliary injury, and you encounter more bleeding and you try to stop the bleeding. Okay, so at that point, the surgeon transfers the patient in an intubated fashion to a second center. The second center reoperates, and their comment is there's serious injury, visible hepatic artery injury, and hepatic necrosis. This patient can need liver transplantation, so they refer the patient intubated fashion to a tertiary center. And at that tertiary center, they do imaging studies. Professor Gonca?
On the upper hand, you see CT angio images. First of all, this is again the axial arterial phase. The second operators that have operated, I believe they have resected some part of the liver. You can see the clips. I don't see the posterior segment of the liver hereby. This is the arterial phase. Let's check this out with the portal phase, with the venous phase. Yeah, there's some liver parenchymal resection with a neighboring collection right here. Let's go back. Meanwhile, we all obviously notice there is some collection here, the fluid collection. We'll see what that is. Let's go back to the arterial phase. So I'm expecting the celiac around here. It's not there. It's a little bit lower. Probably the whole system is now obstructed by this fluid collection. Here is the celiac, the origin, the common hepatic artery. Now I see the left hepatic artery with some surrounding clips. I would expect my right hepatic artery here, around here somewhere. I still don't see it. I expect a collateralization from another SMA collateral or inferior phrenic. I don't see anything, but let's check with the venous phase how the parenchyma is enhanced. Not that bad looking. The first thing you will notice when then vascular injury is there, the arterial enhancement and the portal venous enhancements are different because of the reperfusion. But still, this can happen. This can be compensated by some collateral flow. Again, going back to the right, the arterial phase, sorry. In the axial images, I don't see a direct right hepatic artery, or let's say the posterior division is resected, an anterior division of hepatic artery. This is my vascular findings. Let's go back for the bile stuff. So many clips here. And directly starting from the hilum extending into the hepatic confluence, I see this fluid collection. So for me, I would recommend to do an MRCP here, because with a possible when we think with the clinical findings, I would expect a common bile duct injury that this is the whole bile leak. So I think they did one, yeah. Here's our MRCP. The images that we have are T2 images, the weighted T2 images, the axial non-fat suppressed images, the coronal SSPR, and I don't have any contrast enhanced images, and I have the reconstructions. So us radiologists, we go by the raw images always. So this is my raw MRCP T2 weighted image. This is where you see steady state fluids, hyper intense cysts. These will shine. This is called the T2 bright effect, and you will see them like shining. So because think of it in the bile ducts, the fluid is steady state. It's not flowing. It doesn't have a continuous flow. We expect to see all the bile ducts in these weighted T2 images. So this is a coronal image. This is the raw image. I will show you the reconstructed ones. So here I see a T2 weighted cystic lesion, or a cystic collection, I would say. This is my first thing, because the patient didn't have any kind of cysts, okay, and the post-op thing. And here you can see there is some main duct here, could be a main duct. There is another bile duct here. And when we reconstruct this image, again, you're visualizing it in the coronal fashion. Here we have the pancreatic head. Here is the duodenum. Here is somewhere around the ampulla. Okay, so something is coming up here, but is not entering in the duodenum. And when I'm moving forward, I see another channel here. So this is the pancreatic duct. I would expect them to combine or open up in the ampulla with the main main bile duct. But what I see instead is this fluid will be continuous with the right residual, I would say, bile duct. Let's check this with some axial images. This is actually normally you don't like these T2 images, but we really like them. You can see all the way around. See, so this is the fluid collection. This is the SMV, the portal vein. So around the hilum, I would expect something going around here and entering in the duodenum. But instead, I see the main pancreatic duct. I wanted to combine with something here. It doesn't. Instead, I have this great fluid collection, and this collection is also combining here in the hilum with the liver parenchyma. So this is suspicious for me, a main bile duct injury with right hepatic artery or some aberrant right hepatic artery vascular injury, I would say. I hope I'm true. I'm correct.
Thank you. So at that point, I think everybody would agree in the tertiary center, the patient undergoes to surgery. This is what is encountered. The hilum is dissected high up. And this is the bile duct. We can see the left portal vein dissected. And below, we will see the right hepatic artery. This is the clipped right hepatic artery. All these areas have been dissected. So when we continue with dissection, it's noticed that this is the distal end of the common bile duct. It's freed. So we can notice that the bile duct is again completely injured and cut off. This is the continuation that Professor Gonca showed us on the imaging. Do you notice anything else at this point, or what would be your options at this point? Did you notice anything else? Would you go ahead with reconstruction? What do you think of this image? Yes, Professor Saibel.
Yeah, I would suggest to remove all the clips. This is my suggestion.
Thank you. Removing all the clips and trying to open up all the biliary structures. But as Professor Gonca mentioned, there is a demarcation line and there's a vascular injury. So this patient has been transferred for transplant, actually. So we notice, especially following the passage of the time during these transfers, because it's been transferred to a secondary center and from there to this tertiary center. During this transfer, the liver is completely unviable. So there is a decision to make with how to proceed with surgery.
I'm sorry, I didn't understand. There was an arterial supply to the left side. Why had the patient's this liver insufficiency or liver necrosis? There wasn't any radiological necrosis or ischemia.
For the right side, the artery was cut.
Okay, but the left side was viable.
Yes, that's why.
What was the ratio of the transplantation?
They didn't. The secondary center thought that there might be a necessity.
This is not.
No.
Okay.
There was no discussion for transplantation in the tertiary center, but the secondary center said This requires
this
a
is just a
center of ECMO.
illusion.
Well, radiologically, it looks like the volume would be enough, but maybe because it's acute. In radiologic imaging, the residual liver volume looks enough, but obviously we need to.
No, I try to understand if it is clinically proven that the patient has liver insufficiency and requires a liver, or just an assumption that the patient may need a liver.
The patient
we do not know that. You have to tell that.
Yes, the patient had elevated liver enzymes, but there was no sign of liver insufficiency.
this-
It was assumption of secondary
It's
sense.
an assumption.
Yes, they thought it would require an expert center who had transplant.
Okay.
So the patient did not undergo transplantation, but the right lobe was removed. Once the right lobe was removed, we could see the biliary ducts of segment 1, 2, and 4. Here, all 3 openings of the biliary ducts have been delineated alongside porta, and now jejunum is brought close for reconstruction. And this is the completed specimen. So again, the lessons of this case would be not to reoperate alone and not to trying to repair the injury, because if it was just a biliary injury with common bile duct injury, the patient would not undergo a right hepatectomy, or this would end up even worse. So that's an important lesson, not to try to fix it, and early referral to an expert center, and especially checking vascular imaging. Our final case is a shorter one. It comprises the discussion we made. There were a couple errors with the files, so we will move it more swiftly. 42-year-old female undergoing laparoscopic cholecystectomy, again uneventful surgery according to the surgeon, but there is nausea, abdominal pain before discharge. So the stay gets extended, the patient stays a little bit longer, and 1 week after they do a control laboratory test and they see rise in bilirubin in the postoperative first week. What would you order at that point? They order ultrasound and MRCP, and later they do, following the MRCP, they do ERCP, and they see that there is a collection which is thought as abscess, and it's drained. So there is not immediate reconstruction. And then they do bilateral percutaneous bile drainage. Now we will see the images.
Can I have my screen?
Can you switch to radiology?
Thank you. So the MRCP images didn't work here. At first, this is the first post-op. I'm assuming that it's the first post-op image. You can see on the upper hand, on the left upper hand, many clips around here, and it's not an arterial phase. It's just a portal phase on your left, and the venous phase, late venous phase on your right. But I'm assuming this is the celiac origin, the common hepatic. I can see the tiny origins of the left, right, going there, and right hepatic arteries look like parents. Afterwards, we don't have the PTCD images again. They didn't work. I don't see any collections here. Some here. Sorry. In the anastomotic, in the operation lounge site. Then we have the images of with the drainage catheters. They inserted a drainage catheter in the operational location, and then we have 2 going out from the left and 1 from the right drainage catheters. Meanwhile, I'm noticing the parenchymal enhancement is changing with the liver. And then lastly, finally, we have an arterial phase. Probably the bilirubin levels didn't lower down, I'm assuming. But again, Just as we have assumed from the first image, there is no arterial injury here. I can see all the right and left hepatic branches of the hepatic arteries. So this probably would be the bile duct injury. And now I'm noticing another, this is the hepatic angiostomy, I think. Let me see with the venous phase. This time we don't have the venous phase, so they are mix and matching the CT images. So this is the thing that we should not really actually do. Either do a proper imaging or just don't. Just open up the patient, maybe it's better. Yeah, no vascular injury, probably bilateral bile duct injury, I'm assuming.
So following
Radiology is inconclusive in this one.
So following these comments that there is no vascular injury and probable bilateral cystic biliary injury, they operate and they perform Roux-en-Y hepatic angiostomy for both left and right ducts, and there are no vascular injuries. And for this patient, they first try to manage the abscess and drain the patient, and then they perform reconstruction. This concludes all our cases. Thank you for listening and participation. I also like to thank Dr. Tufan Egeli and Dr. Alpan Gümüşoğlu for their contributions. Thank you.
Thank you very much for this presentation of these complex problems. Is there any question or any comments from the audience or from the chairman? If there is no any questions, I will take advantage of this position and put some maybe takeaway message. So during the operation, stay close to the gallbladder. I think we all think like that. Do not do partial solving of the problem. Make it as soon as possible and make and resolve the problem. So thank you for the discussion, and we will proceed like there is any problem. Thank you.
Dear colleagues, we are opening to this last session of today. My co-chair is Oktober Tashayev and Tilako Ernest. This session topic is Trans-Caspian, Turkish and Balkan HPB Surgical Association activities. How can we improve? We need to the international cooperation. And first speaker is Professor Nuru Bayramov, International Trans-Caspian HPB Surgical Association.
Çok hürmetli katılımcılar, sayın hocalarım, sabahtan biz ciddi komplikasyonlarla, hastalıklarla, ameliyatlarla konuşuruz. Dedim ki bir de bir öğrencilerimize, rezidentlerimize de bir göz atalım, onlara neler verebilirik diye bir konuyu da onlara təqdim edelim, onlara sunalım. Hem de Mustafa Hoca'nın da söylediği gibi bir Trans-Caspian derneği olarak biz ne yapırıq ve ne yapmağı planlayırıq gelecekte, bu konuya değinmek istiyorum. Bizim Trans-Caspian derneği olarak təxminən 2 yıl bundan önce bir proje başlattık. Bu projenin amacı öğrencilere ve rezidentlere Hepato Pankreato Biliary cerrahi konusunda temel ve kısa praktik bilgiler vermektir. Bir online site hazırladık, eğitim portalı hazırladık. Bu portal bizim üniversitede ilk olarak kaydiyattan geçti. Bir eğitim portalı olarak kayıttan geçip bizim senatoda öğrencilerimiz bunu hazırda kullanmaktadır. Ve bu portalı hazırlayarken biz bir komanda kurduk. Bir işçi grubu diyeriz biz. Bunlar kurduk. Bunlar kimler idi? Ben Türkiye'den Mustafa Hoca, Mustafa Kerem Hoca, Gürcistan'dan bizim Gia Tomadze, Kazakistan'dan Alşan Hoca ve sonra da ise Saken Hoca koşuldu bize. Özbekistan'dan bizim hamımızın çok yaxşı tanıdığımız Oktyabr Hoca ve Kırgızistan'dan ise bizim Ernest Hoca bu işe koşuldu. Prinsipimiz neden ibaretti? Bir ümumi her bir hastalık hakkında bilgiler hazırlanır, məlumatlar hazırlanır. Sonra bunlar diğer dillere tercüme olunur ve onlar sonra birlikte toparlanır ve hemen biz bildiğimiz bu cerrahi surgical platforma adlanan platformaya yerleşir. Burada 9 dilde aynı məlumatlar 9 dilde verilir. Aynı zamanda da 9 fonksiyası var. 9 fonksiyonel komponenti var. Ben bunun bunların biri örneğinde İngiliz dilinde olan varyantını size təqdim etmək istəyirəm. Yuxarıda bunun QR kodu var. QR koddan istenilen kəs bura aça bilər, daxil ola bilər. Tamam. Bu portal açıldıktan sonra burada bir neçə pəncərə var. Bu pəncərələrdən biri məsələn hastalıklardı. Bu dediğimiz bu hastalıklar. Buraya daxil olarkən safra yolları yoktur. Pankreas hastalıkları ve karaciğer hastalıkları hakkında pəncərələr var. Biz əgər bu hazırdır, biliary trakt, pankreas hastalıklarına ise yeni başlamışız. Ben bunlardan birini örnek olarak size göstereceğim. Burada bir de dil seçerken buradan bunu yukarı biraz sonra göstereceğim. Dil biraz yukarıdadır. Yani pankreas hastalıklarına dahil olduk. Pankreas hastalıkları içerisinde hələlik bizim akut pankreatit, kronik pankreatit ve pankreatik adenokarsinoma bilgileri var. Buraya dahil oluruz. Diyelim akut pankreatite dahil olsak ətraflı düyməsini buradan bastıqda belə bir pəncərəmiz açılır. Bu sol tərəfdə bir neçə variant var. Textbook Classic, Textbook Question and Answers, Summary, Rapid Guidelines, Question and Answer vesaire. Bunların hamısını kısa şekilde size göstereceğim. Biz Classic, Textbook Classic. Burada gördüğünüz gibi burada yukarıda yazarlar. Burada bütün bu hastalık hakkında bütün temel bilgiler önce. Bilgiler 3 formada verilir. Her bir topik için, her bir konu için 3 formada verilir. Birincisi kısa şekilde hastalığın diyelim tarifi kısa şekilde. İkincisi bunun slaydı veyahut da resmi anlatılır. Üçüncüsü ise geniş bilgi açıklaması, bunun açıklaması. Bütün her bir konu bu 3 formada təqdim eləyir. Diyelim definition idi, tarifi idi hastalığın. Klasifikasiyada aynı şekilde. Sonra epidemiologiya, etiyologiya, patogeniz, patomorfologiya, klinik seyir veyahut da klinik gediş, komplikasyonlar. Sonra keçirik ise ikinci hissədə ise artık klinik bilgilere geçirik. Burada klinik muayene, laboratuvar muayene, diagnostik görüntülemeler, endoskopik muayene, biyopsiya, patomorfoloji muayene, fonksiyonel muayeneler. Sonra ise diagnostik yaklaşım, diagnostik approach barədə bilgiler verilir. Yani aynı stilde. Diagnozun şüphe, diagnozun konfirmasiyası, dəqiqləşdirilməsi, diferensiyel diagnoz, diagnostik kriteriyalar, necə inkar etmək olar, necə hastalığı bundan ilgili bilgiler, etiyolojisinin belirlenmesi. Sonra ise hastalığın tedavisiyle ilgili bilgiler verilir. Aynı kurallar, aynı sistematik şekilde. Əməliyyata göstərişlər, əməliyyata əks göstərişlər, tədavi yaklaşımı, prognoz, profilaksi, screening, izleme, reabilitasiya, özel gruplarda bunun xüsusiyyətləri, özellikləri və xəstələrə məlumatlar. Bu en sonunda ise bu literatür bilgisi. Bu klasik textbook'un forması. Bundan başka bildiğimiz ikinci derslik sual cevaba bakırıq. Bunun çok üzür istəyirəm. Bu formada bir neçə dildə, bu Azərbaycan dilindədir. Sonra Türk dilində Mustafa Hoca ilə beraber, bu Kazak dilində, buradan dili seçə bilirik. Özbek dilində burada müəlliflər çıxmayıb, bilmirəm niyə. Sonra Rus dilində. İndi keçək, bu klasik dersliğin formasıdır. Keçək textbook question and answers bu formada. Bazı öğrenciler deyirlər ki, ben klasik variantı oxumaq istəmirəm. Mənə qısa sual, cavab istəyirəm. Bunu da nəzərə alaraq dərsliyi bu formasında hazırlanır. Bu sefer artık başlıklar değiştirilir. Sual şeklinde koyulur. Yani aynı şekilde devam edirik. Burada artık şekil falan yoktur. Sonra keçirik özet, summary. Özette neler var? Özette ise o kısa her bir konunun baresinde çok kısa bilgileri bir araya toplayarak bir özet formasına almışız. Bu da öğrencilerin isteğinden yapmışız. Bazıları da deyir ki ben geniş okumak istemiyorum. Bana bir özeti bilsem hocam bana yeter. Bu da onlar içindir. Bu şekilde bu sonra bir de rapid guidelines dediğimiz çok kısa kaydalar. Bunu da bizim daha çok rezidentlerimiz için, genel cerrahi rezidentleri için nəzərdə tutmuşuz ki, bir hastaya yaklaşımda geniş protokol yok, kısa kuralları kısa şekilde bilmek istesinler. Bu formada ise gördüğünüz böyle bir ümumi yaklaşım, klinik yaklaşım, tanı, diagnostik ve tedavi yaklaşımın kısa şekilde bunun resmi, slaydı ve diagnostik ve mualice yaklaşımları bu şekilde kısa formada verilir. Sonra keçirik slaytlara. Slide formasında ne var? Slide'da ise hemen bütün o konularda olan slaytlar bir aradadır ve bu da bizim için diyelim bir leksiya demək üçün və yaxud da öğrencilerin slaytlardan birbaşa bakmaları için bu da bir formadır. Bizim bu saytın en önemli noktalarından biri diferansiyel diagnostikadır. Diferansiyel diagnostikada biz belə bir sistem elə qurulur ki, bu taraftan hastalık otomatik seçilir veya da elinden seçirsen, burada ise ikinci bir hastalığı sen buradan seçebilirsen, buradan istenilen hastalığı seçip karşılaştırabilirsen. Diferansiyel diagnostikada önemli olan bilgiler çerçevesinde diyelim bunun tarifinden tutmuş diğer diagnostik kriteriyalara kadar her birisini istenilen iki hastalığı siz karşılaştırabilirsiniz. Bu da diferansiyel tanı üçün verir. Buna hem her bir hastalığın içinden de gitmək olar, hem de buradan diferansiyel diagnoz pəncərəsindən de birbaşa açılanda gitmək mümkündür. Diferansiyel diagnoz pəncərəsinin birbaşa gedəndə isə hastalığı, istenilen iki hastalığı sen buradan seçerek karşılaştırabilirsin. Teşekkür ederim dikkatiniz için.
Thank you. It was a very nice talk. Is there any question from audience? Congratulations, Professor Bayramov. It is very nice educational platform for all students and all surgery residents. Please register this program. It is free for all students and all assistants. Congratulations again.
Thank you.
Next is presentation, Turkish HPB surgical adaptation. Professor Kayan. Yeah?
Thank you very much, dear Chairman, dear colleagues. It's my great honor to be here in Taşkent to present this lecture presentation. First of all, on behalf of all Turkish members, we do thank our colleagues from Uzbekistan for this warm hospitality. It is very nice congress, and also we have learned a lot, I think. We move on with I would like to talk about our association, Turkish HPB Surgery Association. It's one of the oldest HPB surgery associations in the world. It was founded in 1989 as a local association, and it became in 1998 as a big national society, which is focused only on HPB surgery in Turkey. And the headquarters in Istanbul, and this is one of the oldest photos by the establishment of the society. We do have about almost 1,000 members from Turkey. Not only these official members, we do have also 2 school activities, and we have registered students. Our network is about, you can say, 4,000 people whom we are in close contact in our activities. This is the homepage of our official website. It's a very intense homepage. I can suggest you to visit it. There's also an English version of this website. All the informations, the details of the society you can find there. We have also close contact and close cooperation with international societies. This is the data from last year. As you can see, Turkey is the leading country in terms of the member number in EHPBA by far, about 200, and Trans-Caspian is 200. And in the IHPBA, we have the second place after USA. There's a large community, a large family in Turkey, and also organized family within this field. This is our chance. It's also a very active society. We can categorize our activities in almost 16 different fields. I would like to talk about, not about all of them, but some of them I will give some informations. This is the chart of our committees. We have 9 executive commissions, committees, and 2 other committees like audit committee and advisory board. They are not executive boards. And within these 9 executive commissions or committees, we have 36 different colleagues who are working intensively in cooperation with the executive board. It's very important for us, and they are mostly young colleagues. That's why it will produce energy and the new innovation projects for the society. And among these 16 committees, 5 of them, they are new projects that we have established this year, 2026. And first of all, I would like to start with our national HPB consultation meetings. This is very important, and since 2020, every 2 weeks, we are making an online multidisciplinary boards. We are discussing the cases. We do have 2 large cities. They are organizing these online meetings, Izmir, Ankara, and Istanbul. And all the colleagues from different parts of Turkey are presenting their cases in this board online. the radiologists are examining once again and assessing once again the imaging, and we are discussing as surgeons and gastroenterologists, oncologists, pathologists sometimes, the cases. It's very fruitful in terms of the surgical education, not only the young people, but also the senior members. I learned a lot from these boards. Last week, we have organized the 140th multidisciplinary board online. And Professor Bayramov is also a stable member of this board. We thank once again. It's a great contribution. And this is our boards, and we are right now planning to categorize these boards. We have started this work. I think we will have an index about the cases which we were discussed in the past. The second activity is the regional meetings. Regional meetings, we organize it at least 5 per year, mostly more, in a city in Turkey where the colleagues are performing the major HPB surgery. Not only meetings, sometimes courses, and mostly once per year we do organize an international meeting like Trans-Caspian meeting. And this year we have organized in Konya and in Malatya 2 regional meetings, and until the end of the year we will make in total 6 regional meetings. This is also very important in order to reach all the peripheral cities of Turkey. That's why we do have a really active and very cooperative network, which is always in contact. We are benefiting a lot because of these regional meetings. National Congress is also a long tradition in my association. Last October, November, we have organized the 70th National Congress together with the nurses. The surgical nurses have also a simultaneous meeting with us. It's very important. As you can see, the number of the participants is more than 500. It's a very large meeting. It lasts 4 days, and we do have always international faculty. And it's also one of the major academical activities in Turkey. In 2003, we have organized an European HPB Congress in Istanbul. It was the first Congress also of EHBBA. It was the birth of EHBBA. At this time, it was really a large Congress. And last year in Dublin, together with my dear friend Mustafa Kerem, our past president, we have worked for the candidature of Istanbul, and we have won the 2029 Congress for Istanbul. We are waiting all. You are more than welcome in Istanbul in 3 years, and we are really happy to be able to organize such a huge global Congress in Istanbul. Professor Mustafa Kerem will be the Congress President. Another important activity is the National Registry and Multicenter Studies of Turkish HPB Surgery Association. It's also very important. We had some multicentric studies so far. One of them is about chronic pancreatitis. We do have 2 consensus meeting reports. One of them, Professor Abbasol has also talked about it in his lecture. And we are planning right now very innovative and numerous new multicentric studies, especially with the help of the young colleagues. That's why, in order to facilitate and speed up this process, we established a new secretariat for these registries, and we hired a new secretary who is just focused on this purpose. It's very important. And another important thing is the liver registry or HPB surgery registry. We do have a software as association, and in 2022 we have published surgery and research and science and research committee has established and published the new regulation of this registry. And this year we just speed up the process. The liver registry is ready. We are on the way to launch it very soon. We are waiting for the ethical approval. And you see just on the bottom, this is the first kickoff meeting of the centers who will participate to the test phase of this registry. And we are hoping to start in a month, I think. This liver registry is very important for Turkey. We will accumulate and we will gather all the liver data in a scientific way in this registry. And we are right now on the way to prepare a new pancreas surgery registry. I hope that until the end of the year, we will be able to make a start, but the pancreas registry also. This is the registry side of the activities. The society has a journal also since 5 years. The name is HPB Reader. As you can understand from the Reader, it is just this is a specific journal, a digital one. The editors or the editorial board make a research for 3 months, and at the end of the 3 months, they will select some critical papers, meta-analysis or the consensus papers, and they just put it in this journal as an abstract, and an expert in this field make a comment. It is published regularly 4 times a year since 2021. There's a very big interest. Dr. Gümüşoğlu is the editor of the HPB Radar, and they have started to publish right now also the video comments. And this year, as a new tool, we have just published the Turkish contribution to the HPB literature worldwide with a special almanac issue. Young Academic School was also a very, for us, very important and very exciting activity, academic activity. This is an intensive 8-month program of young academics throughout Turkey. We do an open call with the mate, and we have selected 17 young surgeons. They are young, but not residents. Some of them are associate professors or consultant surgeons. And together with our president of the Science and Research Committee, Professor Abbasoğlu, we have run a special program just for them. So each Saturday we made an online Zoom education. It lasted about 8 months. There was a lot of interesting topics, including also mind mapping, visual note taking. There's everything that current academics need for in his or her works. It lasted 10 months. Each Saturday we made it, and at the end we had 17 graduates. Some of them are here right now as speakers. Also, some of them are organizers of our events. Right now we do have a very, to be honest, a powerhouse for us to make this intense activities of the society. And as a graduate project, they have also these graduates have written a book, a small but very important book. This is the first AI book in Turkey in the medicine, AI apps for the academy. We published it. And we do have also 2 important virtual schools. After the pandemic Professor Kerem had an innovative idea to launch a new virtual school for the young colleagues because in the pandemic era, the education, the surgical of the education of the young colleagues was disturbed. And this was the idea, and we discussed with Mustafa about it. Our thought was maybe we have 100 or 200 students. They are all registered students. We have all the data of the students. This is not an open school. They are all registered students. And we thought that it can be maybe 100, 200. And right now, after almost 5 years, we do have almost 2,000 students. They had 2 times exams, and they were certified also. It was a really big success for us, for the society also. It's a structured curriculum. They have all the topics about liver, pancreas, and bile duct surgery, and some other disciplines. From basics to advanced topics, we do have all, and they are all structured. And they have to fulfill 90%, they have to see and fulfill 90% of the education in total. At the end, we were making Zoom webinars, we were just recording, and then we just edited and put it on the special website of the school. It's an example of, for example, this was the liver anatomy lesson from Professor Astarcıoğlu. And we had also in Turkish school, the school was in Turkish, but we had very renowned surgeons from all over the world. They made also the lessons in English. And we have presented this school in Lyon in the HPBA Congress, and it was awarded with the Best Presentation Award. It was also we were extremely happy to be honored with this award. We had 2 graduation exams, and the top 20 students who were certified but had the best notes, they were invited to our national congresses for free. They were the guest of the society. It is a big motivation for the youngs. After that, you can make a QR code to this registration. It's for free. You don't have to pay anything. If you want to be certified, you have to fulfill the lessons from the experts in this era. In Turkish school, we do have about 70 lectures. And after this success and after this presentation in EHPBA Congress, we had an invitation from the president of the society, Dr. Mark Wesseling, to make it for Europe and Africa. But unfortunately, the European and African society was not ready to make the decision. That's why we have decided with Mustafa to make it for the world on our own. And we launched an international HPB surgical school. This is the international version, and this is in English. We have dedicated to the giants of the HPB surgery who passed away in the last few years. And Emre Bozkurt and Veysel Umman, they are both there in Taşkent. They are serving as coordinators of the school. This school is a little bit bigger than the Turkish one. We do have about 100 lectures, also the same concept. We do have a structured curriculum. And we do have, as you can see, they are all the speakers, you know it. Some of them have textbooks, some of them have chapters, and dear Dejan also had a very nice presentation about advanced pancreatic cancer. And we are running that since June 2025. We just ended with, we are just about to end the pancreas lectures. And you can find there all the basic and advanced topics about this. And very interestingly, we were also talking about Mustafa, but once again, we were not, this was, our estimation was false. And right now we do have 1,300 students. They are all registered students from 94 countries all around the world. But unfortunately, we don't have any student from Uzbekistan. That's why it's my, right now, I will take this opportunity to invite our young or all the surgeons from Uzbekistan to register for this school. The school is, again, we do have also, interestingly, a colleague from Fiji Island also. I checked it, he's real, he's existing, he's an amazing radiologist from all over the world. And we didn't have anyone from Denmark. When Denmark also is almost a complete world map. I think we should we should find someone from Denmark also. You can also, through this QR code, you can be registered to this school. It's totally for free. It will end, and I think until the end of November, we will finish the school. Then we are planning to make an certification afterwards. This is another activity of the society. Another activity is that I have surgery next week. It was the idea of Professor Laurel. We have established an application. The idea was to make the matching of the surgeons, the experienced surgeons who are performing HPP surgery with the relatively young surgeons who just want to watch these operations or to participate to the operations. We had to have a software, a special software. We have coordinators. The observers, they are making applications through the software, and the coordinators are matching with the operators all around Turkey. So far, we did have 67 visits to the operations, and we are trying to speed up also the system. It's very important. It says licensed software from our association. Hafta ameliyatım var means next week I have a surgery. And I think that in order to establish a practical surgical education, is very important to see also live what the surgeons are doing. I think that's why we are trying to improve this system. Trans-Caspian Society, we talk about them. I will not go in details, but after the first, it's our great privilege and happiness to participate to this joint regional association. After the first Congress, right now we are organizing Taşkent Congress. We are extremely happy. We have a large delegation, and for the next, I hope for the near future, we are hoping to participate more and more and then to this very important chapter of EHPBA. HPB update was another exciting innovation this year. It is a series of meetings. Each year we are planning, we have started to do that. Each year we will do a periodical meeting about liver and pancreas, separated, 2 meetings per year. What are we doing? We are doing just update lectures. Update lecture means what did happen in the literature last year. There's a special group of people who are just watching and then make the research of the literature, all the consensus reports, meta-analysis, or the important papers. They are just making together with a speaker, and the speaker presents only this literature, nothing more. This is not a formal lecture. And afterwards, after 20 minutes, all the audience, they are just getting the current literature, and after that, an expert come to the stage and make a comments about it, what these changes mean for our practice, which started that the first one, HPB update in Gazi University in, sorry for that. We started with the liver HPB update at the beginning of the May. We visited also Anıtkabir, Atatürk, our founder of the Republic, with society. It was a very successful. For each subtopic of the liver, there was a literature presentation, and afterwards, comments from the experts. And we published also the HPB update book of liver. This is the summary of the lectures. Right now, each member of the society can make a very quick look at the newest literature of 2025. It's very practical to catch the newest developments in the literature. With the help of Dr. Emre Bozkurt, my dear friend, we started to publish monthly newsletters. You see a lot of activities, and we are just running again and again. It's right. That's why it was really obligatory to publish a newsletter of the society. There's a lot of things to talk about for the members. It's not only in Turkish, it's also simultaneous in English. We do have a mailing list from the international also colleagues and friends who are following the activities of Turkish society. Each month we are publishing a newsletter, and this is my last activity. It's also very exciting for us. The idea of this young team. This is like a U14, U17 football teams, junior teams of the in football industry. We need young and fresh colleagues or people in order to ensure the future of the society. And we also want to support the advanced training of these young doctors or surgical residents or surgical medical students. We try to facilitate in scientific research of them, and also we will try to establish a sense of belonging to our association. It's very important for Turkish HPV Surgery Association, which has a lot to do. Also, the future, we have to guarantee our future. That's why we have made an open announcement, and we received a lot of applications. Our team, this is the committee of the HPV Young team. Çağrı Büyükasap is leading the committee, and they make the very prestigious assessment. And 142 in total members they have selected. They are coming from different parts of Turkey, and for each region we have 29 members, and each region has a responsible doctor and also a mentor. And we are right now launching the new education program of these young doctors, and together with the Science and Research Committee, we will launch new multi-center project. Also, we will introduce those young colleagues to this project. I thank you all for inviting me to talk about the activities of our association, and we are all hoping see you in Istanbul in 2029. Thank you very much.
Thank you, Kaya. Is there any question or comments from audience? You see, we have many educational activities, and we are open to make collaboration from all countries, especially young colleagues. Please join us and visit our page, especially young surgeons and medical students. Our HPV, International HPV Surgery Schools as English, it is very impressive opportunity and HPV platform. Please join us. And for Balkan chapter, especially you can join us to the multidisciplinary team if you want any case. We are open. Every 2 weeks we make multidisciplinary meeting. Please join us. Thank you, Kaya.
Once again, thank you. And as always, we are not always open arm for the young friends, also the international friends, colleagues who want to participate to all these activities. Thank you very much for this.
Саламатсыздарбы, урматтуу коллегалар. Азыркы сөз Европалык Hepato Pankreato Biliary хирургия бирикмесинин Батыш-Чыгыш Балкан бөлүмүнүн жетекчиси профессор Деян Реданковичте, Сербия.
Hello, good afternoon, everybody. It's my third time today, so but I have to express really my feeling that I feel very, very warmly welcome here. So thank you, Professor, for your warm hospitality and invitation here in Balkan, in Uzbekistan. I didn't comment the Kaya's talk before because I have the floor now. So I think that all of us here in this hall can be very proud on this, what our friends from Turkey achieved in their Hepatobiliary Pancreatic Association. And I know the Kaya, I know the Professor Kerem, all of them for a long time, but when they summarize everything, what they have done, it can be only congratulated, and it really privilege, I think, for all of us to join this very nice activity, let's say, and very nice spreading of the soul of the HPB, not only for the showing the Turkish HPB, also to involve the young people, to offer your help, to offer introduction of all these countries, but also the very renovated international speakers. And I was really surprised when I saw myself among the all other very important and giants of the HPB, Gova Kobayashi, Professor Rene Adam, all of these guys, Siri Vardenov, all of them, who is our teachers. I was in accompanying to them. So Mustafa and Kaya, thank you very much for putting me there. It's really great pleasure for me. So, but we have to follow you. Okay, my talk today is how we can improve and in this region, and what's our the Trans-Caspian region is the emergency centers across the Central Asia and Caucasus. Also, Turkish Association, as we saw, is a mature, high-volume surgical community with strong infrastructure, as we saw, and West East Balkan region is diverse national, united by geography, history, and common clinical ambitions. We would like to improve ourselves and to be on the level which we think that we deserve. Why this meeting between these two associations matters? First of all, it's a bridge between two countries, between two regions. Via Bulgaria, we are connected to Trans-Caspians, and we are really geographically connected. So we face the similar problems on different scales in referring, in training, and access outcomes and retention of young specialists. It's very important to know that there is a power of proximity, and that our two regions, beside that, we share the borders, we have similar patient population, clinical realities, and we can to emphasize the geography make us natural partners, and we share the similar problems. We have the similar patients burden. It's histological, it's types, this cultural affinity enabling us that we have the cooperation, and also we are bridge between the Europe, Asia, and Middle East. So we can use all these things together. What is the clinical challenges? We can talk about the complex liver resections, and all of us know that it's have high morbidity, that limited volume of the liver resection, the small sensors, and also we have inconsistent referral pathways. And for pancreas surgery, as I talked today, it's a very dangerous surgery, and we have also the problem with late stage presentation. There is no in entire region, in some part of this region, we don't have all the access to neoadjuvant treatment. For example, in my country, nab-paclitaxel is still not registered for to be covered by the government insurance. And also, we have the survival gaps. If we are honest and if we reported our morbidity and mortality, we will face that in the Western Europe's, the biggest problem is with the failure to rescue. It's not a problem. When I try to explain it by words, I say we have similar, let's say, or good surgical techniques. It's not a problem. All of us can do proper lymphadenectomy, proper resection, and even anastomosis. But when we are coming to rescue the patients with the problems, then because I think that in many centers in this region, as in our region, we don't have 24/7 interventional radiology. We don't have 24/7 interventional endoscopy. And therefore, we have to work to understand that it's not only surgery. Therefore, this is Hepato Biliary Pankreatic associations where we have to work together. The surgeons are famous, as you know, as people who is always at the top of the entire train. And we are the pacemaker, and therefore we have to join our endocrinologist, our radiologist, and our gastroenterologist all together, because your result as surgeon will not be the same if you don't have good team. That's for sure. And also, this is the problem with biliary disease burden. And also, we can have shared for example, echinococosis is very common in Turkey as well as in Serbia. So Serbia has, I think, one of the biggest in the West, on the entire Balkan region, because we have a lot of people from Kosovo, and from this region, also from some parts of Serbia, south of Serbia, which is referred as echinococosis problem. Also, we have problem. The Kaya presented that there is some registries, but we need to have on the entire country the consistent register, and we have to register almost every patient. And it's all of us, we say, yeah, I have my register. Yeah, I have registered in your department and maybe in your hospital, but it's not national-wide register which will cover all patients. And then we will be able, as the people from Dutch pancreatic study group and Dutch pancreas cancer study group, that you can analyze the entire country. And then you can face what is the problem, and then you can share it. And also, I think that we don't have reporting the same standardized reporting standards. What is definitions of complications? We have today very nice talk about the post-pancreatic hemorrhage, about the delayed gastric emptyings, where the people from the colleagues from Turkey represent what is the international study group standards. And we have to follow it. Not in one hospital, hemorrhage means this, delayed gastric emptying means this. There is very strict rules, and we have just to follow it. And if we follow it and put in the register, then we will be able to analyze it and to find how we will better do what is our mistakes. We cannot say, okay, I have done everything what I know, and the patient going wrong. What's happened? We have to analyze our results and to be honest with it, how we can improve our treatment. And also, it's very important to put the outcome benchmarking. We need to know what is, and we will be able to compare the result across the centers and across the nations, and to learn one from each other how we can be the better. So, and we need a common language of outcome, common language of complications, and we need better registers. And how we can improve? What can be the improvement target? We think that better outcome require more than an individual experience. For the better outcome, we need team experience, and we need to join together to share our experience, what are our failures. Not to share what we achieved, rather to share what are our failures, then we can learn from the failures. And then, then we have to focus on, we have to focus on we have to focus on care, on the training, on the data. And if we share all these problems, then we can be better and to improve it. And I think I can say that I put 4 priorities for our chapter cooperation. One is the training. This is common pathways for and faculty exchange. We can share our research with the registries and multi-center studies. We have to compare our quality assessment, how we are doing. As Mustafa pointed, we can do together multidisciplinary team and referral standards. And also, we can share the mentorship and young surgeon community. We have to involve our younger surgeons to be mentored by people from different centers. So maybe they will learn what is wrong, but it's better to see how it's doing somewhere out. And then you will see, yes, my center, my professor, big professor is the best one because I saw how the other is doing bad. But otherwise, if you cannot compare, then you will see that your chief is a god. I think that we have to abandon it and to go to be widely open to young surgeons, that there is a lot of techniques, a lot of standards, and we have to share it with them and to encourage them to go to learn from the others. It's also important maybe to build a regional training pathway, which will be consistent of, as Kaya pointed, of the core curriculum, and then case-based teaching, also faculty exchange with the short observation and visiting faculty also between the centers, and also skill courses, simulation, or, for example, ultrasound ablation, minimally invasive perioperative care. And I think that every chapter meeting, it's very important that in these meetings, every young surgeons, every resident can learn something more, and it will be visible educational ladder for all of them. The priority number 2 is to improve the quality of referral. We need to define, it's important also to define what is the high volume centers, to define minimal criteria for complex liver, pancreas, and biliary procedure, to encourage national or regional pathways with clear referral procedures, to promote checklist for pre-operation also and post-operative rescue, and create non-putative morbidity and mortality learning seasons. It's also very important to start simple, to start with some small projects with where we have the procedure volume, case mix, complications, length of stay, for example, and referral delays. And we have to need the participations, complexness, complications, readmissions, and mortality. It's important to start with some small steps, because then you can build more and more and have more complex registers and more complex database. And we are always emphasizing that it's very, very important to invest in the young HPB surgeons. We have to have the mentorship program. And mentorship program, it means that one mentor will be responsible for one young surgeon, and then we can compare how they are doing. It's important to give to young surgeon possibility to talk on the meetings, to talk on they need to have visibility, and that they feel secure. If they start to feel secure from the young age, then when they'll be in the middle age, they will be more than capable to do the talks and to represent our centers. And also, if it's possible, it will be good to create small travel grants and center visits between our two associations. And it's important that these meetings, of course, this meeting is a place for friendship, a place for social networking, but also to be useful in scientific from passive, and it will be important also to give a possibility to young to attendance and to have active role to exchange their knowledge. It is before to collect questions and cases. Also, we have to encourage young people not to be shaming, to give a talk and to also give a questions. Every question which young people ask me, I think that it's very positive. You can't be wrong, because you are in resident program, you are learning, so you can't be wrong. Who of you is so brave to stand up and ask the questions? It's very good achievement for them. I would like to emphasize also. And also, it's important when we have publications to give to young, even residents, if they are doing the study, to be the first author. They have to be first author, to share first and second authorship, and for us as a senior to be last authors, not to be at the top because they did the job. And also, we can have, as Kaya said, we can have 3 simple channels: monthly case forum, standard faculty list, and we can try to find some project incubator when we'll have to put all idea on a brainstorming platform, and then to say this is important or this is not important rules. And it will be, we are surgeons, we are actually very practical, so we don't need bureaucracy, so we can rotate the moderation. It's important also to have co-leaders in young surgeon. If we give them that opportunity, they will feel that they really matters for this project. And also we need to measure our outputs, and all what we have done have to be measurable. Otherwise, we cannot analyze it. And how we can improve? Okay, we can make some chapter comparison measurable. We need to training, to referral, to measure, and to mentorship program. And for my Mr. Chairman, ladies and gentlemen, for conclusion, I think that proximity is an advantage. We have not yet fully used it. We share geography, share cultural, share a burden, so we can. Next generation is, I think, should be ready, and they are watching and waiting for their opportunity. And nowadays, everything is much quicker than it was before. So we, as a senior, have to understand that. We as a senior have to give opportunity to young generation to be much more and much quicker involved than we were. This is the only way how we can invest in them. And I think that together, Trans-Caspian, Turkish and West East Balkan can set a new standard for regional surgical cooperation, so we could be able to improve outcomes for patients across the entire region. Thank you for your attention.
Thank you, Professor Dejan, for a very nice presentation. Any comment or question from audience? So how can we improve to cooperation, do you have any solid suggestion, all association?
I think that the Turkish Association had a very good platform for all of this, and maybe we can sit together and just to maybe we can have some common registry, for example, common registry between West East Balkan and this region and Turkish about the echinococcosis, because we are very unique in the world, and maybe if we have joint data, it can be good. And also maybe we can establish some cooperation program for the young surgeon, that they can spend 1 or 2, 3 months in some institution and to sharing the young surgeon to see how it's experienced in this, and to rotate between the countries. We can establish mentorship program. We can put 10 mentors and then mentees who will apply and who will be able to join us. And also, I think it's important to have faculty in change. That means that, Mustafa, you have to come to Belgrade to visit my institution and to see how we are doing surgery.
Thank you so much. Then we can do it. And thank you so much. The session was done, and tomorrow see you. Whole session, it was great. Thank you for participation, especially the young colleagues. Thank you again.